Good morning, good afternoon, good evening. People in the Zoom room, we're going to start in just a minute. We're going to get ready to set up. They're rambunctious this morning. I don't know what happened. We are live. Yeah. We're in. Can I get started? Yeah. Good morning, everyone here in Finestone Hall. Welcome back. Thank you for being here. And hello to everyone on Zoom. Welcome back. Thank you for being here. We're back for the 2025 version of the Global Oral Health Symposium. We have a lovely day planned for you. I just want to go over a little bit of the schedule. Let's see if the slides advance. No, but I can tell you this. We have a fun day. Oh, here we go. So this is what day 2 is going to look like. We're going to have a bit of humanitarian health. I don't get to hear much about humanitarian health in the little narrow field that I go to with conferences. I don't know what conferences you're going to, but I'm very excited about this. Then we're going to jump into this. Yeah, my bad. I changed the title. This is Lessons for the Global North. I know some of you don't like this Global North, Global South business. And resource limited region sounds a little insulting. So yeah, again, that's my fault for that one. So we are going to feature areas that, again, I don't get to hear from. And again, very excited about this panel. We will have another coffee break between coffee and masala chai. And maybe next year we can have matcha, or, if you have other caffeinated uppers that we need to provide that's more globally appropriate. That's happy to hear recommendations. I'd recommend that bulletin board. I haven't seen much action on that. So if you have other chai recipes, or should we be going Turkish coffee next year? Maybe we should be hiring someone to get the sand, and that would be fun. That would be, yeah, let's get Turkish coffee next year. That would be that thick sediment at the end. There's something really satisfying about that with the cardamom and there's sugar in it though. There's a lot of sugar. We have lessons from the Armstrong Institute. This is a Johns Hopkins entity on patient safety and patient quality. And we're fortunate to have 2 Hopkins rock stars with that. We're going to have another lovely lunch. Yesterday's lunch was fantastic. I'm sorry, those of you in the Zoom room, you missed out. Maybe you should come next year. There's no registration cost. You just have to come up with a visa and the expensive flight for wherever you're coming from. And we're going to finalize the day with the health economics combo, a 1-2 punch. And then we're going to go into these small group workshops, and we'll go into a little bit about that. We're going to go into groups. The idea is, those of you who are taking notes or have fantastic memories, we want to have you record memorable quotes, questions that you have, and come up with something other than another boring call to action. We want those actionable steps. And if there's a way to put that into a paper, that would be, I think, very valuable. And then we'll have a speed round again of closing remarks. So that should be interesting. We do have one more surprise guest. And so let's see if the video works.
Hello, my name is Christina Wanyonyi. I'm a research program leader in health service research at this institute at the University of Cambridge. I'm also the president of the Global Oral Health Inequalities Research Network of IDR. I'm delighted that Johns Hopkins is hosting this Global Oral Health Symposium. We know that oral health is integral to general health and our well-being. And in as many spaces with as many voices, this message needs to be conveyed. It feels very befitting that an institution with such an incredible reputation in public health and medicine is hosting this symposium. I wish you an excellent time there. It looks like a cracking schedule of events, and I look forward to opportunities to interact with you in the future. Thank you.
Fantastic, a cracking symposium. That's got to be the first time anyone has said that. Well, maybe not, but okay. So I'd like to introduce our moderator, Dr. Ekpa Eoma, who was fantastic. She attended the very first symposium in 2023, which was my customized practicum for my MPH here at Hopkins. And so, Dr. Eoma, I'm thrilled that you have returned and you're back. It's very local for you, University of Maryland faculty. So, ladies and gentlemen, please welcome Dr. Eoma.
Hello, good morning, everyone. And good morning to everyone on Zoom. So I don't want this conference to end. It's kind of unfortunate. It's day 2 and it's the final. But I really want to say that when I was in my MPH program, just like Dr. Patel was saying, I was the only dentist. So anytime they would talk about non-communicable diseases or anything, my hand will go up and they'll turn to me and they're like, oh, you're the dentist, right? And I was like, that's not the point. I shouldn't have to be the dentist that has to bring up oral health in conversations about health. And I went to another very popular Ivy League school that I won't mention here because I don't know if they're.
You can.
Oh, okay. Can I?
Yeah, please.
Columbia. So there was no class or conversation on oral health. I just kept saying, gosh, I know why I came here, but how come this curriculum isn't as robust as I would have liked it to be? But enough about that. It is my honor to moderate this panel because this is a part of oral health that I'm most passionate about, which is humanitarian health. And I know, depending on what lens you take, this is not, some people might think this is not as sustainable. But when you are going to remote places like I have been, I've been able to go to places in El Salvador and Guatemala and Jamaica and Nigeria. I was in a place in El Salvador where there was only one dentist for about 30,000 people. I mean, these are realities that everyone lives in. I mean, I'm from Nigeria, I was born and raised, and we're 200 million about, give or take. You know, this number keeps going plus or minus 20 million, but there are about 5,000 dentists for the entire country. So how do you address this gap, this need? And this is where humanitarian oral health comes in, is that everyone wants to help. People want to do the best they can. And sometimes showing up is sometimes the answer, but how do you do it ethically? And this brings me to the amazing panelists that I'm going to introduce. The first is Dr. Sarah Raskin, and she's an associate professor of urban and regional planning at VCU. That's Virginia's Commonwealth University Dental School. And she basically is an inaugural member of VCU's Interdisciplinary Oral Health Equity Research Corps. And she's a former public health professional with experience in university, community, federal, and global settings. Dr. Raskin uses qualitative, epidemiologic, archival, and interpretive approaches to examine the political and moral economies of oral health disparities and dental professional inequities in the US, and to identify policy and other solutions. Dr. Raskin is the co-president of the Association for the Anthropology of Policy, ASAP, a frequent reviewer for major dental journals and NIDCR, that's at NIH, and a co-lead organizer with the Washington, D.C. chapter of the National Lawyers Guild Legal Observer Program. She's also a hobby potter and a very happily parent of a teen. all of those, bless you. Please help me introduce Dr. Raskin.
Thank you so much for having me here today. I'm really flattered, and I'm going to start my timer so that I can try to keep us on schedule as we go. Great. So I think that here we go. So as I was getting ready to prepare my talk, I actually kind of changed the title a bit, sorry. But I'm now calling it Oral Health Humanitarianism, Ethics and Responsibility from the Domestic Sphere, meaning the lessons that I can share with you all, and then kind of back again. So what is the kind of dynamic between the domestic sphere and the global sphere? And yesterday, in particular, as I was listening to Dr. Patel talk about FQHCs, as I was listening to Dr. Rodriguez and Carrie Ann talk about the pluralistic dental team, really including dental therapists, I was thinking about the particular importance for what I'm going to talk about today, which is how U.S. professional dentistry envisions its humanitarian responsibility, some of the problems with that based on my ethnographic research and also my use of social theory, drawing on my background as an anthropologist, and then maybe some ideas about how these things can be improved. So the learning objective is to critically analyze domestic global oral health humanitarianism and then identify reciprocal learnings with the global sphere. And then I know that typically we do disclosures. As a qualitative researcher, a feminist who has really learned a lot about Black feminist methods, and an ethnographer, I prefer the term positionality to kind of tell you where I'm coming from and what are some of my kind of influences. So I have no financial or other non-financial compensation for this presentation. My ethnographic research has been funded by the National Science Foundation and my institution. And not only have I conducted ethnographic research at a MOM project, actually the original Mission the Mercy project in Wise, Virginia, but I actually have also volunteered there for a very long time as a non-clinical volunteer. I have no clinical skills, and hats off to those of you who do. And I also want to go to this point about rurality, because actually I grew up in Central Appalachia. My family is not from there, but I grew up in an area of the United States that not only is rural and extremely impoverished, but also so many of the health disparities are the results of extractive economic interests in that region, extracting wealth as we see kind of worldwide. So I see very much the applicability of a global health lens to that region. So when we think about humanitarianism, like, what does it mean? Well, the Cambridge Dictionary tells us that it is, quote, a belief in improving people's lives and reducing suffering. I would ask, and others, and presumably acting on this belief, right? It's one thing to believe it, it's something else to act. But I would say whose? Oh, those lines should be a little bit underneath, sorry, they've moved. Whose belief, whose idea of improvement, whose idea of what it means to reduce suffering? And I certainly am not the only person who thinks about this. There's a long tradition of critical humanitarian studies. People like Mariam Tickton working in France, and many others kind of examining humanitarian apparatuses and seeing, like, whose interests are they advancing? We have this idea, there's this kind of statement, we want to work ourselves out of a job. But so often we see this replication in places like, long-term refugee camps, for example, where there is just kind of this perpetual cycle and a paternalistic cycle where, speaking to what Dr. Mehta was talking about a moment ago, this kind of idea that, higher income countries give and lower income countries receive, and what is the dynamic of relationship between there? And not increasingly, a little smidge, these ideas have been applied in the oral health sphere as well. So in 2006, Dr. Wendy Moradian actually wrote a vigorous rebuttal to the idea that we needed to increase the number of students who are doing kind of mission-based or mission-oriented, whether it's global missions or domestic missions, and I'll kind of disambiguate the types of volunteers and then I'm talking about in a moment. but Dr. Wendy Meridian wrote this critique of a call to do more of this work. In 2011, my fellow anthropologist colleague and friend Michelle Rivkin-Fish actually went out with a cohort from UNC Chapel Hill on one of their like 3-day mass dental events. And she described the concept of becoming moral citizen dentists and how the education that occurred there, the kind of non-clinical education, the social education, was really about kind of teaching students to kind of learn more about their own sense of morality than about their patient's actual need, right? And that was one of the reasons I was so delighted actually in your talk yesterday. I think it was Carrie Ann sitting here, and when you asked for people to, what was the response? Carrie Ann said, well, I don't diagnose it. I ask them, what their perspective on their mouth is. But according to Michelle Rivkin-Fish, exactly the opposite is going on. And what I have seen in my own ethnographic work in the MOM projects is that there is a lot of attention spent to lifting up the valor of clinicians who are coming to impoverished areas, whether they are rural, whether they are urban. And listen, I don't want to dismiss the work that they do. They are literally relieving people's pain. Some people actually come, well, I'll talk a little bit more about my findings there, but at the same time, they are also creating this kind of milieu or perpetuating this milieu of paternalistic charity. And that is also something that is perpetuating the employment. VCU students are coming, they are meeting dentists who they would like to shadow. If they are pre-dental, they are meeting people whose practices they might like to join. And so there's also this whole kind of professionalization that is taking place at the same time. And I understand why that occurs, but I think that we fundamentally have to ask, are these the only ways to accomplish it? Now, in my bio, I was introduced as one of the co-leads of the National Lawyers Guild Mass Defense Committee. We mostly do legal observing at protests in DC. I'm actually kind of a long-term street-side protester. And you might have also picked that up yesterday from Dr. Fleming when she called me her co-conspirator. We do a lot of kind of thinking about this. But I think that we were fundamentally, it was demanded of us to listen beginning in 2020 with the COVID-19 pandemic, the uprising, the racial justice uprising following George Floyd's murder, and actually in the last 2 years also with the uprising around Free Palestine and the ceasefire. I think that we also have a lot of lessons to learn from community organizers and activists. And so very much my thinking on this topic is guided by movements to decolonize global health, to localize global health, to really interrogate how white supremacy shows up in our work, to stand with and support local organizers and claims. So the disability rights movement, claiming nothing about us without us. And I'm curious, how don't those get applied in oral health humanitarianism right now? And how might they in the future? So when I talk about oral health humanitarianism in the domestic sphere, I want to disambiguate that because there are really kind of two major models. One major model is community-based dental education, and that is where dental schools have long-term sites where they have ongoing relationships, for example, with FQHCs, or for example, like with some of the Indian Health Services sites. And so students might go out for 2 weeks at a time. They might go out for 6 months at a time. They might live in the community if it is far enough away that they can't easily get back to their apartment each night. Those models, on the whole, broadly, tend to cultivate relationships with the local partner organization. Even though the students might kind of rotate, the faces of the students can rotate in and out, there does seem to be some kind of an ongoing relationship. It is also helping generate revenue for that local partner by being able to do reimbursable services. And some of those models, for example, AT Still in Phoenix, it seems that Eastern Carolina, where community-based dental education is core to their mission, are actually then turning out dentists who want to work in these spaces, right? Like that's part of the idea, is to introduce dental students to working in community. I also would be remiss if I didn't observe that the other oral health humanitarian domestic model that I'm about to talk about, these short-term experiences, rose about 25 years ago. And I should say, I'm blanking on his last name, but Terry, who founded the Mom Projects in Virginia, is a friend and a colleague, and he agrees with the critiques that I have of this thing that he started 25 years ago. But these short-term experiences are more parachute experiences, and they actually became very popular at the same time that ADEA and the ADA were declining programs, deliberately declining programs in dental public health and community dentistry. There was a time in the 1970s and 80s and 90s when some schools had vibrant community dentistry programs, and it was a deliberate choice to decline them as part of a broader national kind of level setting about the distribution of dentists in the United States. So I just wanted to share these observations, because then when we think about outcomes, like when we think about patient outcomes, how many procedures occur, the provider outcomes, like the donation value for some of these, the student outcomes, like learning outcomes. And I should say that it's really sad to recognize that a number of these community-based dental education programs have actually seen declines in measures of empathy as students proceed in their time there. That's poorly understood, but I think it's essential that we try to understand how community-based dental education can actually result in a net loss, not a gain, in empathy. Also, something that is completely missing from these measures are questions about systems change. Where are measures of localization, of commitment to advocacy, of commitment to structural reform? So I'm trying to speak very fast, and I promise I will get through this. So as I mentioned, I'm a long-term volunteer and ethnographic researcher at the Cornerstone Mission of Mercy in Wise, Virginia. On the right is the dean of the VCU Dental School, Lyndon Cooper. On the left are some of our students doing work. And so what I have observed is that not only do these experiences, these 3-day drop-in experiences where there are millions of dollars donated over time worth of services, there are also hundreds of thousands of teeth extracted over the course of 25 years. Other things happen, which is really suppressing the local market. So the local dental market for the local dentists. So for example, individuals who are used to going to these mom projects once per year for their dental cleanings, maybe for some appliance repair, if they win the denture lottery, which is a term because they have only so many dentures they're able to make, actually, they see these urban, big city, glamorous dentists roll up in their Lexuses and Teslas, and they start mistrusting their local dentists, right? We have actually seen some decline of utilization of the local dentists who they could have long-term relationships with. Also, it seems to have a suppressive effect on hiring in local FQHCs, because rather than dental graduates can feel comforted by the idea that they can go and give these services and then go back home. And, in that regard, I'm culpable as well, because I too live in an urban area and travel for, days to my home region. And it's cool to have dinner with friends still in the region, but then I still go back to DC where I can get Laotian food and art house movies or whatever. So I'm a part of this problem too. So I just in the last few minutes want to introduce a couple of principles that I think that we could and should push to apply in oral health humanitarianism, some different models. So the model actually closer to me on the left is the UN's Office for the Coordination of Humanitarian Affairs. Their standards for quality and accountability. And so they really situate at the center of quality and accountability the affected people and communities. And so they have identified 9 principles. On the other side of the screen, on the right-hand screen, is the accompaniment model that has been developed and utilized by one of the perhaps most well-known and probably morally upright, although I welcome feedback if that's not accurate, international NGOs, Partners in Health, which if any global health people in here, you've probably read Paul Farmer's work. This is his NGO, and that is his model on the left, not his, but his organization's model. May he rest in peace and for a revolution. Then there are some other examples. For example, the spectrum of community engagement for democratic participation. So this is used for democratic governance in terms of community relationships, moving from the right-hand side of the screen, which is kind of to ignore community interests, all the way to the left-hand side of the screen, your right-hand side of the screen, which is power sharing in a model of deference. This is applied in community engaged research. To me, I don't think there's any reason why it shouldn't be applied actually in oral health humanitarianism in the domestic and global spheres. One project has actually begun doing it. This is actually a publication from last year about the application of the broker declaration to short-term experiences in global health and dental education. And so the authors map it to CODA standards and the ADA Code of Ethics. And then I also just kind of want to close, because I'm running out of time, with some other opportunities that I see. There's been so much movement in the last 5 years, in oral health, led in particular by my dear friend Eleanor, but others, to introduce anti-racist frameworks for dental education. So that is really to get into ADA's accreditation standards and to introduce anti-racism into them, to really re-envision the social contract through an anti-oppressive justice lens, and then also for some of the work on decolonization globally. So I'm 1 minute over. I'm very sorry, but here's my daughter and myself. My shirt is actually taken from a woodblock print from the 1999 WTO protests called The Battle in Seattle. And it says, "Your heart is a muscle the size of your fist. Keep loving, keep fighting." There is my email address, and I look forward to staying in touch.
Thank you very much, Dr. Raskin. I think 15 minutes was not enough. I think we needed more time to just unpack that. But I think you bring up very solid points in terms of how do we translate doing good into equitable, justable care, in which the people that we're doing good for are the creators of their outcomes. I think I'm not guilty, but I'm part of the milieu, as you would say. I've done Mission of Mercy. I did that when I was a pre-dental student. I was just thinking how I've done that as a dental student and post-dental school. And I know that that's not a long-term fix. So my next presenter is Dr. Elham Khatib, and she is a professor of dental public health at, forgive me if I don't pronounce this well, Al-Quds University College of Dentistry. Since 2017, she has held the position of Dean of Scientific Research, contributing significantly to AQU's and the Palestinians' research initiatives. She co-chairs the Palestinian chapter of the Organization for Women in Science since 2020, promoting gender equality in academic and research. In August 2023, Dr. Khatib assumed the presidency for the IADR Palestine chapter, having successfully established its presence within the International Association of Dental Research. Her leadership extends globally as she chaired the Public Health Committee of the World Dental Federation for 3 years, starting in 2021. What am I doing in life? Okay. Recently, in 2024, in September, she was elected as counselor at the World Dental Federation, furthering her impact on global oral health policies, advocacy, and knowledge exchange. Dr. Khatib is widely recognized as a specialist in public health and health services research, advocating tirelessly for health equity and sustainability. She co-chairs the Sustainability Health Equity Movement and is a member of the TUG Dental Health Without Borders Advisory Board. Please welcome Dr. Khatib.
Thank you, Eka, for the introduction. Okay, so I just move. Backwards. Okay. Okay. So maybe this is like better to use this. Okay, so thank you very much for being here this morning. Thank you, Sujay and Dental Solidarity for the invitation. I enjoyed yesterday very much. It was like very insightful presentation. I enjoyed Sarah's also, and I'm looking forward to hear from Khalida and the others. So today I will talk about oral health in humanitarian settings, in crisis settings, and in refugee population. Okay. Go to this again. Okay. Okay, maybe this. Okay, that's better. So we've been talking about oral health and how is it not a priority among all other health issues since, yesterday. And you can imagine if we are talking about oral health as not a priority in a vulnerable and marginalized population like displaced persons. In this presentation, I will talk about oral health, access to oral health, and some statistics that we collected about policies and activities related to refugee oral health among different countries, almost 90 countries, member states at the FDI, which is the World Dental Federations. I didn't realize that we have a global conflict tracker until I found this website that track and update, the global conflicts and their status. And you can imagine in North Africa and the Middle East only, we have like 35 conflict areas and war zones that are, active at that moment. All those conflicts for sure produce displaced persons and refugees. And when we talk about displaced persons, we talked about internally displaced persons and externally displaced persons, that some of them, they are recognized as refugees. As you can see on this graph from the UNHCR, which is the main United Nations agency for refugees, how the numbers are increasing. By 2024, we have 122, almost 123 million people worldwide were forcibly displaced from their homes and their lands. And this has had an impact on oral health systems. In Sudan, we can see like a complete destruction of the healthcare system. And in most areas, they, switched to teledentistry to see their patients and provide care for their patients. In the WHO Eastern Mediterranean report, they showed how the Palestinian territories facing severe oral health care deterioration. We have only 17% of the primary care facilities functional when we talk about Gaza, 50% of the medical missions obstructed, delayed, also in Gaza in the 2024 report. Also, and those statistics are 5 months old. It's 435 attacks on medical personnel, professionals in Gaza, and we can imagine the post-trauma stress, syndrome and the mental health crisis that they are suffering also among medical professionals in Gaza. If we want to talk about the dental workforce, 60 dentists out of 1,500 licensed dentists only working, 4 months ago in Gaza, and most of them, they are working in a very, troubled situations from tents and or from partially destroyed dental clinics. Many of the global organizations recognized political and conflict as social determinants of health. The WHO in different reports stated that political unrest and political instability is one of the main social determinants of health. The United Nations recognized this, the UNDP, and finally, the World Federation of Public Health Association continued to advocate for political instability as an important health determinant of health. Back to this graph, we can see that mainly of those 122 millions are 43 or 44 are refugees and 72 are internally displaced. And those internally displaced even, face even harder condition than the refugees because they are staying in the same area that, suffers from political conflict, from war, or from deteriorating healthcare system. 71 of the people who forcibly displaced externally are hosted in low-income countries. So you can imagine their conditions because they left like a troubled area going to another troubled area already. And unfortunately, 47 million of those displaced persons are children. If we will talk about refugees, we know that refugees and displaced persons, externally ones and internally, they are protected by international law. However, they are still vulnerable population and they still, operate in very complex situations and conditions and face barriers to access healthcare in general and dental care in particular. Also, whenever you read any major organization that care for refugees, you can find that oral disease is one of the top burdens among refugees or displaced persons in their reports, and different, complaints about dental caries, periodontal trauma, and oral lesions. So in different humanitarian settings, research showed like in Libya, there is an internally displaced population because what's happening there, higher rates of untreated caries. I always list that wrong. In Somalia, 60% of the children have dental caries compared to the displaced ones, compared to the non-displaced ones. In Venezuela and Haitian refugees, the research shows that they need very extensive dental cares. Even in Ukraine where refugees, the DMFT, when they were assessed, they found like a high, DMFT, like 3.5, which is in that area considered high. In Gaza, we don't have published, assessment, but we have, observations from the dentists where they showed troubling increase in oral health issues linked to malnutrition and depending on canned food such as scurvy, gingivitis, bleeding gums, reduced salivary flow, weakened dental enamel, and higher susceptibility for infection. And even when we talk about refugee and we compare those refugee population to the disadvantaged population in the host countries, we see always the refugee and the displaced persons had higher prevalence of the disease, as we can see in the US, in Australia, in Canada for adult population. And in all those studies, health status and the need of refugees differs according the origin, the country of origin for those refugees, and the host country and their regulations. We also things like those graphs and how the social determinants of health in migrants include like other disadvantages, barriers like individual, social, institutional, community, socioeconomic, cultural. In addition to all those, we have the extra ones like the limited knowledge of healthcare system when you are in another country, the institutional discrimination, and we talked about this, the shortage of dental professionals, the cultural practices and beliefs of the population itself, the economic constraints and the financing systems for refugees, the prior beliefs about oral health, the trauma and fear that accompany the refugee journey, the access barriers that we know, and the language barriers. In a survey that we did for 90 countries all over the world, as you see, the red countries, we saw that the main responsible agency is the UNHCR, which is the United Nations Commission for Refugees. We can see other local authorities. We know the UNRWA. I'm sure that you heard a lot about UNRWA in the past year. It cares only for Palestinian refugees. And we have the International Organization of Migration and other international charities that care for refugees. When we asked what type of access is available for refugees, in countries with high income, with high efficiency, healthcare efficiency index, we can find free healthcare and subsidized one. But in countries with lower income and lower healthcare efficiency system, we can find that refugees or displaced persons need to pay full cost for dental treatments. When we asked about who financed dental care, for the one before is about healthcare in general, this about the source of financing for dental care. We can see also in countries with higher healthcare system efficiency index, the government pays for the refugee dental treatment. But when we go to low-income countries, we find that international organizations are the responsible agencies for that. When we asked about, do you have an obligatory screening system when those refugee or displaced persons arrive to your countries, we find only 4%. What's happened to, okay, I missed some of the graphs. Okay, so only 4% that has obligatory system for screening. And among those 4%, we have only 33%, which was only one country that have an established referral system. So when we identify the disease for them, we have an established system to refer them for the treatments. What dental services offered, as we expect, mainly emergency dental services, a little bit of therapeutic, and even less for preventive. When we asked about the national policies in that country about refugees, we found that the main policies about general health, some of the policies about, regulate the work of organizations, very little about dental and oral health care for refugees. So our main sample was the National Dental Association and some chief dental officers with the governmental people for oral health. And we asked them about their role for refugee oral health in their hosting countries. Mainly it was promotion activities, less for providing care, even less for advocacy and policy. And 51% of our sample, they have no role with refugee oral health. We asked a follow-up question for our member states. What recommendation do you have for improving access for refugee and displaced persons? They reported policy change, increased resources, awareness campaigns, care provision. That's the main top, strategies to use. And we can see how they emphasize the policy change here. So what goals we need to achieve when we talk about refugee and displaced persons? To improve oral health knowledge and behavior among the refugee themselves, to stabilize the disease, to reduce the pain and the discomfort among the refugee population and displaced persons, to prevent any further oral diseases, to increase access to dental care, to build resilience and capacity among the displaced persons population, and to improve overall health and quality of life and address the mental health issues that related to oral health diseases. The evidence-based strategies that we have to promote oral health among refugees and displaced persons, raising awareness, community engagement and empowerment, integration to primary care. We've been talking about this all yesterday. Use of minimally invasive restorative techniques, especially with mobile clinic missions, training and capacity building among the refugee population and among other healthcare providers that they have access to refugees, displaced persons, and persons in conflict areas. Cultural sensitivity and trust building, and this is very, very, very important. And it's like a measure of success when you work with refugees and displaced persons. And of course, policy, advocacy, and collaboration, and this needs advocacy, partnership, and community engagement. The WHO, when we talk about the humanitarian and the crisis, they don't treat all situations the same. There is some protocols that need to be addressed pre-crisis, during the crisis, and post-crisis. So in the emergency response to crisis, as we talked yesterday, we need to include the initial phase of emergency response. We remember what happened with us in the COVID. We were not included in the first response. We were marginalized. Our dental clinics were closed for months, and this has happened globally. Why? Because we are not a decision makers. We were not, oral health were not included or was not included in the first response. So we were, on a side for months, and people were denied the access to dental care, the proper dental care on the first months, and, in some countries for years. Disease management, this should be a priority to stabilize the disease among the emergency response times, and then we need to integrate it with the programs. We know that those programs are in the front of the response, the humanitarian response. We know that infectious diseases programs, non-communicable disease programs, maternal and child, they are in the first line in the response, the humanitarian response. So oral health need to be integrated. This is the only way that oral health will be addressed in the beginning of any crisis or during even the crisis, if they are incorporated on those programs. They will not, talk about, and we had this conversation today before, they will not look at oral health if it was, isolated. It will not be a priority. It will be considered a luxury, although it's the first one burden among refugee and displaced persons in all major organizations, Sorry, I'm above time, so beyond time. So in post-emergency, we need to focus on data collection. Physicians and dentists in the crisis areas in Gaza, they, call us and say, please document what we are seeing. New conditions, new problems, new challenges in accessing care, even in new, lesions, new diseases that erupt in such, cases that need documentation, need data collection. And of course, community empowerment. And, we know areas that it's always in a crisis. So we need to be prepared by, as we said, embedding, oral health in all primary care programs and packages, increase funding, and always developing culturally appropriate intervention. Among all those, we know that there is resource limitations, lack of trained personnel, health treatment needs. Those populations, they have very complex dental health needs, and the mental health and the trauma that accompanied that, what they happen. And the most or the biggest problem is the sustainability of interventions. So I will try to finish, but the most important thing to do and to have a sustainable intervention, not as we said about, Sarah, what we are talking about, missions, is to integrate oral health in the humanitarian response, integrate oral health in primary packages, integrate oral health in all plans and policies related to the emergency plan, as we said, the non-communicable diseases, and we'll talk about this. Should be the holistic approach, improved outreach, provide training to other healthcare providers, and it's a very good way for our resource allocations. We need to do this in emergency programs and also on long-term strategies, universal health coverage. We need to address displaced persons, refugees, where they are in universal health coverage, the host countries or the countries of origin. We don't want, as we talked yesterday, Khalida, for them to fall in the cracks between those two destinations. We need to know what type of universal health coverage they need to be covered in. Community engagement is very important. Stakeholder involvement is very important too. And this is the most important thing that I've been trying and I didn't succeed yet. Mobile health solutions good, aligning with the global strategy is good, but policy integration with SPHERE, which is the standards of a humanitarian response, and the new UNHCR. Whenever you talk with those major organizations, they said, we don't have oral health in our strategy. We don't have the oral health language. So we can't, work on that. So we need, as organizations and individuals, to advocate with all those major organizations to introduce the oral health language in their strategies. And in a quick study that Hyun Lee and her students did, they found when they analyzed the major organizations that care for refugees, that there is no language for oral health, very inconsistent programs in those major organizations, and there is a big need for integrating oral health in their strategies, and the potential points identified in their work that was primary healthcare delivery and workforce training. That is a good 2 points to start with those major organizations. Those are successful stories. One of them that will be presented by my colleague Khalida in a few minutes about how to improve health in among refugees and displaced persons. And just I want to mention, in Gaza, the UNRWA started to do like a few months ago teledentistry to address the care. Like people who were displaced, dentists who were displaced were using teledentistry to support dentists who stayed in Gaza. So in conclusion, we know that oral health is an overlooked part of a humanitarian response, and we need to get them integrated in primary care and universal health coverage. We need an urgent need for advocacy, policy integration, workforce training, resource allocation. And our next step needs to be to identify and develop protocols for dental work, for dentists and other primary care in humanitarian crisis. But for all us here, organization and individual, I think alongside with the healthcare interventions, we need to champion justice, equity, and peace as individuals and organizations. Please have a look at our resources at the FDI, the project for oral health. We have many different resources, especially this advocacy guide that takes 6 steps to help you as individuals and organizations to establish your advocacy. Oral health is very important, even in displacement, and it's a basic human right. Thank you very much.
Thank you so much, Dr. Khatib, for giving a voice to a population that is usually invisible. When I was in residency, in New York, we had a program with recent refugees who came into the US. They were partnered with the university and the hospital, and they had a day of the week where they came and they got care. And I remember the challenge I had as a clinician, and what no one seemed to address, is that the appointment was 1 hour long. And for most of my patients, I spent at least 15 to 20 minutes getting them comfortable. And then I had 30 minutes to do something, which was never enough. And then they were handed off. And I just remember being like, okay, I'm trying to do something, but somehow, once again, my public health hat was like, this is not enough either. And I was just thinking yesterday how they said about 2.5 billion people in the world have oral diseases. And I'm wondering, I'm sure, out of the 3.5, 122 million are suffering the most. And I keep thinking of the refugee population as one being, I read an article years ago saying stateless, where you don't have a home where you're from, and where you come into, you also don't have a home. So they are very vulnerable. And I thank you for this information. The next person I'm going to bring to our podium is Dr. Khalida Zaire. Did I get it right? Yeah, okay. She is a periodontist based in London and the CEO of the Refugee Crisis Foundation, which is a UK-registered charity and an international humanitarian organization dedicated to promoting health and the well-being for refugees. With nearly a decade of experience, she has been at the forefront of providing oral health care for refugees in camps in Europe and Asia. Since 2018, she has led the largest oral health care program and the only ear and hearing care service for refugees in Cox's Bazar, Bangladesh, the world's largest refugee camp and home to 1 million Rohingya refugees. Alongside designing service provision, Dr. Zahir conducts research to inform the design, delivery, and evaluation of healthcare initiatives. She has been awarded multiple research grants for innovative solutions to addressing the high burden of oral and ear disease. Dr. Zahir works closely with the partners including UNHCR, the World Health Organization, FDI World Dental Federation, academic institutions in the UK and Bangladesh. Please welcome Dr.
How do I do
Are we doing this together?
No.
All you. Thank you so much. It's a pleasure to be here. Thank you, Sujay and Pri, for the invitation. It's very difficult to follow Ilham, and I was supposed to be before Ilham, but I asked Sujay to switch us around, which might be a mistake. So next time I'm going before you. I meant it in a really nice way. She sets the stage very nicely for me. So it's a lot easier for me to come in and just talk about the work that I'm doing. So Ilham covers very nicely the global problem and what the issues are globally. And you may have noticed in some of the graphs there were NGOs, which are international non-governmental organizations, and that's a category that we fall in. So when you're listening to my presentation, just bear in mind that's the role that we play in the international landscape and infrastructure. So I'm a periodontist, which means I use a probe that only goes up to 15 millimeters most of during my day job. And then when I have patients come with me complaining of 2 millimeters recession on their front tooth, and my public health, and global refugee work is also in the back of my mind. I put them off having surgery done, which the practice owners that I work for are not happy with. But I'm like, there are bigger problems in the world than your 2 millimeter recession. Symmetry of them. So it's interesting having that perspective.
Have that been called for next year?
Absolutely. I hope none of my employers are listening to this because I'll be out of a job going back home on Monday. So as Ilham said, we have a global problem. We have a lot of refugees and they do fall through the cracks because the host country, for them, it's a burden. The international, they've fled their country of origin, and then you have a lot of international organizations coming in and trying to do something. We started off our journey with this photo that moved a lot of people, especially in Europe, because it was close to home. So Alan Kurdi was a 2-year-old Syrian Kurdish refugee who was washed up dead, lifeless on the beach in Turkey, and his 5-year-old brother also died the same way. This is not uncommon. Every year, thousands of refugees die at sea. Boats are overfilled, they're capsized, there's a lot of pushback. And I've actually seen the pushback when I was volunteering with a partner organization on the island of Lesbos in Greece, where you can see Turkey right across, and you see the boats just in the middle or being, going back and forth. So there are real issues, and we play a small part because as dentists, other than oral healthcare, what else do we know? So that's where we become advocates for oral healthcare for refugees. So that photo was seen by a couple of friends and those that now have become part of the core team of the organization who were parents. And they were moved by that photo that, they saw their own children in that photo. And they said, well, we have to do something. So what did we do? We decided to do emergency dental care for refugees living in Calais, which is in France, and there was a camp called the Jungle, 10,000 refugees, mostly women, children, unaccompanied minors, lone men, and a really sort of not the safest of camps, not just at night, but even when I was walking around during the day with my dental team as well. And we had approval from the French Dental Council to provide emergency dental care. And I think it's I loved Sarah's presentation. And Sarah, you're the only person I know who said what you said about dental mission trips. And I'm glad you're saying that. And you should be speaking, you should be invited to every single setting, symposium, conference talking about this, because this is an issue that's been going on for decades. The sexy term is decolonizing global health. How many of us actually do that? But we need to move away from that, and we need to start thinking about more sustainable models. But we did start off with that sort of care because in certain settings, that's the only care available. So in this refugee camp, that's coming in, doing the emergency dental care and then going back home. I was a dental student. I was not allowed to treat. And now that I run an organization, students are not allowed to treat patients. This is not the ideal setting for you to learn how to be a clinician, how to provide dental care. I work with ENT surgeons. We had an otolaryngologist yesterday in the room, and I've gone with a couple, and one I said he's not coming back again. His complaint was the tables and chairs weren't set up for us, and I said, well, you walk in a room, you be proactive. If you walk in a refugee camp, you're not in a hospital in Europe where you're the medical director, because he was the medical director of a hospital in Europe. So I've kept it very vague. But even as qualified clinicians with experience of whatever setting that you work in, it doesn't automatically mean you should have that responsibility to see people in that setting and know how to appropriately treat them. So I speak a couple of languages. I speak 4 languages. It was one of Suja's questions yesterday. So one of my supervisors, clinical oral surgery tutors, said to me, Khalida, you speak a couple of languages. To be frank, most of us are Pakistani dentists. The camps mostly have Afghans. I'm from Afghanistan. We don't speak the language. Do you want to come along with us? All I heard was field trip. So I said, yes, absolutely. Whatever it is, I'll go. My dad was like, you're going where? By yourself? I was like, to a refugee camp. And he goes, yeah, that's not happening. You can go if you take one of your brothers. And I have 6 brothers. So I was like, how difficult can this be? 2 were under 18, so that was not possible. This was a decade ago. And then I had to go beg the others. So one I convinced, he was studying civil engineering, and he was like, well, what am I going to do? He came along with us, and we had an autoclave stolen from us, which disappeared overnight, which taken by one of the refugees. So he was negotiating for a couple of hours, and miraculously the following morning it reappeared. And that's when I started having a passion for dentistry. I only did dentistry, and we've got a couple of students, which is why I'm going into the story, because the pros and cons were like, oh, a flexible lifestyle, you make a decent living, why wouldn't you do it? But zero passion for doing it. And when I saw what I saw, and I wasn't clinically treating anyone, and I think that's what dental public health is as well, and global health. You're not doing surgical missions, but the amount of fulfillment that you get from touching hundreds and millions of lives is a lot more important than going in and taking out a couple of teeth. So we worked in France for 2 years, then the camp was shut down. So we moved, we had a stint in Greece, but because of bureaucracy and registering as an NGO, we didn't go further with our work there. So in 2017, there were 750,000 Rohingya, who are an ethnic minority, mostly Muslims, some Hindus as well, from a state called the Rakhine State, which is red in that map, from Myanmar. And the British get called out a lot when we talk about humanitarian, and I'm a British citizen. But the reason the Rohingya have been denied citizenship since 1982, and one of the world's largest stateless population, is because when the British drew some lines and we went from Burma to Myanmar, the Rakhine State ended up becoming part of Myanmar. And Myanmar said, well, actually, you're Bangladeshi. Bangladesh are like, no, you're not Bangladeshi, you're Burmese. So these people have been denied citizenship, which means that, and that's just as Elham was saying, before you go down talking about oral health and integrating oral healthcare, which we've all heard a lot, and I feel like some of the students might say, well, okay, great, what is integrating oral healthcare? What are we trying to do? Before you go that far deep down, you've got to understand what is the setting that you're working in and the population? So the Rohingya live in one of the world's largest refugee camps in the world. Some say it is the world's largest refugee camp. It's 24 square kilometers. So we've got somebody from the Philippines. So Manila, according to ChatGPT, is the most densest city in the world. These camps in Cox's Bazar, they're denser than the densest city in the world. So you've got around 50,000 people per square kilometer living in mostly bamboo shelters. And this part of the country in Bangladesh is prone to monsoon and cyclone season. So we see a lot of destruction every year. As an organization, I took a leadership role, and there's imposter syndrome that I'm trying to fight off, and I think we should own the work that we all do. And I had a lot of learning to do because I was a clinician and I was going through postgraduate training and residency. So I could pick up a blade and I can cut, and I was a humanitarian, and then I was also doing research because a mentor of mine, Professor David Williams from Queen Mary University, introduced me to Elham in 2019. And that's when I learned about Elham, and she took me under her wing. So thanks to her for understanding how you can combine the three together and the importance of research in advocacy, because my mentor said to me, Professor Williams, that it's great, Khalida, showing photos and videos, but what do the refugees want? What are their needs? Have you asked them before you design and implement services? So what I've learned, and it's a very organic learning process, because there isn't really a course you can go into to learn leadership, humanitarianism, advocacy, and academia all in one, and then be responsible for an organization. And so there's a very heavy sense of responsibility. And where we are now, fast forward from 2018 to 7 years later, we work as an organization, as an international NGO with local NGOs. And that's not out of choice, although it should be. But more importantly, the government of Bangladesh states that as an international organization, you cannot work in the camps. You have to work with a locally registered charity. Although they stopped registering charities in 2017, we know it's because there's a lot of international aid coming in and there wasn't much for the host community. So we work with local NGOs that implement our programs. So we work in their facility, our finances are through them, and I inform our own local team. So I have a team of project managers, dentists, and empowering local communities, which we were talking about. We have a couple of the Rohingya refugees who could speak English, speak Bangla and the Rohingya language and Burmese. So very talented individuals, young, who we trained up to become dental assistants, and now they're dental assistants. They are enumerators. They collect a lot of data for us, and they're actively involved in our research project. And I do a lot of schmoozing as well, which are what most of those photos are. It's got to be done. You've got to do it. Once you earn trust, and Elham made this point, you have to earn trust with the local population, but also the big actors. You can't ignore them, the stakeholders. And I went in 2022, and it was the first time they were meeting me, having, the programs being implemented in the camps for about 2 to 3 years. And it was very much like, who are you? What do you want to do? Especially with the ear and hearing care program, because we wanted to do tympanoplasties to repair eardrums. And they were like, you want to do what in the refugee camp under local anesthetic, and it's normally done under general anesthetic, and it was a lot of conversations and building trust and actually listening to them about what the needs are in the camp. So when I went in 2022, I mean, how can you not love me? They loved me, and they said next time you can't. They said you have a free pass, and you can continue to do whatever you like in the camp. So I'm very fortunate that I work in a humanitarian situation, in a humanitarian crisis, with the most wonderful partners that one could ask for. That goes from academia to UNHCR to WHO to the government. So when I went in January, we had dinner meetings, but there was no schmoozing because we were all friends by this time. Mm-hmm. So the projects that we do, I work in oral health care, but I also work in ear and hearing care, and the model we use is exactly the same. You do a local needs assessment, you do a piece of research, you design an intervention, you pilot it, and then you scale it up. And we also have a grant from the Academy of Medical Science. So we're talking about cross-sector relationships now and cross-sector partnerships. And Sarah's work is really important in the sense, and me and Ilham were both taking so many photos of your slides because we don't know that, that area of humanitarianism. And we both feel responsible that we should know this. So there's a lot of learning we can take from other disciplines. So I work with a professor in psycholinguistics, and she's designing a tool to screen kids for learning difficulties. And we were talking about autism yesterday as well. And this we forget. And that's something that can be embedded in our oral health care program, in our ear and hearing care program. And finally, research and advocacy. And I don't need to convince you of why that's important. So the situation in the camps is one where we have 1 million refugees, of which 51% are children. There are 33 camps. They're divided into two. So we have the ones in what's known in the Ukia district and in Teknaf, and then there's an island with 30,000 refugees as well. Very dense. You can see that's a density map. Most of the camps have around 30 to 40,000 people per camp. We have 4 dental clinics, and we also provide a mobile dental service as well. And we have a community-based oral health promotion and prevention program, which I'll go into more detail, that's funded by the FDI. And I'm going to play a very short video because you've heard enough of me. I had actually cut this, so you could only listen to 15 seconds of it because it's a 3-minute video, but I don't think we can do that. So I'm going to go to the next slide. But there's essentially a message from our, or I don't know if I can come out of full screen and just play the snippet. Yeah, I don't want to mess up your settings because you might not invite me next year.
To set up, this is quite challenging to.
Okay, we'll just have to listen to it in this setting.
Interventions like extraction, filling, and abscess drainage, that kind of common treatments we only provided here. But if we have.
Okay, well, it's on our website and it's on YouTube, so you can watch it there. But essentially, our dentist goes that this is, it's nice to hear from the local dental team. So I'm going to briefly go over a couple of research projects that we have going on where we're trying to understand the needs of the population. We looked at data from 4,000 patients attending our emergency mobile dental clinics. All they could receive was extraction and temporary restorations. And this wasn't so much to look at oral healthcare, but actually understand who these people are. Very low levels of education, 76% had no formal education. They report brushing their teeth, but we learned that they were using abrasive substances. Tobacco use was highly prevalent, and not surprising, high prevalence of caries, negative impact on quality of life. So this was us trying to slowly understand who these people are that we're trying to work with and pick up on behaviors that we could then investigate in studies and projects going further down the line. And that led us to a community-based program, which is called the Healthy Smiles. And this is part of the refugee oral health project led by Professor Ilham, where we are implementing a supervised school-based toothbrushing, SDF application, hand washing and healthy eating program. And we have a baseline questionnaire, oral health screening, SDF application. We've got construction work. So that's something else I also do. I have to think about things like how do you make washing stations and instruct my local team. Train the teachers. So this is the teacher showing the students. And that's our dentist. That's my project manager, Dr. Tahmina, who I think is logged in from Bangladesh. And then we did a 6-month follow-up. Now, it was very nice that this was adopted into the classes schedule. So at every single day at break time, they have an activity called Healthy Smiles. I don't know how many of us are that excited to brush our teeth in the morning, but it's nice to see that these kids are. So sometimes photos and videos do go a long way. Yes. There's a place for them. And I'm just going to briefly go over some data. And this is a manuscript in preparation, so we're hoping to publish this pretty soon. Half of the kids were underweight. Again, not surprising, but a finding that's actually quite important for us to then pick on going further down the line with our programs and actually sharing this with the local authorities as well. Again, parental education level, 82% had no formal education, but we knew this. And also, this is not surprising if you consider where these refugees come from. The difference between the refugees here and my personal experience of refugees in Europe are the refugees that take the Mediterranean route come from countries where prior to war, conflict, it was a flourishing state. You've got highly educated people that have had to flee, and they're the ones fortunate to make the journey. They're stateless in their country of origin, so they don't have any rights there. And there are literally very few organizations, you could count them on one hand, that work in the state that these refugees are from because of how unsafe it is and the restrictions placed by the government of Myanmar as well. So it's not surprising that 93% have said that they've never seen a dentist in their life. Now, again, we had some questions about toothbrushing, but we have to take this with a pinch of salt, because you hear they say we brush our teeth, and then you say, okay, well, what do you use to clean your teeth? And most of them will say we use toothpaste as well, but we use charcoal. And the DMFT, again, similar to other humanitarian settings, is about 3. Caries prevalence rate was around 90%. And we applied SDF, evaluated it 6 months later, and at 6 months, 50% had a rest of caries. And this is an intervention that's quite important in these settings, to try to use community-based, low-cost interventions to treat a common disease. And then as part of my residency, I looked at the prevalence and severity of periodontal disease in the refugee, but also comparing it to the impoverished host community. And that's where there can be hostilities between the refugee and the host community. You have millions and of dollars of funding coming in for a population, and other host community think, well, what about us? We don't have access to these services. And a really good review by Bhatia et al. Looked at healthcare services, and the host community had statistically significant less access to healthcare services. 15% said we have access to healthcare services, compared to 25% of the refugees. So with periodontal disease as well, quite a high prevalence rate. And as Elham said, the refugees 90% had severe periodontitis, compared to 74% of the host community. Recently, and I'll finish on this very quickly, I'm so sorry, I'm running over. So I was asked by the water sanitation and hygiene sector to conduct a survey looking at, they're giving out these toothbrushes in 2 camps, and there are 33 camps, and they want to have a business case to show that giving out toothbrushes and toothpaste makes a difference. So they said, well, we're doing a survey, can you help us design it? And I was like, yeah, absolutely, you're collecting the data, why would I say no? So we had a total of 642 households in 6 camps, and most of them, again, no education, charcoal and salt use highly prevalent. The IOM camps, where they were giving out the toothbrushes and the toothpaste, most of the refugees were regularly cleaning with it, but they were also using an adjunct like charcoal commonly with it. And the reason they use charcoal is because they use a lot of palm and betel nut, smokeless tobacco, and they leave stains, and also causes abrasion and tooth surface loss. So they use charcoal to try to remove the stains. Most of them go to see quack doctors and use home remedies because they don't have access to dental care. So we say quite a lot sitting in the global north about what we think refugees need, no matter how much I talk about localization. So when I was there in January, I sent an invitation to all the oral healthcare providers, and I said, hey, let's get together in a room. Let's come together as one voice to tell you guys what we think we need, not you coming in, doing helicopter research and going out. Let's hear it from you. You are providing services in the camp. And I'm hoping to publish the findings from this, but essentially, the second, high tobacco use and low oral health literacy, we're not surprised by that because of the findings. But what was surprising to me was the next 2, false beliefs about treatment, that a lot of the refugees and the practices that they use, some are very interesting. Overprescription of antibiotics. Now, somebody said, now this is not a surprise, but I'll tell you what's more surprising, is this is by the dentist. And I said to them, well, what is the clinical indication for you giving antibiotics? And the list that I had was 6 indications, and one was after taking out any tooth, before scaling. For any patient that needs scaling. And I said, okay. I think we should follow up on this point further down the line because I don't want to tell them what to do. We've got to have the discussion and take those forward. So we had some community-based activities for World Oral Health Day to get the kids excited. And these are the real challenges. It's very nice to show the work that my team does, but they work in very harsh conditions, cyclone, monsoon, fires. So it's not so easy doing research in refugee camps. But I'm very blessed with a fortunate team that try their best. So we've got to prioritize research in humanitarian settings that's led by organizations working in those settings, not by academic institutions sitting in the global north. And we've got to try to strengthen those collaborations. They do need support and they do ask for support. And we need to create that fostering environment to build local capacity in research. And finally, money talks. So funding is always an issue, and that's something either through research grants or through international NGOs and nonprofits that I pitch to quite a lot to try to scale up some of these projects. And I think I told Elham, or maybe I didn't, but when I met with UNHCR in January, they said to me, "Oh, we heard about your school-based supervised toothbrushing program," and I was like, "Yeah," and they were like, "We can fund 2 more," and I was like, okay, I didn't think you would pick up on this, but that's amazing. So there are international stakeholders that do support the work that we do. Thank you very much. And I'm sorry for the
Dr. Mehta said I should blame him for running over time. Not the amazing presentations that we've had. We could go on. I could listen to you for the rest of the day. But unfortunately, for the Zoom questions that were put online, could you please post it on the tablet or also email if you have specific questions for each presenter? We apologize for not being able to answer questions, but we're going to go over to our next section. Okay, help.
Should be this one.
All right. Yes.
Yay.
Okay. So lessons from resource limited regions. Over the last few months, I've been battling with the word resource limited because most countries have resources. It's how it's distributed, how it's used, and usually how it's used in comparison to other countries. And I sometimes think maybe we should say capacity rich, resource. Stop maybe using the word resource, but we're going to hear from 3 amazing speakers on the lessons from resource limited regions. And our first presenter is Dr. Abiola Adeniyi, and she serves as an assistant professor of health and human resources at the Farley Dickinson's University, Vancouver, and is the incoming chair of the World Federation of Public Health Associations of Oral Health Working Group. Her postdoctoral research at UBC focused on the chasms for change interventions in Kenya, reflecting her commitment to innovative maternal health solutions in global context. Dr. Adeniyi played a pivotal role in formulating Nigeria's first national oral health policy and pioneered the inaugural School of Dental Health Service program in Lagos State. An internationally trained dentist with advanced degrees from Nigeria, the United Kingdom, and Canada, she completed her PhD at the University of British Columbia, focusing on integrated care and interprofessional collaborative approaches. Her research expertise spans maternal and child oral health epidemiology, with particular emphasis on integrating oral health care into broader healthcare systems. As a board member of the Canadian Association for Dental Public Health, she continues to champion evidence-based approaches to reducing oral health disparities worldwide. Please help me welcome Dr. Adeniyi.
Hi, everyone. All right. It's my honor and privilege to be here with you all. I've had an amazing time today. Thank you for organizing this. Typically, when I attend conferences, I struggle to pay attention. But in the last 2 days, I have found it so amazing. It's been rich, it's been interesting. And I do hope that you find some lessons to learn from this session that I will be sharing with you. So I thought I'll start by sharing with you a story from our casebook. In 1998, I want you to imagine a small rural town in Tonga. You'd have a little boy who was 7 and he's in class trying to learn. But he's having pain, and the last 3 days he's been unable to sleep. And speaking to his mom, asking for help, but there's no dentist nearby to provide the kind of help he would need. The mother needs to go to the next island to get care. Fast forward this story, 2011, things have changed. Children are able to stay in school and learn because something happened. A program started called Mali Mali, which means smile in Tonga. That's an example of what we try to put together in this casebook, sponsored by the World Federation of Public Health Associations, to sort of tell you the stories of what is being done with school oral health. Yesterday, some people spoke about school oral health, and I've listened to, even within refugee settings, they're talking about using schools as a good setting. So I hope you can find things to learn. And I like what you said about resource limited. I have found, I grew up in Nigeria and I have been in North America for the last 7 years. I do find that there are areas, even within the global north, where they have resource limitations as well. So I invite you to think about this as lessons that you can probably take into your own individual context and potentially use. So what is the goal for this session? I'm hoping that by the time we're done, you'll be able to identify strategies that you can adapt wherever you find yourself, to think about how you might engage children in schools. I've structured this session to have like 4 distinct parts: a brief introduction to explain why we thought it was important to look at case studies all over the world, how we decided what case studies to include, and we sort of set this session to focus on Southeast Asia. And so I'll just be speaking to 3 cases from Southeast Asia. And then I would conclude by talking about what I think are the key success factors from these 3 cases. A little bit of background about the sponsors of this research. I, coming in as the chair of the Oral Health Working Group sometime in May. Okay, that's a little daunting, but it's a group of people who have passion for public health, and their real interest is around health equity. And so the Federation comprises about 130 member organizations, and there are 13 working groups, of which oral health is a working group. And the oral health working group is all about advocating for change and about developing strength for global public health. And of course, we focus a lot on oral health. And for example, in the last year, we've been working on a podcast with non-communicable disease group to sort of just put it out there that oral health is important to overall well-being. So why did we embark on this project? Over the last 2 days, I'm sure if you've heard nothing, you've heard about the scale of the global crisis with oral health. But we find that the largest proportion of people affected are children and women. That might explain why that is my own particular interest area. But it's more interesting to find that you might look at the prevalences in low and middle income countries and find out that it is low. But because they have such a high population, you would have high absolute numbers in these settings. And we recognize that research consistently shows us that when you build up good habits in childhood, children can take this on throughout life. So we thought educational institutions are the perfect setting for you to start to intervene and really bring in that preventive lens to get people going. So we thought about moving away from treatment into more of prevention and how we might stop people from developing disease. I think one thing I haven't spoken to is the fact that I got into dentistry because I started to visit a dentist at the age of 9. And that just stimulated my interest and made me think, if I had known this, probably I would have no disease. And when I got into dental school and realized that a lot of dental problems can be prevented, I thought this is what we should be doing. This is where we should put all our energy and our focus. Okay, so how did we decide what programs to include? We decided we wanted to look for innovative interventions. And by that, what did we mean? We're looking for new ways of delivering the service, a focus on prevention, definitely, but we were interested in programs that had community participation and looked at them owning the programs. We're looking for programs that focused on locally adapted resources that was suitable for the context, and then potentially sustainable funding models as well. I will be honest to say that we didn't really find a lot of sustainable models for funding. That seems to be an ongoing challenge, but still we were quite captivated by the kind of programs we identified. So how did we select the programs? We put out a survey for people to report what are the innovative programs you've encountered, and why do you think it's innovative? And then we screened the programs and reached out to the program leads for resources on each of the programs we thought were eligible. Once we confirmed eligibility, we then connected with the leads to ask for resources on the programs, as well as having interviews with the program leads. So in summary, those are our sources of data for this intervention. I thought I would start by sharing with you all the cases we did find in the casebook. At the end, I'll be sharing the QR code to the casebook. It's online, it's free, you can download it and read everything if you wish. But we've identified 8 programs and each of them is unique. But today, as I mentioned, we're going to focus on 3 from Southeast Asia because Sujay asked that we stick with Southeast Asia for this presentation. So I had 3 programs, and I think I want to start by identifying what was common to all 3 programs before I then try to identify what was different about the 3 programs. Each of these programs focused on prevention, and they identified that they would provide oral hygiene education to the children. Of course, it was age appropriate and focused on maintaining good oral hygiene. They all incorporated fluorides in one way. One major user, Tonga uses fluoride vanishes. In the Cook Islands, they also use stilants. In Indonesia, their approach was to use dental mousse. So fluoride was something that all of them made use of. And that is interesting, given the conversations we're having around the use of fluoride and its safety these days. The other thing that was common to all the schools was mobilizing community action to support each of these programs. I will go on to show you where there might have been differences between all of the 3 programs. Right. For Indonesia, the title says it's a dental immunization program. It has absolutely nothing to do with vaccines. It just was a term to coin the fact that it's focused on prevention. And this model was developed by Dr. Irene. She's a member of our working group in, I think, 1998, when she recognized that oral health was a problem in Indonesia. And she used what she described as a 3 friends approach. Simply, she has an oral health caries screening tool, which is either as an app or a flip chart that parents and teachers can use to decide how much risk a child has. If you find that the child has a lot of risk, they will then apply fluoride mousse, which speaks to the remineralization phase of the 3 phases. Finally, they would do fluoride application. And if they think it's an extreme case, they will then refer to the dental professional for a sealant. I want to highlight the fact that this focuses on parents and teachers rather than dental professionals going in to intervene. I think that was the very important thing. I forgot to mention that one thing that was common to all 3 programs was they lacked robust evaluation strategies, which was unlike one of the other programs that we found in the casebook. I'll leave you to check the casebook to identify that program. But all 3 programs do have some evaluation components, but it's not as robust as we would like. And so we want to encourage thinking around including that if you choose to do a school oral health program. But the good thing was that one thing that happened is they were able to integrate school oral health interventions in the national policy by 2015 because of the success, the clear reduction in dental caries occurrence that happened in the community. Let me jump quickly to Mali Mali program. This we heard of in 2023 when we attended a symposium, and we're really captivated by how they were able to move the children from like 0.9% daily brushing to 100% daily brushing. What happens is in their schools, they've included daily brushing as part of the curriculum. So children will get to school each day and get to brush their teeth in school. And they have noted dramatic reduction in caries occurrence in these schools. The other piece with the Mali Mali program is that they have annual festivals that are driven by parents and teachers again to sort of connect the children and in fact the entire community to dental resources. It's important to know that I think in Mali Mali they had just less than 10 dentists working therein. I'll jump forward to the Cook Islands. This for me was one of the more interesting cases because this adopted an integrated approach to the school oral health. The oral health education is really embedded as part of the health education for the children, and it's part of the integrated care framework for health in the community. As at 2024, they had done over 7,000 screenings. One thing I wanted to say was they are now thinking about having a strong evaluation protocol. In this program, when I speak about the Koputa Ganta, I'm not sure I'm saying that correctly, but it is a motivational interviewing approach that adopts cultural practices, and the response to it has been phenomenal in these communities. So I thought I would put all three programs together to see what was interesting about each one. In Indonesia, the focus has been the defense approach. Daily fluoride rinses is what they focused on in Tonga. While in the Cook Islands, it has been about integration. What are the things that I think we can transfer? Community ownership, I can almost say that is across board, but it was strongest in the Indonesian model. In Tonga, they do have support from JICA and SPMC. That is what has kept the fluoride going. And that's what has sustained its function. And finally, the use of the Koputa method I mentioned earlier is what stands out with the Cook Island program. In thinking about what we might take away from this, I want to say that it's, for me, I think I'll think around the focus on prevention. Rather than waiting for diseases to develop, they've been proactive to look at ways to get these children healthy and keeping them going in that way. The second thing I will speak about is the cultural adaptation. And I think that is one reason why the uptake for all these programs has been really great. Community engagement, that would definitely be connected to the cultural adaptation that I spoke about. And I think that's why, for example, in Mali Mali, almost all the schools in the island have enrolled in this oral health program. The integration with other health systems, in Indonesia, we talk about having a policy for oral health. And then maybe in Cook Islands, the way they've been able to make it part of the healthcare delivery is also good to note. And so for me, these are the key things I think we can take away to use as learning points. Why are we sharing this information? I think there's a lot that needs to still be done to move oral health forward. And I do believe that schools are a good intervention area. I heard what Sarah said this morning, and I think she's challenging my thinking about, are we practicing saviorism by doing school oral health? I would say that these three programs have shown that school oral health can actually be a good tool if properly used, and if it does consider what the local realities are. So these are my suggestions for how we might move forward from here. We need to think about policy frameworks that would make school oral health programs a useful tool. We want to think really about how we might evaluate these programs and make sure that they continue to work for their users. We want to think about how we might share knowledge, especially between areas that have high resources and low resources. What are you doing well? What What might I learn from you? And potentially develop models that we could scale. I want to just end by really thanking all the programs that we featured in the school casebook, especially the 3 that I'm speaking to this morning. The QR code there would help you connect with the school oral health casebook if you're interested. And I've left just my email. If you do want us to talk a bit more about this, please feel free to reach out. And I want to say thank you all for listening to me this morning.
Thank you so much, Dr. Adeni, for that. I think we can all learn about the fact that public health is prevention, and oral health is one of the fields where at least our system here in the US is trained for payments on intervention, not prevention. And I think getting any child young to set them up for their life course. So thank you. My next presenter is Dr. Ramprasad I'm going to say this again so I get it right. Dr. Ramprasad Vastare, and he is a distinguished academician and practitioner in public health dentistry, serving as professor and head of the department at Manipal College of Dental Science in Manipal. He is a MAHE FAMER Fellow, and he holds additional qualifications from renowned institutions, including certificates in tobacco cessation and health promotion, bioethics and research methodology. His expertise and leadership extend to being an executive committee member of both the Academic of Health Professional Educators India and the Indian Association of Public Health Dentistry. His academic and professional pursuits are driven by a passion for preventative dentistry, tobacco cessation, bioethics, and research methodology. He's also deeply involved in promoting interprofessional education, collaboration, and practice, reflecting his commitment to fostering holistic approaches in healthcare, education, and delivery. As a mentor, educator, and leader, his endeavors embody a blend of scholarship, advocacy, and collaboration. His involvement in academic and professional associations strengthened his role as a change maker in public health dentistry and a health professional in health education professionally. Please help me welcome Dr. Vastare.
Good morning to all of you. Warm greetings to each one of you, and my personal thanks for being here for this particular session. What a beautiful platform. What a beautiful day. Special thanks to Dr. Sujay, Dr. Priyanka, and the Solidarity Dental Foundation for the invitation and for me being here. This particular presentation is on the emphasis of interprofessional education, interprofessional collaboration, and interprofessional practice for enhanced community oral health. I think last 10 years, 15 years, we've seen this particular initiative receive a lot of focus and a lot of interdisciplinary talks, presentations, as well as the need for us to get together. It all starts with I, you, and we. We have a personal and a professional component. You have a personal and professional. And when we become we, it's all the more magical. In the sense, when we are joining hands to actually improve any health outcome for the community setting, for patients, I think it's truly magical. The more we focus on the inside, the better we are able to focus on the outside. We get more clarity. And that, I think, is one of the core issues of interprofessional respect, interprofessional cordiality, and interprofessional collaboration, which actually holds the bridge, in the sense which actually holds the whole concept together. So I come from Manipal College of Dental Sciences. I've been heading the Department of Public Health Dentistry for the last 5 years. And I'm also the FIMER Fellow. You have a FIMER Institute in Philadelphia. So there are centers all over the world. And Manipal has a FIMER Institute which specializes for leadership in interprofessional education, collaboration, and practice. One of a kind in India. And I belong to the first batch of the Manipal FIMER Institute. So this integration of public health dentistry, preventive dentistry, and interprofessional education has actually been in Manipal, and we have experienced it. So that is the reason I would like to strongly propagate the concept of interprofessional education, collaboration, and practice for enhanced community oral health. IPE, IPC, and IPP has received a lot of focus, not just in community activities, initiatives, and people coming together, but also through evidence-based literature support. We are having more and more of evidence getting gathered that these initiatives are actually holding substance, and it's making a pivotal role in changing outcomes for the patient, who's actually the center of all these activities. All these discussions, all these activities which we are going about is with this one particular component of improving life for the patient. So that is the central component of all these activities, whether it's a school of health, school of public health, school of dentistry, school of medicine, nursing, physiotherapy, whatever it is, whichever health professional we are all in, the center of all these activities is still the patient. That individual patient feeling better, that individual patient's life getting better is the focus of all these activities. When we talk of interprofessional education, collaboration, and practice, there is huge respect for the Canadian Interprofessional Health Collaborative, which actually gave us these guidelines. The CIHC Competency Framework for Advancing Collaboration was the landmark meeting document agreement which actually set the stage for all these activities. We've been very privileged to have a very senior mentor guide us at Manipal, who holds Dr. TMA Pai Chair for Interprofessional Education, Collaboration, and Practice, Professor John H.P. Gilbert, who has actually given us the foundation, along with Dr. William Burdick and Dr. Siraj Ali, who set the foundation for these initiatives. About 220 fellows have graduated from this institute over the past 10 years, and we have seen remarkable progress in various programs and community initiatives. When we actually look at what is it that we do in interprofessional education, collaboration, and practice, we see that role clarification, team functioning, collaborative leadership, and interprofessional conflict resolution get a lot of priority and focus. When two people working in silos for a long time have actually come together to say hi, to share a cup of coffee, and to see what is it that they can discuss and how they can make things better for each other and for the patient, there are high chances that there will be a severe conflict. I think different, you think different. No, that is not what I think. That is not the way our department works. That's not the way our institution works. This is normal. These things are to be expected normally. And when there's so much of a difference between two individuals, you can imagine how much of a difference there will be in the settings in which each person works. And how do we join hands to make things better for the patient? That is one area where you can have issues, and interprofessional conflict resolution is something which has to be addressed very carefully. But much before that, what is the contributory role of each individual, the specialty, towards interprofessional commitment? That is something which has to be seen. Practitioners understand their own role, their limitations as well, and the roles of those in other professions, and use this knowledge to establish and meet person or close ones to achieve community goals. Practitioners understand the principles of team dynamics and group processes to enable effective interprofessional team collaboration. Practitioners work together with all participants, including persons, close ones, to formulate, implement, and evaluate care and services to enhance health outcomes for the patient. And they actively engage self and others, including person and close ones in dealing effectively with interprofessional conflict. So this needs a little bit of flexibility. In the sense, we need to allocate time for interprofessional education, collaboration, and practice in our own curricula. Whether it is the medical curricula, or dental, nursing, pharmacy, physiotherapy, whatever, we need to allocate time. So there's something called as a RIPLS, Readiness for Interprofessional Learning, is a concept which has really gained respect over the past 8, 10, 12 years. So when this is used in different curricula across different students, nursing students are very eager to know what dental students can actually do. Medical students are very excited to know what pharmacy, physiotherapy students can do, and actually how these people can come together and make life better for the patient. Until this particular concept received support, they were all working in their own directions, and they finally meet. And in many places across the world, hospitals are across areas, and very rarely there is interaction between disciplines. Until and unless there is some common together meeting, people are engaged, people are busy, running their own lives, running their own departments, but there is very, very little interaction between specialties. Medical professionals do not know anything about oral health. Oral health professionals are not in the know of pharmacy, physiotherapy. Dental professionals are to know what extra services and training nursing students have undergone. Medical professionals need to know what is it that each specialty can offer. So that sensitization, communication patterns have to receive that particular focus, and that particular attention and time allocation has to be made, even in their own curricula, so that medical students during their training itself know that these students, these other specialties can actually add value to what these people are actually advising the patient. So that internal referral, cross-referral is absolutely required. It's very, very essential, that enhances the quality of life of the patient. Interprofessional collaboration basically looks at a partnership between a team of health providers and a client in a participatory, collaborative, and coordinated approach to shared decision-making around health and social issues. So it has the role clarification, interprofessional conflict resolution, collaborative leadership, and team functioning. So when you have, say, 4 or 5 specialties coming together to provide comprehensive care for the patient, who is going to lead the team? Each specialty, that person has been working in that particular area for 20 years, 30 years, and he's considered as a leader. So with another specialty, there's another person who's been working and that he's a lead in that specialty. So who's going to lead this interprofessional team? That is something which has to be addressed. How do we talk about it? How do we go about it? And if things are going right, great, the whole team gets appreciation. But what if something goes wrong? If the patient sues the whole team, who's going to be accountable? Who's going to pay? Who's going to take the discredit? Who's going to be held responsible? Again, that needs accountability. Because of these issues, you need that sensitization and training to establish education, collaboration, and practice, which actually adds a lot of positive support for total and enhanced patient health outcomes. Interprofessional projects are a delight to everyone concerned, as it has the potential to add tremendous value to one's quality of living. Interpersonal and interprofessional relationships contributing to enhanced community, physical, mental, and emotional health. Having said yes, these things are excellent, but they are high energy fields and demand careful attention to the details and close cordial communication with all concerned faculty and support staff to areas where they can contribute, how they can make things better, and how they can actually improve things for the patient. I present a bird's eye view of a few projects which actually were supportive in improving health outcomes for the community. Tobacco cessation is one area which has been very close to my heart. Been pursuing it for the past, I should say, 19 years. When we started working in India to form a network of healthcare professionals who are really interested. So now we have a TC Alliance, a Tobacco Control Alliance in our country, where about 175 of us are in touch with developments in each state. When we started off, there was no mandate to have a tobacco cessation counseling facility in all the dental institutions. We started thinking about it because dental professionals are one of the first professionals, healthcare-wise, to see patients and spot the stains of cigarettes on the incisors, molars, see the changes in the palate, and they're able to identify even if the patient is saying that he or she is not using tobacco. So we come to know quite easily that this person is actually smoking or using tobacco. Then you had the use of carbon monoxide breath analyzers, which came in actively. We started using that. We started pushing this objective through our association, because I'm also a member of our association head office. We have a specialty association called the Indian Association of Public Health Dentistry. Like-minded people started talking about it. Then we convinced the regulatory authority, which is the Dental Council of India, to have a mandate. We have 330 plus dental institutions in the country. 330 is a big number. But there was no mandate to have a tobacco cessation counseling unit in all the institutions. We found it as a starting point and we pushed it aggressively, and it became a law in the sense it became a mandate and it became first on the inspection list whether this particular institution has a tobacco cessation facility or not. What we did was a success. Most of the institutions had to comply, and then the medical council woke up. The NMC, earlier it was called the Medical Council of India, now it became the NMC. So they woke up and said, the Dental Council has done well. Why should we not make it compulsory across all the medical institutions? So 6 months back, we achieved this in 2018. 6 months back, there was a mandate for all the medical institutions to establish tobacco cessation unit compulsorily in all the medical institutions. So they had inauguration, online inauguration, 724 medical institutions in the country were asked to set up a tobacco cessation unit facility. This is one area where you need to carefully integrate, communicate with specialists in psychiatry, clinical psychology, community medicine, general medicine, ENT, oncology, and make sure that there is a support unit. So tobacco cessation as a subject is not a one faculty or a one specialty area. It has to be integrated with quite a few people who are actually providing a very supportive role. And we were fortunate to receive support even from the National Tobacco Control Program, which was running from the government side in our own district. So there was a free supply of NRT lozenges, nicotine replacement therapy lozenges, at a subsidized rate for the patients. So patients need it. There is a free supply from the government. There is a mandate from the regulatory authority to have it as a part of all institutions, and the patients get the benefit. So this took time. I should say it has taken about 10 years for us to reach this stage. And it's one area where we saw associations pitching in, other specialties coming in, medical professionals voicing out, and we had to actually navigate this particular area. But now we have a tobacco cessation facility in the ground floor itself, in our institution as well. And we see quite a few communication issues. We do come across interns getting trained in the specialty. We come across young faculty, postgraduates getting trained in this specialty, and they've learned the art, in the sense, the nuances of communicating with other specialties and taking things and making things better for the patient. There are accountability issues, and there can be cases where you're actually having a conflict. Just to cite one particular example, oral surgery sees road traffic accidents quite often. Trauma cases, oral and maxillofacial surgery, they do find patients who met with road traffic accidents. But when you have patients who are not willing to accept blood transfusion, for example, the Jehovah's Witness, they're very particular about not accepting blood from another person. If the case warrants, if the case needs blood transfusion, the medical opinion is, say, blood transfusion is required, suggested, advised, and the parents are not in favor of it because of their religious beliefs, then there can be a conflict. We have had cases where the child actually needs blood transfusion, Parents did not want. The doctor went ahead with blood transfusion because he wanted to save the child. And the mother disowned the child and said, you can give the child for adoption.
Oh.
It is an international standard case, which is recorded. In the sense, these things can happen. So you have interprofessional conflicts. You can have cases where ethical issues are being addressed. You can have issues which are very sensitive. So these issues have to be handled carefully and very sensitively. The supplementary mobile dental unit also was one of the projects. It took us about 2 years to conceptualize, fund, as well as get all the support teams in place to organize the mobile dental unit. Quite useful in serving remote areas, coastal areas, and inaccessible areas. The evening dental clinic was another project which involved a lot of interprofessional and intra-professional opinions. Within our own specialty of oral health, we sometimes need to convince clinicians, orthodontists, prosthodontists, endodontists, what is it their role is and how we can navigate this for better patient outcomes. Because this is, when you have a comprehensive unit involving multi-specialties, you need to make sure that everybody's opinion is counted and the patient is actually explained well and things are addressed well. We have had multiple programs with the district health office involving school teachers, the fishing communities, school dental health programs, community health screening, as well as various MOUs, in addition to on-campus treatments and special schools where we have interacted on priority and sensitively with those selected groups. Just to wind up, I'm in total agreement with my respected previous speakers who have actually addressed most of the background issues. But when we are looking at integration of oral health with primary health care, there are strategies, there are proven strategies for better implementation, better integration of oral health with primary health care, which includes risk assessment, oral health evaluation, preventive intervention, information education communication, and fifth, interprofessional education, collaboration, and practice. So this is a standard strategy which has been proven, and this is the advice made by different bodies and different health organizations. So I just leave you with my sincere acknowledgements and thanks to Professor John H.V. Gilbert and Dr. Siraj Ali Muhammad, who are actually the pioneers, in addition to Dr. William Burdick at the Manipal Fimer Regional Institute, which gave us the guidelines and built capacity in relation to interprofessional education, collaboration, and practice for our whole country. I think this was a one-of-a-kind institute, and this actually made a difference. So that was my presentation and overview. Thank you so much.
Thank you so much, Doctor. A person, as you were talking, I was just thinking about how the reason why I became a dentist is because of interprofessional collaboration. When I was growing up in Nigeria, I had a cut on my knee.
Okay.
And it wasn't healing. It was taking a long time to heal. And I went to the federal clinic, and the physician's office was right beside the dental office. And the dentist just kept walking into the room. And he came, as the physician was checking me out, he kind of was like, "Hey, I'm a dentist." Till then, I'd never been to a dentist before. So I was kind of like, "What are you? Who are you?" And he kind of was like, "Have you ever been to dentist?" And I was like, "No. I'm here for my knee." And he kind of was like, "I'm just going to take a look and see what's going on." And at the time, I had a malocclusion really severely. And he was like, "Oh, there's someone who can fix that." And I was like, "Oh, who?" He was like, "An orthodontist." And then that kind of started my journey towards then becoming a dentist. So it really is crucial, collaboration. Our last speaker for this session is Dr. Olayinka Adekugbe. And she has a distinguished career in global health. Dr. Yinka has held several various roles within renowned organizations, including USAID, the Clinton Health Access, the WHO, the Catholic Relief Services, and Pro Health. And as the executive director of the Oral Health Program, she spearheads initiatives providing preventative dental education to underserved populations in Missouri, Iowa, and Indiana. Dr. Yinka earned her Doctor of Dental Medicine from Boston University, her Master of Public Health from New York University, and her Master of Science in Dental Public Health from NYU. Please help me welcome Dr. Adegugbe.
Hi, good morning, everybody. I'm so glad to be here. And listening to everybody speaking, I think I'm in a safe space. When people ask me, what do? I consider myself somebody that has a portfolio of career. So I don't do one thing. I've done different things at different times. And I think listening to her, the periodontologist, and where you are a clinician, I'm a clinician now, and I'm wearing my public health hat. And somebody is telling me that Dr. Adekugbe, the buccal flanges, the denture is not sitting well. And I'm there rolling my eyes that, well, lots of people don't even have access to feeling their decay, and you're here telling me the denture is not fitting well. So sometimes it's just making that you wear different caps at different times, and sometimes you really want to tell the clinicians that there are a lot of things happening in the world and denture not sitting well, and there are bigger issues out there. So thank you. I'm so glad to be here today. So today I'll be talking about one of the work I do in Nigeria. Like I said, I do different things at different times. I think one thing that has helped me in public health dentistry and what I do is after graduating from dental school in Nigeria, I actually stepped out of dentistry for a while, for like 8 to 10 years while I was doing mainstream public health. And that kind of like gave me the opportunity to understand health system strengthening and advocacy, that we don't have to do public health alone. We really need to work together within a team. And coming back to dental public health now, I think it has made me more dynamic and understanding the issues and ability to address those issues better. So I'm Dr. Olayinka Adekugbe. I'm presenting the work I'm doing in Nigeria in an organization I established in honor of my parents, Comfort and Patrick and Comfort Adekugbe Oral Health Program. So it started like a pet project, but sometimes a pet project becomes a bigger project and you do all these things. So basically what we're trying to do is improving access to dental services by engaging community structures, the Nigerian experience. I wouldn't say this was what I was trying to do. I was just following my public health passion. And sometimes people like Sunjay talk to you and you're like, it's like, okay, this is what you're doing. And you're like, okay, this is actually what I'm doing. So sometimes I don't start out this way, but I end up here. So just engaging community structures and what we do in Nigeria. The background, I'll talk about the oral health programs in Nigeria, our school outreaches, what we've done in Lagos, Nigeria, engaging stakeholders, working with governments, working with data insights, urgent dental needs, future plans, and basic conclusion. So we do know that oral health is a big problem. All over the world, sometimes having worked in Nigeria and working in the United States, you could see that disparity is the same, and public health is really the first principle. Is always the marginalized are the most affected, they are the most vulnerable, and anywhere you go in the world, you see it plays out. It's still the same thing that happens it's still the same framework of public health that happens anywhere you are in the world. And Nigeria faces a lot of oral health challenges peculiar to limited infrastructure, professional workforce, and low awareness. And what we want to do in oral health program is to see how we can collaborate with community structures to address some of these gaps that is oral health, and what we can do to make things better. So what we'll do is the oral health program in Nigeria, our initiative was to increase awareness and services through community engagement. We focused basically on school-based screening program, outreaches, partnership with government and private sector. Because of my experience working with government in Nigeria, I worked in Save the Children and had a stint with WHO Nigeria. So working with government for me is critical in what I do, because I do understand the role of government in preparing the right environment for project implementation and in terms of sustainability. So if we do all this work in the community and we don't have that engagement with the government in terms of creating structure, then most times we are just working downstream, and upstream things are not changing, and we keep having problems downstream in terms of what we do. So the first school outreach was to increase awareness and just tell the students how to practice good oral hygiene. So we had the issue of caries, children needing caries and grossly broken down tooths. This was the data from our school program. We had about 128 students participating in the program. 40% had good oral hygiene there, and we had decay. 75% of them actually had tooth decay, and 20% needed extraction of their tooths. This was our first site in Abuja, which is the Federal Capital Territory in Abuja. We also had some outreaches. We had an outreach in Lagos, which was to provide free screening for widows in one of the communities in Lagos. This was important because in working based on the base of the school-based program, I was thinking of a way in which oral health could be like a wraparound activity, because when I was working in HIV in Nigeria, we did a lot of that, in which we'll have a central intervention and we'll begin to wrap other intervention around ongoing intervention. So this particular intervention had food distribution that they did for the women, like household food security. So what we're trying to do in this intervention was to see how we could embed oral health into household food distribution, such that they are coming for their food normally, but we are adding another extra layer, which is oral health services and prevention and education. So this was done in Lagos. We extended free dental screening for widows and their children. This was to see how we can include oral health in ongoing services. What we've seen in working in Nigeria, we like I said, engaging with government structure for me is critical to program implementation and seeing what we can do. So in as much as we do all these programs, we've also tried to create avenues in which we could work with the government, like the Federal Ministry of Health, the National Primary Healthcare Development Agency, the National Association of Pediatric Dentists, and churches, local firm, and philanthropic organization. Just to say that Nigeria is structured in such a way that the federal sets policy, and that is what the federal does. They set policy, they set guidelines, so they don't implement. But at the same time, they have this National Primary Healthcare Development Agency that does implementation at the primary healthcare level. So it's just the ability, how do we connect the policymakers with the implementers, with the National Primary Healthcare Agency. And we also have these institutions like the National Association of Pediatric Dentists. How can we all come together to speak the same language and speak the same voice? So we've been trying to work with these various organizations, which I would say has not been particularly easy, also because of political will and political commitment. And what we've seen is, especially for National Primary Healthcare Development Agency, number 2, they have said they have this routine immunization, polio vaccination, that they have people that go and vaccinate those children. That will it be possible to add oral health as one of the package of services that these people they have that go, because Nigeria is really very good with polio and vaccination. So can we add oral health as one of the things, the community mobilizations and polio, the people that deliver polio, could they deliver oral health intervention as part of this intervention? But the question is, what what level of intervention will this particular set of people be able to provide? Can they provide fluoride vanishes? Will they be able to do the rinsing for the children? Vis-a-vis, what does the Nigerian Association of Pediatric Dentists think about this in terms of the bandwidth of tax sharing or tax shifting? So you begin to have those kind of problems and those kind of issues, because when we had the meeting, the representative from the Nigerian Association of Pediatric Dentists actually said it there that you have to be very careful the level of services you want to tax shift to this level of community healthcare workers, lest they go and they say they are dentists. So these are the challenges we've had in engaging with stakeholders and other partners. So, like I said, in working with government structures, we've looked at how can we integrate oral healthcare into primary healthcare. We've thought about training community healthcare workers on the WHO oral healthcare handbook, which has also been challenges in terms of funding. Just to say that everything that is done on this project is done by personal funds. So most times I do it off personal funds. So it's not as if there's like a big resource. We just do things based on passion. So we also raised a proposal for establishing a oral health technical working group to influence national policy. I wrote a letter to the National Primary Healthcare Development Agency, and there was no response, but we are hoping that we'll get a response to them. But what has been critical in my mind is to see how we could embed oral healthcare into routine immunization and primary healthcare services and polio, because Nigeria is known to have done well in polio immunization, routine immunization. So for those places where we have successes already, can we layer oral healthcare services as one of the intervention, or to pilot it and see where we can go from there, supporting research, monitoring and evaluation, and reporting. So basically our statistics, based on what we've done, we've been able to screen over 400 children from 2022 to 2023. 60% of them required prophy, like they call it in America, or in Nigeria we call it scaling and polishing. So just trying to change my lingo. So scaling and polishing or prophy, depending on the part of the world you're from. So 30% will need restorative and 10% of them need extraction. I wish I could do more for these children rather than screening. I was talking to Dr. Abiola today that sometimes you actually feel bad when you just go and you screen them, and in your head you're asking yourself, what next am I going to do for these kids in terms of service delivery or promoting access to care? But I hope we get there, although of late we've been trying to provide prophy during our outreaches for the children at the minimum. But we are hoping that as we take things further, we'll be able to do some restorative work, and at the best have prevention as treatment, where these kids are having access to fluoride, regular fluoride vanish, fluoride rinsing, so that they don't come here needing restorative feeling. And I really hope we get there if we have the right institutional structure to support what we do. Urgent dental needs, like I've said, expanding access to preventive services. I think one thing that is also paramount in my mind is training of community healthcare workers for community-led intervention. Looking at all the programs that have been done in other places about the school-based toothbrushing program. I think that was quite challenging, I think, and that's something that we can replicate in the schools where we work. So this is one of the our volunteer dentist that works with us in Nigeria, providing oral health information to the kids. We hope to keep scaling up to other states, or probably strengthening existing intervention that we have going on, and also looking forward to have more partners for more sustainable impact. So based on what we've done in the little advocacy we've been able to do in Nigeria in terms of working with the government structure, I think it's always gladdens my heart when I see policy documents and I see pictures of our projects right there in the policy documents. Number one, it shows me that even if we've not seen results, we are being recognized and we are being acknowledged. So these are recent policy documents in Nigeria that we helped them, and it was also it gladdened my heart that our pictures could be used in this policy documents. So I'm hoping that they are paying attention. If it's one of the things I learned in advocacy is sometimes you might not get your advocacy results, but you get notified. So this is like, okay, we are paying attention to what you guys are doing. We see you, and we hope we'll work better in the future. So that's really very good. And we also had an invitation in 2024 to be part of the National Oral Health Week ministerial briefing, which was done in Nigeria. These to me are little baby step successes that they are paying attention and they would want to in the future. We are hoping that we'll be able to engage more with the government and engage more and have that sustainable oral health intervention. I must say, working with government anywhere is not easy. Making policy change and doing advocacy, sometimes it's easier for we public health programmers to just go to a certain state and do something small and count our successes, count the number of toothbrushes we give them. But to make that change at the policy level is a much more difficult task for us to do. Also because you have people, you have government, you have advocacy, you have it's political, it becomes political and making those changes. So we just need to hang in there and keep doing the work, keep up the good work, like one of my professors will say, and hoping that we'll be able to move the needle in times as time goes by. So we do know that oral health is often overlooked, is an overlooked aspect of community health, but we understand that we cannot do it alone. Multi-sectoral collaboration is needed because we need to tell the community-based organization, the CSOs, they do policy better, they know how to do advocacy better. So it's to empower them with the information on oral health so they can be our voice, because dentistry is a lot, I must say. So sometimes combining clinical dentistry with public health dentistry and now trying to do advocacy and CSO engagements with all that, it just becomes very... So what we can do is to train the CSOs to be advocates so that they can keep talking about the need for oral health. So we are hoping that we'll have more funding. If we don't have more funding, we have ourselves to do our work, and the passion will just keep us going in engaging to improve oral health outcomes in Nigeria. These are some of the pictures in some of our projects. Like, one thing I would like to say is that I've never, my model for this intervention was never been in Nigeria or been in the middle of implementation. It's just to give strategic direction. And I'm really happy that people are doing this project, which is not revolving around you, such that if you step back, they can continue to do what they are doing. So this has been a huge and tremendous success to see that people are passionate and they are going ahead with the work, even when you are not there. So it's not about Dr. Adehugbe, is about the people seeing the need for their people and continuing with the project. These are some of our projects. The Zoom link was when we were trying to connect the dots with WHO Congo to see how we can create the working group for oral health. But like I said, we had a lot of, well, we are making progress. We'll get there. We hope that things will get better. And we do know that is advocacy. It's a lot of baby steps. So these are like some of our picture gallery, what we do. And today has just been a full circle moment for me where everything I've done is coming together. So to my dad, I'm sure he's upstairs and saying, move on, oh daughter of mine, my mom that's taught me resilience, my siblings, everybody that I've worked with in times past, and people I intend to work with in the future. So thank you so much for this opportunity.
Our sincere thanks to Dr. Raskin, Dr. Zaire, Dr. Khatib, Dr. Adekwe, Dr. Adeni, and Dr. Laste for your very insightful, encouraging, and just reminding us that with dentistry, especially global oral health, it's not going to be a one-size-fits-all, and that all the steps that you do in interprofessional collaboration, in prevention, in refugees, and just in community oral health programs, that everything moves the needle further. And just thank you for the work that you do.
Right, I realize that we're a bit behind. And I see, thank you, Dr. Cole and Dr. Wu for being here. We're gonna go through just a couple of things, and then we're gonna have just a very quick coffee break, a stretch break, and then we will get into patient safety momentarily. So just a little bit of patience here. I just wanted to pull up, there's been some questions about the Padlet. So let's see if I can pull it up. And I just want to explain how that works. Dun, dun. Yeah. Okay, so you can scan this. If we can help get the link back on the Zoom chat, I think it's there. But so you can go to this and you can find, if you scroll down, and I can't do this because it's a screenshot, but if you scroll down on this website, there's a plus mark. And on that plus mark, you can then add a document, a photo, a picture, or just a question. So if you have a question specifically for Dr. Raskin, you can just post it right there, and we will make sure that Dr. Raskin addresses that. We are going to go into a little bit of a breakout session after lunch, after our health economics group, and we will have these various breakout chat groups, writing sessions. So workforce, interprofessional collaboration, innovation in tech, policy and advocacy, global oral health equity, and humanitarian crises. So for those of you who've been here for the 2 days, you are quite familiar with this. And kind of the task is to, you'll spend a few minutes just recalling memorable quotes. They won't be verbatim, but that's okay. We'll summarize some lessons, propose some next steps, because as we've talked about, we've had plenty of calls, but no action. So we want action and ultimately draft a document. We'll outline the structure. We'll have a note taker or note takers, and they will put a lot of these notes in the Padlet. And similar to what we did yesterday with Dragon's Den, there will be kind of we will determine the time depending on how late we're going. It might be 2-3 minutes, and you'll come up and be the rapporteur and discuss 2 minutes. Boss says 2 minutes. So thanks, boss. And so it's going to be a speed run. It's going to be really difficult. So, you can't go like I'm doing right now, umming and hawing and whatnot. So let's can we take like 5 minutes for a stretch and coffee? I know some of you have been taking breaks. Let's do that. And we'll get, out of respect for Dr. Cole, Dr. Wu, we'll get them on, and we'll invite them for lunch, of course, and we'll get through it. So please take a break. Please take a stretch. Zoom people, a little patience.
Awesome.
Yeah.
So I now.
Should be feeling obvious.
So it's starting.
Oh, I think Shopee is.
You know, it's. Dating or.
My buddy from Panama. Yeah.
Wednesday. I live in Suffolk County.
We had quite a bit. Yeah, it was fun. Yeah, we have about 20 in this kind of international dentist WhatsApp chat. Which is this guy right there.
So we provide. It's fine.
The mouses.
I no longer understand, there you go.
Yeah. Provider, which means we like webinar to bring together, like share, discuss, problem solve. They're not working entirely, but
I can move, whatever, yeah.
but it's a pleasure. They're not.
Greetings, everyone in Zoom land. Welcome back. Thank you for your patience. We're definitely behind. So we have a little surprise guest for you, and this is going to tee up very nicely what we're going to talk about as far as patient safety and some interesting concerns that we haven't been able to
I mean, they're doing
discuss.
thorough.
So let's see if this works.
Hi, I'm Dr. Eka Perez Franco. I am an orofacial pain specialist. I am diplomate of the American Academy of Orofacial Pain. I'm the director of the Center for Headaches, Facial Pain, and Temporomandibular Disorders at Pacifica Salud Medical Center, a Johns Hopkins Medicine International affiliated center in Panama City, Panama. I am the former president of the International Association for the Study of Pain, the Panamanian chapter, and I am the president of the Latin American Academy of Facial Pain, Temporomandibular, and Sleep Disorders. I want to congratulate the organizers of this event, the Global Oral Health Symposium. Events like this one are so necessary to raise awareness among health professionals in order to talk about the importance of teamwork, the need to strengthen the link between the different medical and dental specialties, and to discuss and understand the relationship between the orofacial health and the general health and well-being in our patients. In Latin America, there are very few orofacial pain specialists, a specialty that has become the bridge between different medical specialties and that unites different health professionals, such as neurologists, ENTs, rheumatologists, dentists, physiatrists, among others, and helps translate, understand, and manage pathologies that occur in the craniofacial region and don't know anatomical limits. We need to encourage training and education and data collection in order to have more research in the field and increase the impact in public policies and government support. I'm sending you a very, very warm hug from Panama. Have a wonderful day.
Thank you, Dr. Perez Franco. So quickly, just as far as pain, this is defined as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So this is an interesting sort of twist in the evolution of the definition. This can be a personal experience, not strictly from sensory neurons. And there's really this kind of movement to respect people's pain. There's this kind of a physical pain that we think as clinicians, but then there's the emotional component. And the way different people describe it is incredibly challenging. This has been vexing, poets and philosophers and such for centuries. So this aspect of respecting people's pain, also realizing the nonverbal expression of pain. So for folks who are unable to communicate it, we used to think that children, infants don't experience pain. And so the attitudes for circumcision pain is a little bit different. And so this is probably the first time you've gone to an oral health conference and somebody brings up circumcision, I guess. But it's all related, isn't it? So facial pain, orofacial pain, is a fairly new specialty recognized at the end of March 2020. I think I mentioned this yesterday. I'm sure you all were quite busy end of March 2020 doing something else, flipping classrooms and whatever else you were doing. Orofacial pain and oral medicine were these two that recently got recognized. And the reason I mention this is because this is very much testing the progression of what we assume the stereotype of dentistry. And this has been the challenge in institutions of whether it's at the School of Medicine or the School of Public Health. There are these different categories, as you can see. They can be complex, and the recommendation for the frontline clinician is that you do what you can do, eliminate or rule out oral and dental causes to pain. And if you still can't figure it out, then obviously you need to refer. The tricky part is figuring out whom you should refer to. Diagnosis is key, and we need to figure out how to recognize and refer early. As mentioned this morning, the biggest challenge is data. We have absolutely, I'm going to use the word poor. I would use a different word in other circles, but it's absolutely foul, the type of data that we have. And it really has encouraged just inappropriate treatment. So there's this urgent need. The National Academies of Science, Engineering, and Medicine put up this report in 2020. Again, nobody read it. To improve interprofessional education opportunities. Again, we're repeating the same things that we've already heard time and time again over these 2 days. We need centers of excellence for this area. Shameless plug, if you want further reading on pharmacotherapeutics on musculoskeletal orofacial pain. And our next presenter was a key author with this one. So a couple of parting thoughts. The NASM report noted that women are treated in male-dominated clinical spaces. So females are more likely to experience temporomandibular joint disorders, and all my attendings were older white guys. And so you could see that I was told that, well, this doesn't happen with Black people, but we just don't see it. Well, they're not coming to you because you're in certain areas. So if we changed, again, the diversity of our clinicians in our training programs, you might actually have a different outlook of your patient population. So we have this ongoing challenge with conflicting diagnoses, which we're going to hear momentarily, a very interesting story. Issues with patient abandonment. So if I do a certain type of treatment, like I've been brainwashed into thinking occlusal rehabilitation will cure all TMD. Well, if you don't get fixed by me, if I can't cure you, you're the problem. The patient is the problem. And you need to get out of my office, especially this is the private practice attitude. Please leave. Off you go. Don't let the door hit you on the backside on your way up. There are massive financial implications to this. Largest cost estimate is $120,000 Canadian. So you might say, well, that's what, 50 US? No, it's not quite 50, maybe 80, 90,000 American. It's a lot of money to have your teeth reconstructed. And there's no evidence to suggest that this is going to cure your TMD, whether that's even the appropriate diagnosis. So obviously we get to loss in trust. We heard this morning. There's stigma. There's social isolation leading to all sorts of non-dental issues that we don't study. Reduced self-esteem, difficulties addressing nutrition. Routinely hear this prescription that, well, the cure for you is a soft diet, and you're going to do this for the rest of your life. Now, this is, are you kidding me? At 20 years old, for a teenager, you're going to tell somebody soft diet for life. That's it. So no steaks, no, okay, maybe for the vegetarians, that would be fine, but no carrots, no salads, no nuts. This is not an appropriate recommendation. And that's part of day 3 next year, where we get the nutritionist to explain what are the implications when you tell a 20-year-old soft diet nutrition for the rest of your life. Intimacy. This is something conservative dentists really don't want to talk about with open operatories. With MAGA dentists, we're not going to talk about oral sex or anything like that. So forget about that conversation. And then there are major implications as far as thoughts and attempts of suicide. Again, we get no training in that in the 4-year dental curriculum. That's for residency. That might be the oral and maxillofacial surgeon residency program. They will definitely get it. Orofacial pain, we get that. Perio, I don't think you get anything about this. So with that, these are our 2 speakers. I'm going to introduce Dr. Cole first, and then I will introduce Dr. Wu. Shannon Cole is PhD, currently the senior medical writer and editor at Johns Hopkins University School of Medicine, the Armstrong Institute for Patient Safety and Quality. Shannon is the, as I said, senior medical writer and editor at the Armstrong Institute, where they facilitate organizational communication and dissemination efforts across research and clinical operations. Dr. Cole completed her doctorate in biopsychology at the University of Michigan and postdoctoral fellowship in the Department of Anatomy and Neurobiology at the University of Maryland School of Medicine. As a patient, Dr. Cole has extensively sought the opinions of dentists and academic orofacial health professionals in the greater Baltimore region and in the state of Maryland regarding temporomandibular joint disorder and orofacial pain to better understand evaluation, surgical and non-surgical treatment options and procedures and referral structures within the state. Dr. Cole, thank you for being here. Welcome.
Thanks very much for having me. That's a nice way to say I've had a lot of trouble figuring out what is going on with my mouth. One more. Okay, good. So this is the title of this is actually the title of our sujet of my paper, Patient Safety and Quality Improvement in the Care of Musculoskeletal Orofacial Pain. I thought about coming up with an alternative title. Why does my face hurt? Why is it so hard to figure out? And what do I do about it? So jokes aside, in actually trying to treat my own issues, what I found was just this maze of hoops and who do I talk to and can anyone give me an accurate diagnosis that spanned probably the better part of 7 years. In the interest of time, I'm going to have this in two parts. So part one is essentially me as a patient/patient advocate talking about my own experience, which I attempt to compress about 7 years worth of information into 7 minutes. And then the second half will be sort of these lessons learned as I joined the Armstrong Institute partway through this journey. Also, in the interest of time, I'll probably have more text than I actually get through. If y'all want to talk to me afterwards, or if you want any resources, please reach out. All of it's online. So, chronic TMD is a complex musculoskeletal disorder that can have multiple aggravating factors contributing to its onset and chronicity. Estimates on prevalence of TMDs range with different terminology, definitions, analytical approaches, and data collection. Notice we have it broken down here into 3 general kinds of TMDs, but even within those, there are probably different subcategories. So what I'm saying is there's not just one TMD. There are many. This is a blanket umbrella term that frequently gets the wrong treatment because of incorrect diagnosis. Double dipping from that list that y'all saw, just take 10 seconds. Take a look at this. This is what people go through when they have some form of oral pain or musculoskeletal orofacial pain. I've had quite a few on this list, not all, but enough that it has caused some major life impairment. So just take 5-10 seconds. You probably have had some of these yourself without realizing it. This might seem dramatic. There are people who roll around on the floor in agony because their jaw hurts. It is a major life impediment. So this is my face today. In case you don't know, we all have a skeleton inside each of us. I started out with some congenital proclivities for jaw issues when I was quite young. Had a few hits on the noggin, which y'all probably figured out already. Under age 6, age 7 to 12, I had braces, didn't take. Age 19 to 23, I had first generation Invisalign with first premolar extraction. I also had wisdom teeth taken out. As it turns out, that's not such a good idea, but that's what they used to do. Age 29, the year I defended my dissertation at the University of Michigan, I woke up one morning, lost my retainer, and I have a locked jaw and kept playing with it until I heard a loud pop. What I know now is that was the sound of my joint getting blown out. I had to relearn how to speak in order to defend my dissertation. Notice the teeth missing. Notice the face has been compressed and pulled in. That is outdated orthodontia. So 2017, I had a replacement splint made by a family dentist. At that point, the grinding and bruxism from the difference in my jaw was so much, I actually bit through it. Normally, you have to take a hammer to that, or you have to put it in a pot of boiling water to cause it any harm. I then went to an orthodontist to see what do I do. He said I would need something called orthognathic surgery, and he said he could do it in 9 months. That is not what you want to hear, actually. So this is orthognathic surgery. Essentially, a maxillofacial surgeon will come in and they'll break your jaw in certain points depending upon your needs and advance the jaw forward. This is done to correct the bite. Sometimes it's done to widen the airway. Sometimes it's very successful. Many times it is not. I did not do this. That was 2017. Fast forward, I moved to Baltimore for my postdoc, and here's where we're going to try our very best to do 7 years in 7 minutes. So we already had, so this is the map of Baltimore for those of you who don't know. And please bear with me, this is rudimentary. I will do my best to make for it with information and showmanship. So on the left side, we have 3 categories. We have professionals that say, I need surgery, I need braces, or to go with conservative treatment. So in this first dot, I moved to Baltimore, and luckily Baltimore has one of the top-notch dental schools in the world at UMB. So I went and saw a dentist. She provided a splint. Didn't know if I needed surgery or braces. She also gave me muscle relaxers, which, as it turns out, that's not good for life productivity in a postdoc. So she sent me to another person who was an orthodontist who used to treat TMD. And he told me, unfortunately, that braces will not fix my TMD. And the best I could hope for is to manage the issues. He had no opinions on surgery at the time. Then I was sent to 2 more people. He sent me to an orofacial pain specialist who is wonderful. And she recommended that I try conservative treatments as best as possible, including physical therapy and a few other things. She also sent me to a maxillofacial surgeon who is excellent. And he recommended conservative treatment and PT and sent me on my way. Again, this is 2018 for those of y'all that see the year in the corner. So I went to physical therapy. Also, all these should be a little bit down, so I do apologize, but focus on the quantity and the category if you could. So they sent me to a PT up in Towson. He'd been doing this about 30 years, really good guy. And partway through the treatment, he took a protege who is also good and is also still practicing before he retired in 2019. That was good for me. Then 2020 happened, and I don't know about y'all, but I had a hard time getting a teeth cleaning during the pandemic. And so I reached out, said, hey, where do I go? So they sent me to a private practice guy. He's also very good, been in practice about 40 years, and talked to him about, hey, what do I do? And so he sent me to an orthodontist. And so then this orthodontist sent me to another person, excuse me. I was now sent to a new orthodontist and a new TMD specialist. And the orthodontist said, hey, I can't treat you because I don't know where your jaw is supposed to be. So he sent me to this TMD guy. This TMD guy has this splint thing. He puts it in your mouth and it'll level out your bite. And then essentially you're trying to hit a moving target if you don't know where the resting point of the jaw is, which is the correct way to do this. So then we had some recommendations. In 2020, I had a bite splint to use 24/7 or as much as possible. I want you all to think about having a hunk of acrylic in your mouth 22 hours a day, except when you're eating. In 2022, as I started to conclude treatment, they recommended I get a sleep study to see what my breathing pattern might be in case I needed a surgery. We hadn't mentioned surgery to this point. This was supposed to be the cure. Sleep study says no apnea, but I wake up 26 times a night. Guys, remember I'm wearing a splint. Yeah, that didn't get put together. So this is my joint. This is an MRI of my joint. The left one's on top. That popping noise is what the meniscus, for you, those in the know, that's basically a little piece of tissue. It shot out the backside. So it's bone on bone, which is not as bad as it sounds. And then on the bottom side, that's the right joint. It has some problems, but not quite as bad. Here's the splint. Imagine wearing that for 4.5 years, 22 hours a day. And if you don't do it, things get out of whack. At least that's what they tell you. There's more to that story. Okay, so I go to a maxillofacial surgeon here locally in town. Note the dots. I'm trying to show y'all a map. This is how dispersed all this treatment plan is. This is 2022. Orthodontic surgery will not fix your TMD and is elective. I didn't go back to him simply because he didn't look at me for the first 15 minutes of our visit. So I'm just going to cut on your face. You don't want to be there Tuesday at 2 p.m. But I respected his knowledge and I appreciated his input. So then we have a battle. We have a group of orofacial pain specialists versus the TMD specialist who's saying, hey, you're probably going to need this surgery. They say, absolutely not. They say use Botox to break a grinding habit. This is what happens when you are stressed. This is what happens when you have a splint in your mouth 24/7. And this is what happens when you have an uneven bite. They said use a night retainer and then continue physical therapy. Conservative treatment. Okay. So going back to, so you might notice this. Look at the question marks. When I brought this new information back to the orthodontist and the TMD specialist, they changed the story. They're not confused. They're saying absolutely not. This conservative treatment will not be enough. You need braces and you need surgery. And this is what I was told. This bite will plague you for the rest of your life. The TMD specialist said this is the widest your airway will ever be. And I typically reserve Botox only for people traveling outside the country. There's a couple other things I didn't write on there, which is the orthodontist told me he has not known one person who had that surgery that has ever regretted it out of 2,000. That is statistically impossible. And I know better because I know two that have regretted it. And then it goes on, guys. But imagine that amount of pressure when you're in a delicate situation. So because I wasn't the biggest fan of the first guy, they sent me down to a world-renowned orofacial surgeon down in Bowie. It took 8 months to set up that appointment. It cost $1,125 for that visit. And what he said is he recommended surgery, big surprise, to widen the airway, to improve bite and correct orthodontic work, and said the jaw cannot be properly placed without surgery. His fee was $66,000 out of network, and plus hospital fees. I did not do this, remember that. Excuse me, here we go. This is that same image you saw earlier. On the right, he took that profile. In the red, what you can see, that's my current position. And here's where he was going to move me in the blue. That's a 32 millimeter advancement. I realize many people here might not be dentists or orthodontists. That's a lot. The musculature cannot support, usually cannot support that kind of thing. And for those that don't know, there's a trigeminal nerve that runs through the bottom of your jaw. Basically, you're looking at a numb chin. However, look at that movie star profile. He'd also put in a cheek implant for $6,000. So then I go to another person I'd heard about who offered an alternative therapy. She recommended a proprietary appliance that includes an adjustment. Her profile is, and if I sound attitudey, these are people who are trying to help. I blame nobody. These are people that believe with conviction that they're doing the right thing. So this includes braces and an appliance, adjustments every 10 days, and working with 2 different cranial sacral therapists and a tongue clip, which look that up if you want to. I'm not going to talk about it. It makes me uncomfortable. That's $50,000 plus cranial and tongue clip. Essentially, that's a blank check for about $100,000. No Botox, though. She thought that was a bad idea. So that was good to know. I would draw your attention to this, though. Here's what she gave me for my money that was really informative. On the left side is the right condyle, and what I've highlighted is my left jaw. On the left side, that's with the bite splint in, and with the right side, that's with the bite splint out. Understand, this splint is pushing bone against bone, which is is done under the guise of holding the jaw stable, but in actuality, that's what you're trying not to do with the TMD case. See how many people I've already gone to, and there's all these differing opinions, and I've had to drive quite a bit and pay quite a bit of money. I'm very fortunate to have that as a luxury. So we're almost through this part of the journey. I then went to a person who specializes in integrative dentistry. They didn't examine my records, so they don't know what's going on with me necessarily. They gave me about 20 minutes of FaceTime out of a 2-hour visit in which I dealt with their family practice. They offered braces and orthotic to advance bite. They broke the retainer I came in with, which I had to fight with them to pay to replace. And they gave me a book, which was clearly their Bible, discussing how nutrition relates to oral health. And the second chapter in it, I believe, was the decline of Western civilization, the moral decline of Western civilization. People with conviction are the best or the worst. Yeah. Okay. So at this point, you're probably thinking something like me. Why is it so hard to get a straight answer? Why is it so hard to get consensus on TMD? And do I need this surgery or not? Can we, yes.
I didn't see anywhere where they sent you to a neurologist or did a study of head and neck pain and headaches and things like that.
You're correct.
Was there any point where instead of going to a dental person, dentist, oral surgeon, whatever, that they referred you instead to somebody outside of the quote unquote dental specialist? No.
Could you just summarize the question?
Sure. It was asked if at any point I was sent to a neurologist or someone to help with headaches or neck pain and things like that. Is that correct? That's summary.
Yeah, as a general dentist, if
Sure.
I had you as, and that's all I am as a general dentist, if I had you as a patient, long time before any of this, I would have sent you to a neurologist, head and neck pain. The patients that I've had who had serious what we thought was TMD, lots of times it was actually there are all sorts of headaches that can be diagnosed as TMD.
I will say two things and then I'm gonna have to move forward just for the sake of time. But no, I appreciate your question. Remember that this is not specified just for the sake of time and not mapping it out. This whole time I've been going to physical therapy at least once a week, acupuncture at least once a week. And then at some point down the line, got a craniosacral therapist. But no, I never had a neurology consult at all. So, but that was independent. Okay, moving forward. But thank you for the question, really. So I now go to another maxillary orofacial surgeon, who was the first one I saw. And excuse me. Oops. Okay, so I go back to this team of orofacial pain specialists. They say, don't get surgery and don't go back to that TMD specialist. They literally said, do not go back to this person under any conditions. Those are the kinds of people with conviction you like. So then I went to a final maxillary orofacial surgeon. He recommends surgery now. Unfortunately for me, /fortunately for me, he now described the procedure in detail. I thought I knew what orthodontic surgery was. It's hell. It's a brutal surgery. And he also at the same time countered the renowned surgeon's input. I brought the coordinate sheet that I paid $1,125 for, and he said, we don't do that anymore. We don't advance your jaw that much. What they do now instead is they align it to the posture and do a rotation, so it's not as bad of an advancement. Seems smart to me. Also, he's covered by insurance. That's good news. So this is what orthodontic surgery, these are the people who, at least in my opinion, probably need it more than I do. So essentially they break it in multiple places. You have brackets and screws put in. Here is also what happens to some people afterwards. And sometimes this swelling doesn't completely go away, y'all. It takes about a year to fully recover from this. So I am not quite that bad, and I'm very thankful for that. But they're recommending this. You have to drink out of a syringe. You have to take antiemetics because there's so much blood pooling down in your stomach. You'll vomit. And I did ask the surgeon, I said, what happens if I vomit while my jaws are wired shut for a month afterwards? He said, oh, you just lean forward. But in worst case, we always have wire cutters next to the bed. So do you think I want the surgery? Okay, so here we go. We're going back to this. Don't get surgery. Don't go back to TMD specialist. They recommend braces. And the TMD specialists in Northland say that's not feasible. You can't get braces. So there's still conflict even now in the year 2024. I had some health issues into the winter, and which prompted reconsideration of surgery, actually related to neck and back issues, because one of the things they say is it's going to affect your airway and the way you lean in your posture. Didn't do it, but I did still look around. And unfortunately, the original orthodontist is now retired. This has been going on almost 5 years with him. So this is in the last 3 weeks. No joke, y'all. That's why these slides developed the way they did. I found 3 orthodontists in my network of people I've curated. Orthodontist number 1 concurs, braces and surgery will be a 2-year process. Remember, the first guy said 9 months. Second orthodontist said 16 months. This one's saying 2 years. Second ortho is now saying it's a 3-year process. And then I get informed by the third orthodontist, who is excellent. He's the first orthodontist in this story in Baltimore. He said, actually, what we do is we pull your bite back and then we pull your jaw forward. So imagine you're widening that issue. You're going to feel terrible for the 2 years you do this. And that TMD specialist said, actually, most people feel a lot better once they get their braces on. They start sleeping better. So again, there's another inconsistency. So why is it so hard to get a straight answer? Why is it so hard to get consensus on TMD treatment? So around the time that I had that very unfortunate consult with the integrative medicine person, integrative dentistry person, and note, I'm intentionally being respectful and leaving names out. I happened to bump into 2 general groups of people. One was Sujay, who was doing his master's of public health here, and 2 were members of the Armstrong Institute, like Dr. Wu, and members of the Center for Diagnostic Excellence. And this kind of coalesced all at once. I was trying to think, why am I having so much trouble? And we found some answers. So again, in the interest of time, I'm not going to be able to read through all the text, but bear with me. I'll give you a general overview. So I happened to be working with Dr. Wu, and he gave me some editorials in the Journal of Patient Safety and Risk Management to read. Reaching Common Ground, the role of shared mental models in patient safety. It got me thinking, why aren't these people on the same page? How do we bridge that gap? Unity of medical errors. For y'all that don't know, medical errors, they happen. They happen quite common, and there are people working very hard at the Armstrong Institute and in many other places to stop that. And these aren't just about pain. These are life-threatening, severe errors. This article on Just Culture, it discusses how do we hold people responsible for the medical practice without blaming or condemning them. We need that in order to encourage people to talk about mistakes and techniques that work and don't work. There's more to it. And then this one, I point out last, staying ahead of the curve on patient safety. People are working diligently, but consider this quote. The clearest evidence from the in repeated study of the frequency of patient harm in acute care hospitals worldwide, the needle appears to be stuck around 10%. A recent study found at least 1 adverse event in nearly a quarter of all admissions in hospitals randomly sampled in the state of Massachusetts. So that's 1 in 10 or 1 in 25. And this is in settings where people get harmed and potentially die quite quickly. What do you think it is with dentistry, which is quite dispersed all over? It's having a tremendous amount of time getting people to talk, people to agree upon standard practices, and don't necessarily track the outcomes of patients. Probably, I would be willing to bet it's quite a bit higher. At the same time, I was reading some articles from the Center for Diagnostic Excellence. This is written by the co-director, David Newman-Toker. He has put forward a few different models for diagnostic excellence. I won't be able to go through this right now, but the point is, there are people that are making advancements in these areas for patient safety and quality improvement. And what I realized is, okay, if we're making these advancements and we're actually able to recognize now, this is just within the last year or so, about 800,000 Americans become permanently disabled or die annually across care settings because of diseases that are misdiagnosed. So if it's that high in these settings, how do you think we're faring given all the trouble I've just described to you? It might not be that people are being, how do I put this? In these sorts of settings, people might not die from TMD, but these are major quality of life impediments. People do go into septic shock and have to have teeth removed. They can be seriously harmed. So these are basic principles, guidelines, and areas of study that we realized could probably be applied to dentistry. So if it's this hard to prevent medical errors, from causing harm in other areas of healthcare, could it possibly be any better in dentistry? And so all this together inspired this paper. So we don't have time to run through all of this, but takeaway 1 and 2. The two biggest issues we were able to identify through literature review is 90% of dentists are in private practice. But the information from the patient safety related work is mostly done in acute care settings, hospital settings, clinics, things of that nature. Dentists are in private practice. They've hung out their shingle. They're not necessarily talking to each other. Their own name is on the door. So this creates a number of barriers to communicating when things go wrong and communicating what the latest and greatest techniques are. In addition, they don't share any electronic health record information whatsoever. So they're not even sharing their notes. It's really hard to improve if you're not talking to each other. It's really hard to improve, especially if you're not speaking the same language and if you have no incentive to report when problems happen. So one thing I've learned over the last few years is medicine is largely a relational endeavor. And I learned from a luminary in the patient safety field who retired a couple of years ago, the two biggest problems in healthcare are communication and access. That is seen here in dentistry. I won't have time to go through all of this, unfortunately, I do apologize. But what I really want to say is there are different cultural movements and different cultural initiatives that have shown great success within other areas of medicine, and namely safety culture, which really promotes the values of putting the safety of the patient first. That is key. And then within that is something called just culture, which is simply we're essentially rewarding people for coming forth and reporting adverse health events, issues, things that cause harm, but holding people responsibly without condemning or blaming them. We need to be reporting, otherwise we can't improve. And how many of these folks that I've talked about do you think are going out of their way to say, hi, I heard a patient, here's what happened, here's how we can stop doing that? And these sorts of, and removing these sorts of barriers encourages learning in this, would encourage learning in this area. Excuse me. We had borrowing a couple of slides from a colleague who was talking about the importance of relationships in medicine. And so here's a paper she pointed out. 3 reasons why relational issues are intrinsic to process improvement. You need to integrate multiple perspectives to develop a full understanding of the work process. No single individual has the capacity to solve problems in complex systems. Change efforts may initially involve some type of loss. And successful change requires commitment, not just compliance. So shared goals are important. That's going to be pretty hard to do in standard dentistry and health. This is a second slide she permitted me to borrow. Teamwork and communication are critical for the components of safe healthcare systems. And we can't just put a simple checklist in. We actually need to have a social and cultural shift. So how do you prompt this in dentistry? It's going to be kind of a hard thing because people are all separate. They're not interested in talking with each other necessarily. Now, sort of to sum up, just simply due to time, I'd like to point out, y'all might have noticed I'm a white male. I'm highly educated. I have good health insurance. I have income and I have access to healthcare professionals across this whole journey. This is about the best possible outcome for someone trying to get a straight answer about what's going on with them. It doesn't get much better than that. Excuse me. All in all, this probably cost what you've heard today probably cost about $18,000 to $20,000 out of my own personal pocket. People don't have that kind of disposable income most of the time, so just to wrap up, I hope I've done a decent enough job of saying, this is my journey, this is my experience. These are some patterns I saw in general medicine that I think could be applied to the field of dentistry quite easily. And I think that's why it's imperative that dentistry be integrated with medicine to the best of our ability. And it really can't afford to go on pretending that it isn't in medicine. And to be perfectly honest, I had a different slide here because I really think that both the rest of medicine and dentistry can learn from each other. I think that dentistry can learn the lessons that have already been acquired in medicine, but in this new field, in these applications, the rest of medicine can learn in an entirely new test bed. So it's not even a test bed, but a new domain. Personally, I think it's an untapped gold mine. And I strongly encourage everybody to have interpersonal communication as much, or interprofessional communication as much as possible. Just very quickly want to give a thanks to my spouse who has put up with me this entire time. Believe me, y'all, there's been a lot. My two PTs who have stuck with me the whole way, our director of research at Armstrong, who's also been a good mentor, Albert Wu, for being also just a wonderful help and resource. Two members of the Center for Diagnostic Excellence, David Russell, Megan Clark, and then the Armstrong Institute at large. And then also all of the people at the front desk and the hygienist and everyone who doesn't have a name on a website. These people are where you get the key information from. They're the ones who tell you who to watch out for. They're the ones who get you in to see the person when you have an emergency. They're heroes. So, yeah, thank you. Over to you.
That's okay. Thank you, Dr. Cole. Yeah, what'd you do here? No. You can go there.
Yeah, I can
No.
do for a few minutes.
No.
Oh, scroll. I see.
Yeah. I told you I try to make up for it with showmanship.
Yeah, wow, you had a lot of slides. Oh, we're done. We'll go. There we go. All right, fantastic. That I mean, I've never seen a talk like that. The mapping, that was brilliant. When you told me on the phone, I was trying to imagine it. I didn't quite get it.
There's a lot more than I showed.
I know. That was brilliant. You need to go on the road with that. That needs to be at APHA and maybe Academy Health, and there's a couple dental conferences I'd like to send you to. If I had a budget, if I had a $50 million for the Center for Oral Health here at Hopkins, I definitely fund you. So, Dr. Wu, I'm gonna have to talk to you afterward. So we'll move right along. Dr. Wu, as you can see, Dr. Wu has this fantastic bio that I will read, but I do want to say we are really fortunate at Hopkins to have just absolute stellar faculty. And Dr. Wu helped bail me out with the original 2023 inaugural Global Oral Health Symposium. Same challenge as this year, lack of funding and grant makers and toothpaste manufacturers that start with C. I won't tell you which ones, but you can have a guess. There's only two, I think. Saying, oh yeah, we fund these things all the time. We can fund. And then, you set up a meeting and they ghost you. They literally did not show up to a Zoom call that they organized. And they said, have your people call my people. I have no people. I'll organize it. Dr. Wu and the Cheshire, the Center for Health Services Outcomes Research, bailed me out and helped fund the inaugural one. So thank you, Dr. Wu. You might not remember. And Dr. Marsteller as well. Maybe Dr. Marsteller didn't tell you. Dr. Wu is MD, MPH, is a practicing general internist and the Fred and Juliet Soper Professor of Health Policy and Management with joint appointments in epidemiology, international health, medicine, surgery, and business at Johns Hopkins University. He is director of the Center for Health Services and Outcomes Research and the PhD in Health Services Research Program. He has worked in patient safety since 1988. He was senior advisor for patient safety at WHO from 2007 to 2009 and continues with this work. He is director of strategic collaborations for the Armstrong Institute, leads the online Masters of Applied Science in Patient Safety and Healthcare Quality, and is editor-in-chief of the Journal of Patient Safety and Risk Management. He coined the term second victim and is co-founder and co-director of the RISE Resilience in Stressful Events Peer Support Program. I welcome to the podium, Dr. Wu.
Thank you so much. And congratulations on this symposium. And I'm actually grateful to come on after Shannon because I don't really have any truly compelling stories. I'm sad to say that I've never had any really horrible experience with dental care. But I think that maybe one map can trump 1,000 words. And I'm going to talk a little bit more about some of the principles behind maybe some of the problems that Shannon has experienced, but also this problem in general for not just the dental profession, but for healthcare or even care of all kinds. So, the Dental Patient Safety Organization has written that dentistry, like other areas of healthcare, is inherently risky. And all of you, any of you probably know this better than I. How many of you have ever practiced in one way or another oral health or dental health? Incidentally, are any of you attached to the MPH program currently? I have a query for you at the end of my talk. There, in fact, is not as much research as one would like, and this gets again to infrastructure and structure. But clearly, there are things that go wrong in dentistry. There are two experts who've written about this in a resource which is called PSNet. It is online and made available by the Agency for Healthcare Research and Quality. That agency may disappear in the next several months. Hopefully this repository will remain, but perhaps the most common adverse events in dentistry, as well as we know, are after treatment pain, hard tissue and soft tissue injuries, nerve injuries, medication-related problems, and infection. And there are others. There are things with anesthesia occasionally and so forth. Perhaps misdiagnosis is a hidden adverse event. Rather than go into this, because honestly, I don't know so much about the particulars, maybe I could get you to share some of your knowledge later in the presentation. I'm going to talk instead about the history of patient safety. And this picture is, some of you might have seen this structure on your way here, or some of you work on this campus. And so it looks a bit like this. Things are a little less pastoral these days, and there's a little bit more civil engineering happening. But patient safety, in fact, has not existed as long as Johns Hopkins, or patient safety science has not existed so long. I think in some ways it dates back to a couple of things. One is a really landmark report called "To Err is Human" from the Institute of Medicine. Have any of you ever heard of this? So a few of you, for sure. Oops, wait a second here. That's interesting. It doesn't I'm going to now work from memory since the equipment doesn't want to tell me what is really on this slide. You can guess perhaps, but first of all, this report, which came out in 1999, was really the first widely publicized document that demonstrated that patient safety is an important problem. It is not caused primarily by individuals, and that it is systems that cause safety and hazards. This is any of you play jazz music? Do any of you, do you know about improvisation?
No.
Yeah, okay, well, here we go. Jim Reason is perhaps the father of safety science. He's at the University of Manchester. He is a little bit retired now, but he wrote a book published by the Cambridge University Press in 1990 called Human Error. I actually happened to walk by a bookshop in Cambridge and saw this in the window, and I said, I wonder what that's about. I did not pick it up at the time, but I ultimately purchased a copy. And he basically said that there are two ways to think about human error, period. Not in dentistry, not in medicine, just in life, because this is what humans do. But there are two ways to think about how errors are caused. And the first is the person approach. And this is the way our brains automatically work. If someone takes out the wrong tooth and you read about it in the paper, what do you say? What do you say about the dentist? What an idiot, yes. And we basically focus naturally on the errors and the violations in practice that on people. It's incompetent practitioners. It's people who don't know enough. And our remedial efforts are directed at fixing people, maybe re-educating them. But unfortunately, of course, people, humans, we are error-prone. We make mistakes sometimes. The other is the systems approach, and that traces causal factors back to the entire system of care and perhaps beyond the system of care. And remedial efforts are then directed at trying to fix system flaws. And in fact, the more flaws that you can fix that are not at individual people level, but at the level of how things are organized or paid for, the more efficient and perhaps the more effective you'll be. Oh, here we go. Well, you can test me to see if this is true. The most famous diagram in all of safety, which and this has been adopted. This actually was in Reason's first book, but this is the Swiss cheese model of system failure. And basically, what this suggests is that there are hazardous acts, perhaps, that we as practitioners will occasionally perpetrate. I'm an outpatient doctor these days, so perhaps the most dangerous thing I can do is prescribe the wrong medicine. If I do that, then, and the patient takes it, they may be harmed. However, and fortunately, there are many layers of protection that are really parts of our whole healthcare system that prevent all of those errors from making it all the way through to the patient. One of the protections might be, in fact, I order through a computer, and the computer says, that could be a fatal dose. Do you really want to do this? If so, click yes. Another layer of protection is the nurses who perhaps pick up the prescription. Another is at the pharmacy where they say, oh, that isn't right. Another might be the patient themselves. When they get that, they say, this isn't what I was taking before. Are you sure I should be taking this? So these layers of defenses are a great thing. But every now and then, all of those systems fail for some reason or another, just momentarily, and errors make it through and wind up causing harm. This is a depiction of the system. And the systems that we set up create safety, and they also create hazards. And some of those levels are not so obvious. One of them is the patient, or things about the patient that make them more likely to be subject to errors. It may be that they aren't so well educated about health. It may be that they don't communicate well, maybe because they're babies or older and unable to communicate, or maybe they don't speak the same language as providers, a real global health problem. There are problems with the things that we do. People, instructions may not be clear. There are things that are related to us, individual providers. More than that, teams often don't work so well, even though the individuals are perfectly competent. The work environment can be disruptive or overly busy or overly noisy, the way work is set up. People may be asked to work too many shifts, see too many patients in too little time. They may not have enough equipment or the right equipment or up-to-date equipment to do things optimally. There are problems at higher levels, at funding levels, perhaps. Maybe there's no insurance. Maybe whatever it is that you need is not covered. There's even health policies. So there are things at all of these levels that can make things safer, or in fact, make things more hazardous. We clinicians, those of us who are clinicians, really work at what people call the sharp end of the system. And I guess if you're a dentist, I was going to not make dental jokes, but in fact, it's reasonable to think that dentists, oral surgeons, work at the sharp end. But that is the most obvious end. Obviously, it's possible to poke a hole where it doesn't belong. But those are things that relate to an action that you take, an error, maybe a bit of tremor, a little imprecision, or not knowing where to poke. And the results are generally more obvious than they might be at other levels. But at the blunt end of the system, funding, work routines, equipment, training, policies, resources you have or don't have, there are actually a lot more of those things that happen. And so when we think about safety, it is worth and important to think about the whole system. Because of that, we need to remember that workers are not to blame. And we also need to, of course, be aware that we are already just blamey humans, because that's the way we think. But workers are generally not to blame. People are set up by the system. As I was walking up here, I'm actually really happy to see that, well, there's a wire that you can't see here that is supplying this more or less effectively. But as I came up here, I noticed it's taped down. Otherwise, every 20th speaker who came up here would trip over it and bang themselves against the podium and injure themselves. But that's a system issue. It's not that the person is necessarily uncoordinated, it's the way it's set up. And practitioners are set up, if they don't have adequate sterilization for instruments, they're more likely to cause infections in taking care of a patient. So blame, unfortunately, causes a vicious circle. And now we're going to get into culture a little bit. If you are blamed, what's the first thing you say?
Defense.
Yeah, you try to defend yourself. You maybe cover your head, and again, a natural thing. In fact, you may also, are you more or less inclined to tell people about when you do something wrong? Yeah, okay, good. So, and people really will deny and maybe even try to ignore things that can be ignored. The problem with that is that the knowledge about things ever going wrong become very scarce. Of course, this gets in the way of us learning from mistakes. How do you learn from mistakes if you don't know that they even exist? And leaders, when things go wrong, will say, that's the first time that's ever happened, or that's only the second time that's happened this year. And what do they want to do to the person who made the error? To blame them. So this is a real vicious cycle. So one of the most important things, and I would not challenge, but I would append Shannon's most importance, And I think that having a culture of safety might be the most important thing. A culture of safety encompasses three features. First, understanding and acknowledging that the work you're doing is risky. And basically determining that you're going to try to make operations as safe as possible. The second is having a blame-free, or at least a just culture, a fair blame culture, where people feel like it's okay to talk about when things go wrong so that they can be fixed. The third is encouragement of collaboration. In any kind of practice, there are lots of people, even in a dental office, there are many people with different roles. But across the street in the hospital, we have a small dental department that does some training, but they collaborate maybe more naturally because they're stuck right in the middle of the hospital. It's easier to get to the pain clinic and physical therapy and the neurologists and the rheumatologists and so forth. But because there's so many parts of the system where things can go wrong, it's much easier to find solutions if you can get input from all of those people. And finally, the organization needs to be committed when things turn up that could be fixed, to say, thank you for telling me about your mistake. You know, it really wasn't your mistake, it was our mistake. We're very grateful to you. We'd like to give you a small gift for telling us about your error. Which sounds silly in a way, but thanking people and then saying this, Toyota, that invented a lot of quality assurance and quality improvement, says that every error is a treasure. Because of course they only have one error per 100,000, cars that they make. But when they do find one, they say, hooray, we have something we can do better at. Because of this, 25 years ago, I helped a little bit to write a policy on telling patients themselves about things going wrong. When in general in dental care, if some small error is made, who tells the patient about this error that was made in their care? Yes, who? You do. You're a good person. I'm going to tell you about all the things that go wrong and you can tell the patients. But in general, since I didn't see a lot of hands go up, I think the correct answer is no one. I think that a lot of things, I suspect, I don't know, but a lot of things don't get told to patients when they go wrong. The policy for medical error disclosure is that it's the right of patients to receive information about their care, including when things go wrong. And if they report promptly, they will not be punished, stated explicitly. So a little bit about quality and safety at Johns Hopkins. It's getting close to this time of year. This is the graduating medical school class, not this year, a couple of years ago, in front of that dome, which hasn't been refurbished, but it doesn't look exactly like it did in the picture. A very wise and fortunate and privileged gentleman named Mike Armstrong in 2011 was inspired to make a donation to Johns Hopkins. Actually, he was also the chairman of our board of directors. So he knew what was going on, knew when things went well and when things went badly. And he made a substantial gift to set up an institute, the Armstrong Institute for Quality and Safety. This was in 2011. The initial gift was $10 million. And the Armstrong Institute's mission, actually, this was the original mission. It may have been slightly altered since then. And sort of their acting principles are: we partner with patients, their loved ones, and all interested parties to end preventable harm, continuously improve patient outcomes and experience, and eliminate waste. Core behaviors, which doesn't necessarily sound like every professor or surgeon that you've ever heard of. I'm humble and curious. I respect, appreciate, and help others. I'm accountable for continuously improving myself, my organization, and my community. With that in mind, we actually developed one of the very first patient safety culture surveys. One of our faculty, Brian Sexton, developed the first survey. We are now using a different one, which is the Hospital Survey on Patient Safety, or HSOPS. And we ask all of our staff questions which we may or may not really want to know the answers to, but we think we should get. And we survey people. Staff will freely speak up if they see something that may negatively affect patient care. 61, this was a few years ago, but 61% said yes. So that's good, but that means 39% don't speak up freely. Staff are afraid to ask questions when something does not seem right. 48% said afraid. That's certainly not a good thing. Staff feel free to question the decisions or actions of those with more authority. 40% said yes, that's good, not great. Staff feel like their mistakes are being held against them, 31%, not the majority, but that's a lot of people who maybe aren't talking so much. When an event is reported, it feels like the person is being written up, not the problem. As in, I'm going to report you, as opposed to, thank you for filing this patient safety incident. Staff worry that mistakes they make will be kept in their personnel file. 18%, again, not the biggest number, but we don't want this. And so we have been working, and I think we on the survey, we actually have made progress in the last 5 or 7 years on transforming our culture, because there is a gap in where we would like to be. And what we need to do is really transform culture before or at the same time as we transform safety and quality. This has become a little bit of a national movement. In 2019, the World Health Organization on World Patient Safety Day, which is September 17th, this was their first World Patient Safety Day, passed by the World Health Assembly. And the goal was to foster a culture of safety. And this was the first thing that they came out with, create patient safety culture through ownership engagement, engaging staff, leaders committed to a blame-free environment, open communication, reporting and learning from errors, and teamwork. So Shannon and others have talked a little bit about the importance of all of these things. I think that reporting and a system for reporting when things go wrong that is systematic, easy to use, and is used is very important, because otherwise, what percentage of patients who are seen in dental offices are harmed by the care they get? What's the percentage? Who knows? It may be private information, but I would venture a guess that even practices can't tell you what the real number is, and it's not a standardized definition, and it doesn't go anywhere, and no one really asks about it unless you maybe kill the patient, which happens pretty rarely in dental care, fortunately, but unfortunately, because this is a complete unknown. Interestingly, we're doing some work began doing some work recently with the largest veterinary healthcare system in the world. And same problem. Though veterinarians who do work in private offices, maybe are a little bit more similar to me as an internal medicine doctor than a dentist, actually, because they are doing surgery and prescribing medicines, and it's true that pets have oral health too, but they have now instituted a standard reporting system across 5,000 hospitals and practices to report incidents. The National Academy of Medicine, used to be the Institute of Medicine, has a collaborative on assuring the well-being and resilience of individual practitioners. And we haven't talked so much about this, and this is sort of the shoe on the other foot, or I don't know what the right expression would be for oral health, but it's not so easy to be a practitioner sometimes. If you're working alone in an office, one of the biggest things is, you're alone. You're pretty isolated. You've got your staff, but you're a little bit isolated. It can be lonely. I'm a much smarter doctor than I would be otherwise, because I work here and there's smart people around that I can talk to all the time. So in any event, the National Academy of Medicine and others of us have noted that you would really like everyone who's taking care of you to be happy, optimistic, healthy, and as well as they could be, so that they can be their best selves and take care of you. That's in everyone's interest. In fact, it's been written recently that there are three aims of healthcare previously stated, but the fourth aim is that healthcare providers should be healthy too. We're going to have another problem here with this is my opportunity to. Are any of you also psychiatrists? Okay, yeah. A third of my patients, I think, easily have, are taking psychiatric medicines. But this is a little bit of a Rorschach ink blot test. You see an ink blot, you interpret what you think it should be. Our organization has developed a program to support healthcare workers who, one way or another, are overly stressed or traumatized by their care. This is called RISE. And it's actually now been this model, which is a team of peer supporters, people who are working in the hospital or working in healthcare, but are eager to help their colleagues, are trained and available to provide support to their colleagues. I think we're in about 150 hospitals now. So I don't have a fix for you, but it's sort of, for better or worse, humans provide healthcare, and we are fallible creatures. We will always make errors, and that's something we can't change. Jim Reason said, we cannot change the human condition, but we can change the conditions under which humans work. I would say that the idea that a greater partnership between dentistry and the rest of organized medicine makes a lot of sense. I think that people who are at the University of Maryland and getting their dental care there do better than perhaps in some other places, because they're right on the main on the campus of a major medical center. And I'm not sure what the best way to do this is, but to borrow some strength and perhaps some of the same mechanisms that are used in I don't know what you want to call the rest of healthcare, in the rest of organized medicine, might be a good idea. Reporting systems might be one place to start. So I'm happy to answer questions. If anyone is dying to learn more about patient safety, we have a Master's of Applied Science. It's 100% online in patient safety. It can be done over 2 years, or it can be done over 3 years or 4 years. And if you just look up the Masters of Applied Science in Patient Safety at Hopkins, it'll pop up. happy to answer questions. Send me an email. And I used to be on that other platform, but now I'm on Blue Sky. I'm with you, Dr. Wu. I could take a question or two as that, otherwise I would have been lying on this other slide here.
So just to start off, how are the funding opportunity for patient safety? Is it the priority of the government? Have you received funding for patient safety as a protocol?
So I have received funding from primarily the Agency for Healthcare Quality and Research, which is the lead agency for patient safety in the US and will exist for at least another few weeks. I've also gotten some funding from the VA, the Veterans Health Agency, which is quite invested in getting safer care for their veterans. There are private foundations that do this. I've also gotten money, which is not a sure thing, but from the World Health Organization to do something. So there is some money out there, but health systems too are often interested in investing in improving safety, which also in the end winds up saving money often.
Thank you so much.
I'm wondering if you collaborate with Johns Hopkins institutions internationally, and if you have, do you see like drastic differences in things like the survey that you presented there?
Yeah, so Johns Hopkins, we work a lot. Armstrong works closely with Johns Hopkins International. In fact, I would say many, if not most, of our international collaborations or consultations are through JHI, including helping to run some hospitals in some countries. Some other things are through WHO.
How can we make sure as a non-manager that this surveys that we're taking, asking us if we feel safe about reporting our own error, or if we feel safe about, reporting any problems, or if we're not agreeing with someone else's decisions, is actually taken into account? Because I have and my husband as well, have taken those surveys and the results, because they are forced or obligated to, kind of publish to the department the results. Last one said that only 40% feel, comfortable about sharing or questioning someone else's decision, but nothing has changed in over a year. So what can we?
Good question. I mean, I think that leadership is really essential to getting these things done. But I think that I think that a sort of a top-down and a bottom-up approach works. I think if you talk to managers, volunteer to speak about these things, or to organize events, and seek the help or the support of leadership. If nothing else, they might be embarrassed into saying yes and supporting you. If they are resistant, that's, I don't know how much discretion people have to work elsewhere, but that's always an option, or it's sometimes an option. But I think that having top leaders often don't really know what's happening at the ground, at the level of the floor or the ground. And if they can be educated, most of them are well-meaning and are willing to hear things. So I would say talk about it.
Maybe last question.
I really like the program that you mentioned, that is RISE, the RISE program that is a virus-13. How exactly that work? And is that program working on the Hopkins Hospital?
Yeah, that program there are 30 volunteers who are on the team. If you actually just look up RISE Johns Hopkins, you'll get some information. I promised that I would, for those of you who are in the MPH class, Okay, this is going off script, but there is a nonprofit in Baltimore City called Baltimore Connect. We used to have some, it serves people in East Baltimore, in the community. We used to have some dental health and dental public health work that was being done. We're considering starting it again. If anyone in the MPH class is interested, send me an email.
Thank you. Thank you, Dr. Wu. And Dr. Cole, I think you can probably all agree, we need more collaboration from medicine, from patient safety movement. I've never seen anything quite to this level of panel at NOHC or any of the other public health dental conferences and such. Before we let you go for lunch, the couple things. Did Dr. Raskin have to leave? Fantastic.
1:30.
1:30, okay, so we have something for her. If I could have Dr. Zahir come to the podium, please. Dr. Khatib, please approach the podium. Thank you. Dr. Abiola from my neck of the woods. You will appreciate BC salvage maple. And the one and only Dr. Ramprasad. Dr. Ramprasad wins the award for farthest travel, even though Alaska, it's debatable, but it's a domestic flight. Thank you. Sir. Thank you. And Dr. Olaika, where did you go? No? Fantastic. Thank you. And the one and only Dr. Shannon Cole, please come on down. And is Dr. Wu here? I just saw him. Oh, there he is. Dr. Wu, could you come to the podium? Thank you. Oh, thank you so much. I'm gonna have you stand here. Yeah, perfect. Thank you for advancing oral health. Fund the Center for Oral Health. No problem. And I think Yeah, Dr. Raskin will be back momentarily. So I would suggest we have some lunch, something civilized. Boss, should we start at 1 while we eat? Yeah, we should get back on time, right? So you can still munch while people are speaking. I don't think the speakers will mind too much. Although, yeah, it's a working lunch. I don't know what the speakers will eat, but Zoom people, please grab something to eat and we will be back in 15 minutes. Thank you all.
Yeah, like maybe. Yeah. Are we, in this chapter, yeah.
Yeah.
Right, so.
Oh, all right. I'm gonna make sure I mute the Zoom.
I don't want. So.
Welcome back, Zoom people. I hope you had a good little restful stretch. We're enjoying a working lunch here. I would like to introduce Carrie Kunzelman, immediate past president of the American Dental Therapy Association, to do and recognize a land acknowledgement. Thank you, Carrie.
Chickasaw, hello, my name is Carrie Ann Kunzelman and I'm a member of the Chickasaw Nation of Oklahoma. I am traveling here from Portland, Oregon, where I reside. I'm also a dental therapist. I wanted to just share with you all that yesterday, Dr. Rodriguez had shared a land acknowledgement. I'm just recognizing the ancestral lands that we are on at this moment. And I had just did a little quick Google search and I noticed that Johns Hopkins has a land acknowledgement on their website. And I wanted to just point that out and to go ahead and read it for you all. It states, we humbly acknowledge that Johns Hopkins University is located on the traditional and contemporary homelands of Indigenous people. The campus resides on unceded lands of the Piscataway and Susquehanna peoples. We recognize the enduring presence of more than 7,000 Indigenous peoples in Baltimore City, including Piscataway, Lumbee, Eastern Band of Cherokee, and many others represented by our Indigenous students, faculty, staff, and local Indigenous agency partners. Together, we acknowledge the history of genocide and ongoing systemic inequities that have impacted Indigenous intergenerational traumas and health disparities. We give thanks to the past, present, and future stewards of this land and recognize tribal nations' sovereignty and right to self-determination based on past and present treaty rights. We aim to hold ourselves and the university community accountable to advancing tribal health equity. Thank you.
Thank you, Carrie. Thank you for that. I would like to, we've had a lot of questions about what's this Solidarity Dental thing? And I'd like to invite the co-founder of the thing to explain it. Dr. Priyanka Goodsarkar, if you could come to the podium and explain what the heck is Solidarity Dental Foundation?
Okay, not more than 2 minutes. My time for Dragon's Den. You can time me. I've done this before. So we're gonna try. Okay, so Solidarity Dental started as my master's program thesis project. Going on strong now. Our mission, vision are right out there on the website. I'm not gonna say it again, but volunteering and parachuting is what we don't believe in. What we believe in is on the website. So I want to tell you what we don't believe in is parachuting and volunteering. No to that. Big time sustainability. A lot of questions were asked about what is 1%. We started off in Ecuador, had this 1% for the planet kind of a model, which talks about fair trade in oral health care. Our Ecuador model was working. It was fantastic. Political turmoil. We had to take a pause. We haven't started back up yet, but we envision doing that. Meanwhile, we had geographic expansion, Tanzania, Ghana, recent trip to India with the whole team. That was an experience. So we are growing, I would say. And that is what Solidarity is doing, trying to bring the education component in, mentoring, global health experience that are non-volunteering and non-parachuting. Again, long-term projects that are sustainable. So we are growing. And you being here, you're already a part of Solidarity. I don't think you are not going to be a part because it's like, we call ourselves the mafias. So just saying it out there. But I just want to acknowledge my whole team. And if you could just stand up where you are, or you could come up. Dr. Jessica Clayback, our executive director. None other than Dr. Sujay Mehta, our director of global health education. Our fantastic social media done by Dr. Karen. Our in-house health informatics done by Dr. Anair. And today,
And yesterday we had this amazing student support from Dr. Sana, Marina Nevishkin, and Ryan. So, big round of applause for everyone. Feel free to go to our website and social media page. You'll know all about us and follow us. Is that what I say, Karen? Follow us.
Thanks, Dr. Preet. Let's see if this.
Sujay, I forgot one.
2 minutes.
No, wait, I forgot. I can come back, right? I didn't get that. And we also have two great family members supporting us. On camera, we have Meena. Thank you, Meena, so much. And some Gen Z interviews done by my son, Soham. So thank you very much.
Yeah, it is a bit of a mafia. So let's see if this site works. I don't know if, no, doesn't look like you can see that. Okay, well, the Padlet, so you can see there's that QR code. I wonder, can we put the Padlet back in the Zoom chat again?
I can.
Yeah, just because we're telling people. But so on this, if you scroll down, there's been a few extra additions and questions. So thank you for posing your questions. We are going to make sure that the speakers address those. And we want to hear your positive feedback as well as your constructive criticism. This is a little bit of a mom and pop operation in that, although this is at, the #1 public health institution in the United States, the funding of this is challenging because it's oral health and it really is siloed. I think you will agree that we've had some really quite amazing speakers in a variety of topics. And we just want to continue that and see how we can improve it, but also take it to university leadership to say, we'd like to come back next year and not in 2 years or 3 years or 5 years or not, never. So, well, there's, yeah, I don't think this is going to work. No. Okay. So we're going to do a little health economics because, again, this is one of those topics that I just don't see in the little narrow niche of conferences that I attend. So let's see. Let me introduce the right person in the right order. So Professor Frick, Dr. Frick was involved in our inaugural 2023 Global Oral Health Symposium. Did we call it a symposium? I don't think it wasn't quite. One day isn't worthy of symposium, right, boss? Yeah, I don't think so. So I don't know what we called it, but we had, we're fortunate to have Dr. Frick, Dr. Goodsucker, Dr. Fleming returned, and Dr. Hewan Lee participated with a video message. Dr. Lee participated last week with our prequel, and Dr. Seymour also participated in our prequel. But Dr. Frick is here today, a health economist and professor at the Johns Hopkins Carey Business School with joint appointments at the School of Medicine and Bloomberg School of Public Health. Has been faculty at Johns Hopkins University since 1996, was the vice dean for education at the business school for more than 8 years. Dr. Frick has been actively involved in cost effectiveness research and teaching throughout their career, has spoken at 2 other oral health events. This one, as mentioned, and at Academy Health that in Baltimore, that was last year. And let's see, actively involved in cost effectiveness research, teaching. Yeah, 2 other, did that. Recently had a commentary published on the need for cost effectiveness data on the management of temporomandibular joint disorder, which I was the guest editor for. Hence, you see how this keeps going in the Journal of the California Dental Association. So I'd like to welcome Professor Frick to the podium. Thanks. Should be great. All right. So thinking about what we've got here, what is economics? I don't know how many of you have ever had an economics course.
When I think about economics, and I've only got 20 minutes to sort of give this very broad overview, economics is all about a systematic paradigm for thinking about how to allocate scarce resources, or the sort of textbook definition, the study of the allocation of scarce resources. And then when we think about health economics specifically, we're going to take that paradigm of economics, we're going to apply it to a whole bunch of different individuals in the healthcare space. Consumers / patients / our population, the providers of healthcare, businesses affecting health. And you might ask, well, what business doesn't affect health? I mean, it could be everything from businesses in food, to businesses that create pollution, to businesses that create games that have us sitting more than standing when we should be out and about in the outdoor world. Businesses that provide healthcare, businesses that pay for healthcare, particularly in a society like the United States, where we have commercial third-party payers, and then, of course, the government agencies that can both provide and pay for healthcare, both in the US and in other countries. And we study all of those. And so what does a health economist do? Just before I get around and talk about why it's important for you, this is what I've done just this week. Other than the teaching of a class on business, on healthcare innovation, but it's a lot of different things. And I think what's important is learning a little bit about economics, even if you never become an expert in health economics and why it's important in dental health, it will help you be better advocates. It will help you be better decision makers, and it will give you the language to talk to the people who are either controlling the resources that you want to get, or who are making decisions about government resource allocation that you need in order to do your work better. So when we think about innovation, this is part of the language of business. Sometimes we look at sustaining innovation. We're going to do a little better what we've been doing already. Other times we're going to look for disruptive innovations, something completely new. A great example of a disruptive innovation in a non-healthcare setting was the personal computer. It couldn't do everything that the big mainframes were doing, but it opened up a whole new market that didn't exist before. So when you think about oral healthcare, what might be things that could totally disrupt the market for it and change how people take care of their oral health? When we think about what is business, okay, there's some statements from our business school's website. We're not just talking about making money and maximizing profits, though those are important things to think about when you're thinking about a business. You can't continue if you don't have more revenue than you have costs. But as you can see, we want to create lasting value. We have 4 sets of core values, the first one of which is unwavering humanity. We worry about where resources come from, how we're going to use them, and we use accounting or the language of business to help trace those resources. When we build a business, you might need angel investors who bring money to a complete startup. Then, once you've gotten through that complete startup phase, which is very risky for those investors who are willing to put that first bid in, then you get to venture capital, where the investor thinks there really is something here, and it's still risky, but it's a lot less risky, and they're going to invest and usually play some type of role. And there are many, many venture capital firms out there that specialize in the healthcare industry, which can help to bring new money to the industry as well. As an economist, when I analyze consumption, I think about the fact that my patient or consumer has a monetary budget, only a certain amount of money that they can spend. They have a time budget, only a certain amount of time they have available. I mean, why do we not do some good health behaviors? Often we say, I don't have enough time to do it. Okay, so that's real. It's a limited resource. And then the preferences, and where do people's preferences come from? They come from our ethics. They come from what we're taught about health. They come from what we're taught about taking care of ourselves in general. And then on the production side, all firms want to maximize excess revenue, even if they're not for-profit firms, minimize the cost of production. And then if it's a for-profit firm, it distributes the excess revenue to the owners. If it's a not-for-profit firm, it can think about what's our bigger goal? What do we want to do with that excess revenue? Do we want to work with more people? Do we want to do more for the people we're already helping? And firms have to choose how much to produce and what price to set. And those aren't the things we're going to focus on immediately, but when you're thinking about economics and you're talking to people who are making these decisions and using these terms, this at least would begin to give you some of that language. When we think about whether to adopt a new technology as a government provider, or whether to pay for something as a government provider or an insurer, we have these 6 different types of studies. All of them have cost in them, because we always want to know what resources do we need. But to think about the other ones, cost in general, accounting or economic cost, and then with economic cost, there's a special term, opportunity cost. We think about what's the value of the next best alternative. But we also have to worry about the cost to whom. Is it the cost to the patient? Is it the cost to the government? Is it the cost to the third-party payer? What about the cost to the healthcare system? Make sure whoever's adding up the cost tells you who the costs are for. Then if they're costs from 3 or 4 or 5 years ago, especially over the last 3 or 4 or 5 years, we know how much higher costs are now than they were a few years back. So are they adjusting for inflation? And if we're looking at cost over time, Shannon's story earlier about the multiple years of managing TMD, we could look at cash flow, where we could try to say, if we were getting some return on our investment and we had all the money in the bank today we would ever need to fund this stream of costs, how much would we need in the bank today? Again, different ways of thinking about the cost from a business point of view. Cost minimization, we have 2 alternative interventions. Their outcomes are equal. From a purely economic point of view, we simply ask which one costs less. Now, there may be different distributions of those benefits, even if the averages are the same. So we may want to think about the ethics and distributional issues. And when we talk about equal outcomes, do they have to be exactly the same, not statistically significantly different? Is it the main symptom that the person's having that's the same, but other symptoms aren't, or is everything the same? All these things we'd have to ponder. Which brings us to cost consequence analysis, where we describe the costs, we list some consequences. Lots of conditions have multiple symptoms. There's pain, it disrupts our sleep, it disrupts our work, it disrupts other things. And so then you report all the impacts. How does it change your sleep? How does it change your pain? How does it change your ability to be productive at work? But leave it to the decision maker to say, is it worth it? Cost effectiveness then is where we choose one of those outcomes as the primary thing. Maybe the primary thing is pain. And if one intervention happens to cost less and do better at reducing pain, then again, from a purely economic point of view, choose that one. But there again, you have to think about what about distributional issues, and do we have to worry about those? But if one costs more and is better, in my example, at reducing pain, then you have to ask, well, how much extra are we spending to reduce more pain? And the decision maker still has to implicitly decide, is it worth that spending or not? Cost utility analysis is where we hear about quality adjusted life years or QALYs and disability adjusted life years or DALYs. In the time that I have, I'm only going to talk about QALYs, but you calculate the costs, you translate your clinical outcomes into quality adjusted life years. And then once again, if one of the choices costs more and gets more quality adjusted life years for the patient population you're working with, then you ask, how much extra does it cost for each quality adjusted life year my population gains? In the United States, we don't have a magic number. It's always worth spending less than $100,000 per QALY. There are other countries around the world where they do have a threshold. The UK is one of the best known. Their threshold, if we convert it into US dollars, is about 50,000 US dollars to improve by one quality adjusted life year. So what is a quality adjusted life year, you might ask? It's a measure of health utility over time. Health utility is a way of thinking about health-related quality of life. I won't bore you with some of the really interesting and thought-provoking questions that people get asked to come up with the utility scores in the first place. But on this scale, perfect health is valued at 1. Death is valued at 0. Some health states are considered negative. And as I like to say, we wouldn't have to debate assisted suicide if there weren't some people who thought that at least some health states were worse than death. And how does oral health fit into this? Again, if it's a pain issue, that would affect our health-related quality of life. And we would say, if I've got some oral pain, I'm probably not at a 1 today. If it's affecting my sleep, I might be even lower than that. If it's affecting my ability to work, I might be even lower than that. We think about all these things, and if I'm now anxious about it as well, so now I've got mental health issues, it could also affect where I am on this scale. This is just a really simple way of showing what we're talking about on a graph. On the vertical axis, you have the health utility scale. On the horizontal axis, you have time. If a person is completely healthy for a full year, they've gained or experienced 1 quality adjusted life year. What you're asking is what fraction of that 1 quality adjusted life year do they experience each year? And it could be less than 1 either because they don't live the whole year. It could be less than 1 because they're not in perfect health the whole time. So whenever you see anything that's in the literature, and there's not a whole lot in the oral health literature yet that puts things in terms of dollars spent per quality adjusted life year gained, somebody somewhere along the line has answered a question thinking about that issue. How am I feeling? How is my health affecting my ability to function? And how do we think about that? And this is just, a list of things, of ways that it could affect our quality of life. I already mentioned pain and sleep. There could be a stigma depending on the oral health condition. It could affect one's ability to eat, could affect one's ability to speak. We could probably think of some other things that would go on that list as well, all of which, again, influence where you are on that 0 to 1 scale. And by relieving any of those symptoms, you can move closer to 1. By relieving combinations of symptoms, sometimes if you reduce 1 symptom at a time, you move a certain amount. If you reduce more than 1 symptom at a time, it doesn't always work out that it reduces by more than the sum of the parts or less than the sum of the parts, but they interact with each other. And that's important to think about as well. And not only do they interact with each other, but they interact with whatever other conditions people have. I do a lot of work in the eye care and vision space. Many people who are visually impaired or blind are older adults. Their vision is important, but so is their heart disease, their diabetes, their osteoarthritis, and any other conditions they may have. And sometimes curing just their vision doesn't make as big of a difference in their health-related quality of life as we might think. So when you're thinking about oral health, one thing to think about is how important in one's overall health is oral health. And again, it really depends on what other set of conditions people have. Finally, for cost-benefit analysis, we're trying to convert all of our medical outcomes into monetary figures. Okay? Medical care avoided, if we treat somebody early and we prevent further development of disease, that's an easy one to understand how we would convert that into a monetary figure. Increased productivity in the workplace. We can imagine how we would convert that into a monetary figure. But is it just worth some money to feel better? Is it worth some money to have a longer life? We like to think both of those are yes. The value of a life, we use this in the government sometimes uses this in making decisions in general. They'll call it a value of a statistical life. How much is it worth to keep someone alive? They use that when they're looking at things like environmental intervention. Changing the speed limit. Well, we get there faster, but more people die in worse crashes. So how do we think about that trade-off? And the value of better health, I always like people to think about, any type of pain. You don't take your ibuprofen or whatever painkiller you're taking because you like ibuprofen. You take it because you are willing to pay some amount in order to reduce the pain. And what is that worth to you? So thinking about that can be quite important. And when we think about productivity, we think about both absenteeism and presenteeism. Absenteeism, obviously, is when you don't go into the workplace. Presenteeism, which really does come up again in the eye care space, dry eye is a classic one that rarely causes absenteeism because there's a lot of presenteeism. It's hard to concentrate when you have dry eye constantly. And I'm sure you could think of a variety of oral health conditions. I had an abscess one time, a number of years ago. I came to work the day after my dentist took the abscess tooth out. I was there by 9 o'clock and ready to go. And folks were like, what are you doing here? I said, no, you have no idea how I was feeling yesterday. Okay, yesterday I couldn't get any work done. Today I'm feeling, it's not comfortable where the dentist took the tooth out, but it feels a lot better overall. And so there was definitely some presenteeism when I had tried to work through the prior day, and the day after I could go to work and be just fine. So in summary, big concepts. We teach whole courses in the School of Public Health and Business School on the Homewood campus that can take 8 or 16 weeks to talk about health economics and cost effectiveness. Whole sequence of courses, in fact, on cost effectiveness here at the School of Public Health. I've given you a broadest overview. as well as some terms to think about in business. As we think about innovation in the oral health space, as we think about getting things covered on formularies, on general health insurance, much harder on the dental health insurance, but on general health insurance, what are the arguments that we can make? And the arguments, obviously, in some cases, are just because we want people to be better. We want them to feel better. We want to reduce their suffering. But the arguments also have to be accompanied by economic data and business data almost every time. And there are tools that are available to take what we do and translate it into outcomes that speak to policymakers, speak to investors, and speak to entrepreneurs who can help. And these are some of the terms. There are plenty of additional tools that you can look at, but this is really what helps to make a difference and move the discussion forward. Thank you.
Thank you, Dr. Frick. That was wonderful. It is a great honor to be able to introduce our final speaker of the symposium. She's a dear friend and colleague, Dr. Priyanka Gutsukar. I just want to take a few moments to kind of talk a little bit about her background and what an inspiring leader she is in the global health world, oral health world. So she is an assistant professor and the director of global health at University of Cincinnati. And she is also the co-founder of the Solidarity Dental Foundation. She is an inspiring, brilliant mind and researcher who is well published. And really the best thing about Dr. Priyanka is her commitment to expanding access to oral health care is contagious. Many of you have met her and know her and understand when I say we are all thankful that you are here and can't wait to listen to your presentation.
Yeah. Pressure now. Okay. It helps it.
Oh,
I don't have my presentation.
that's not there?
No, it's on this one. Can I do down arrow? What's the difference?
Be there.
Last speaker. Okay, thank you. Thank you. Thank you. Okay, last and hopefully the best, hopefully very interactive and nobody's sleeping. All right. Okay. Thank you, Dr. Frick, for giving that introduction. It just makes my presentation go easier. Happy to be here. Thank you, Dr. Mehta, formally for inviting and being a part of this. Thank you for the great introduction, Jess. I work at the College of Medicine, a very different experience for a dentist to be at the College of Medicine. We don't have a dental school, although we do have a dental hygiene school. So I learned a lot of things about economics from the medicine perspective of things. Oh, they're not changing here. So let me fix something. Okay. Okay. They're probably here. Yeah. This one's not here. No. Because we're accidentally sharing this. Okay, disclosure. I have no financial disclosures. I'll be presenting 2 cases. They reflect my original work through the foundation, through my university, and include a conceptual framework to kind of help dentists, us, understand the economics of it, because I was very weak in economics when I went to dental school, and when I got out, I was weaker. I was a good surgeon, but a weaker economist or had weaker knowledge in economics. So, what you will see, thank you, Megan. No. I want you to plot. I'm so sorry. It says plot thyself. This is a graph. I want you in your head to think, where do you lie on this Dunning-Kruger effect? It's a cognitive bias that describes two kinds of people, limited experience and expertise. They're either going to underestimate their expertise or are going to think that they're just way smarter. When you think of health economics, where do you fall on this plot? Anybody? Okay, I asked my husband where he is, and he said he was in the black box outside. A healthcare professional. Knowledge of economics is, we all know, but in your head, at least find out where you are. I think I am at the spot where there's more to this than I thought. I did take economics classes while doing my MBA, taught me a lot of things. This is going to be a 30,000 feet overview of what we are going to go and discuss. And now I can't change my slides. Can I try it here? No.
This one didn't work, did it?
No.
Yeah.
Yeah. Oh, down button, not the front. Okay, got it. So we've learned a lot about the economic rationale. If you see on the first figure that you see, the combined dental caries, periodontitis, and tooth loss. The burden is more than, combined burden is more than mental health, respiratory disorders, diabetes, and cardiovascular disorders. So the burden is huge. The World Economic Forum report says the cost of oral disease to global economy is substantial. And in 2022, the density of dentistry personnel per 10,000 was 3.3. So we definitely have a demand and supply issue. We have some workforce issues, resource allocations, and definitely the burden of oral health disease is higher. It's higher than the combined effect of mental health, cardiovascular, and diabetes. So what do? We are in a mix. So definitely the whole oral health world, the global oral health world, is paying this cost of inaction. The cost of inaction is on two levels. One, it's underfunded. Anybody disagree? Has better options? Yes, it is underfunded, but there is also another problem that there are some resources that we are probably not using in the best way possible. Can we think of that? Is that a low-hanging fruit, or is that a fruit we can go and get first? There could be two schools of thought to this, but this whole inactivity in the economical area of oral health is leading to lower quality of life, lower oral health related quality of life, weakened social participation, educational attainment, as Dr. Frick said, presenteeism, absenteeism with eye care. If we have similar issues, if there is severe dental pain, abscess, there are students that miss going to school. There are kids that's happening. People miss work because they have enormous pain. And of course, now that we're finding other systemic connections, the bidirectional relationship, the other disease conditions are also interlinked and intertwined with oral health disease. So as a community, we are paying the cost of this inaction. So now we have two choices. Do we invest more or do we invest better? Anybody? Better? More? More and better. Okay, so then it's going to cause two conditions here. If we invest better and reallocate those resources for oral health care, where are we going to get those resources from? Either it's going to be the more, or we're going to take resources from somewhere else and put them in oral health, causing a disinvestment in the other arena. So more and better, better and more, just better?
Both.
Yes. Did we? Both?
Yes.
Is it going to be possible?
I think so.
Yeah? I love the optimism in the room. I agree. No, it has to be more, it has to be better, or we're going to all pay this cost of inaction. So as oral healthcare professionals, what I want to do is now come from a 30,000 feet to a 10,000 feet. I cannot do the economics 101, but give a little economic evaluation toolbox. I like to call it the humble view because we're not as great as Dr. Frick, but we can try to understand. We can be better if we are able to understand some of it. Sujay. Okay. So we did talk about this demand for and utilization of dental care. Definitely, there's where we use the demand analysis, productivity, technical efficacy, economies of scale. This is for the DSOs, for the industry partners, for our corporate partners. They're mostly demand and supply analyses. But what we, as dental public health professionals, as people that design programs, work with those interventions and implement them should always look at outcome measures. And what I mean by outcome measures is what Dr. Frick mentioned in his presentation before. I'm only going to put an oral health view on that is cost-effective analyses. I want you to remember it is a non-monetary measure of benefits, meaning our DMFT index, our periodontal index, the probing depth, 2 millimeters or 15 millimeters, Kalida. Probing depth. I cannot forget that. That was a great one. Cost utility analysis is another measure that is going to look at oral health through a holistic approach. What Dr. Frick mentioned, the quality adjusted life years. In the dental world, there are not a lot of studies, but a few that have used this quality adjusted tooth years called as QATs. It even sounds weird. I know what it rhymes with. I'm not going to say it, but very few studies have used them. Can we use these measures? Cost benefit analysis is the measure of actual benefits. I know these are just terms, but I'm going to show you 2 cases where we've used these kind of measures to kind of go and learn more about them. But for now, I want you to remember these 3 terms: cost effective analysis, cost utility, and cost benefit. Okay, so now we're all going out to the field, done our needs assessment, know what our problem is. That says step 1, define the problem. We've identified our options. Either it's an intervention or it's a policy. In the policy world, we're going to be called policy. This is a diagram I want you to take home. This is my key takeaway from this talk. Then we go to our next step is determine the standing perspective. Are we going to think from a healthcare perspective, healthcare systems perspective, or a societal perspective? The current CEA guidelines say that we should consider both perspectives. Going forward, our step 4 is where we predict a baseline condition, meaning something is present, that is our comparator, and then compare it to predict a response if SDFs did not exist. If certain interventions and if dental decay, if cure to dental decay did not exist, then what would happen? It's just an example, but that's our predict a response box. So those are 2 types of decisions or comparisons you will make when you are going or diving deep into cost benefit or any type of economic evaluation. After that, where it comes is you find out what the opportunity costs are, meaning what is the value of the resource and in which way can it be used the best. That's what opportunity cost meaning. That's what estimating the costs mean. And then what that leads to is we go ahead and estimate the benefits. What I want you to remember here is we are estimating these benefits probably over a period of time. They're not going to happen immediately. This is probably 5 years later. After this intervention is in place, this is going to happen. But you are supposed to predict that to have a cost benefit analysis. You then compare the cost, the benefits and cost, make sure either they're matching or they're not matching, and that's where your decision tree starts. The main thing or the mostly what people forget is to address or estimate the distribution. Is what that means is how does this distribution look in the wealthy communities versus the poor communities? The worst way to say it or even put it on a slide, but that's how there is this distinction made is how is the distribution looking? You've done your cost benefit analysis, you know what the costs are, you know what the benefits are. Now, how would this work in different distributions is what are the components as dentists, basically dental public health. We should know this because if we don't know this, the interventions that we are going to implement are going to be a little difficult to predict in the future. What I want to go through is, this is a study we did in Ecuador. It is actually a prevention program evaluation approach. Right? It's an evaluation approach. So on-site mobile dental units went to rural and peri-urban Quito, focused on adult population. 4 years of longitudinal data was collected. We used a risk-based caries prevention approach, similar to Canberra, if you've heard of Canberra, pretty much popular in Australia at the moment, if I'm not wrong. And the study objective was to evaluate caries risk-based prevention over 4 years for 2,800 workers. So here's my question. We have to find out two things. Does it work? And is it worth the intervention? Probably you did not sleep when Dr. Frick was talking or during my initial slides. What are we going to use to find does it work? Analysis? Which one? Effective, benefits, utility? And then we got to find, is it worth? So does it work will give us a health impact. Is it worth was the actual economic value of that intervention? And remember what was the name? It was a prevention program evaluation approach. So we are evaluating. So the outcomes that I would look under my effectiveness evaluation would be the incidence of caries. For example, here, because we've done a needs assessment, we took the baseline to be 8 decayed teeth. The DALYs or the QALYs averted, the DALYs averted and the QALYs gained is another measure that we would use. And then the retention adherence to the prevention protocols, because this was working on a risk-based caries prevention programming. For the economic evaluation of it, we would use the cost-effective analysis, which means cost per case of caries prevented. That would give us a return on investment estimation. So that's the economic evaluation, which means is it worth it, the economic value, and does it work is the health impact, giving us clinical impact and the economic evaluation. Now, why this matters, even if the ROI is conservative, because we have to remember that the return on investment is not going to calculate the other holistic measures that we mentioned. Emergencies, long-term gains, productivity. Sometimes you might see a neutral, a cost-saving scenario or a neutral scenario, which is a good scenario because we are averting those emergencies. We don't want, if you remember yesterday from Dr. Elias Moran's talk, the amount that is allocated or that is spent on dental visits in ER is way more, 10x more than that happens in a usual setting, in a non-emergency setting. So this evaluation, if I did this evaluation for my 2,800 people in those cities, calculated transport, calculated all of my effectiveness and economic evaluation, the numbers that I get, what would they inform me? They'd inform me if I should scale up, if I should replicate, and what are those numbers going to tell the policymakers? That is there a policy required? So we've all been talking about this. There's a lot of policy and advocacy required for oral health. These numbers are going to give us that. And as clinicians, as dentists, as dental public health professionals, we are going to be able to better explain those numbers than anybody else. Of course, we have to get help because we don't know all. We all know where we fall on that graph. But we can give a clinical overview, a clinical perspective to these numbers. This is the last case, talking about an investment case modeling approach. So the target population where I work is in rural Tanzania that have no access to dental care. There is one dental therapist that serves about 35,000 people. There are some community health workers, midwives, dental specialists. So what we did here was we tried to do a simulation model. We all know the basic package for oral health care, BPOC. So that says acute dental care for pain and extractions, simple fillings, so fillings, no drill, fluoride toothpaste, and our human resource was our dental therapist. The specialist for this area was about 4 hours from where these villages were located, and then some promotion by community health workers according to the basic package for oral health. We ran a beta model, made a few changes. Still kept the acute dental care to be the same. We had more SDF, silver diamine fluoride treatments going in. Fluoride toothpaste remained the same. And for our human resource, because there were a lot of community health workers, we had access to dental therapists. We did change the human resource point there. And then we did some calculations for our basic package and beta package. On the far right, you see the difference. You'll see the cost of toothpaste stays the same. What changes is the cost for the human resource, because if the dental therapist is better able to do some treatments, one, we are solving the problem of access because they do not have access to those specialist dentists. That will also save time for the dental specialist, and then the dental therapist can get more procedures done. Exactly what Dr. Richard Rodriguez was going to mention yesterday. So the key findings, so we did run something called as a Markov simulation, simulation. I cannot go into the depths of it, but if anyone's interested, I'm happy to meet with them because that's another class. So we did have our key findings on this, that the DALYs averted. Human resource cost, obviously, that went down. The basic package, the return on investment is 47% according to calculation, which meant every $1 spent, you get 1.47 in health value. The beta package gave an ROI of 77. So for every $1 invested, you get 1.77 in return. It really looks small, but believe me, it's a huge amount when you are going to do the comparison between the basic and the beta package. So Markov simulation actually helped us to simulate the clinical and the economic effects on treatment, helped us compare those, and then create a healthcare program that was suitable for this population and actually aided the decision making. So if I go back, the name for this program was investment case modeling approach. Should we invest or should we not? Is the ROI positive? Yes. If it were negative, we would have thought. Even if it is slightly positive, if it's positive, we are going to go based on these numbers. So again, we're making some, if the math is not mathing, can I say that? My 12 years old is here. He said not to use any slang, but that's mine for the day. The math is mathing, then you are correct. Then you're okay to go ahead and do the program. If it's in negative, you seriously need to give it a thought. But that's about it. I'm happy to answer any questions if we have a minute, or if you have questions for Dr. Frey. Yes.
Do you have any examples of interventions like where the math wasn't mathing?
Yeah, I do. I'm happy to share them with you. We have cases of failure. Yes.
You mentioned about that in Tanzania, you introduced something that is oral health promotion with health work. How was that?
So we had access to the dental therapy school and the nursing school, and we actually did some continued education for them. We used something called as lift the lip technique because one, it actually just means lift the lip and see what's happening in the mouth, which I know we were talking about this yesterday after the nephrology panel is, can you look inside your dialysis patient's mouth by just lifting the lip? It's economical, doesn't involve a lot of expertise, but you can look inside the mouth and at least nurses, community health workers therapists can know what's going on. So we actually educated them to do screenings, to do educations, instead of going the dentist pathway, which was not accessible and where only specialists were available probably 4 hours from where they were living. So we kind of took a little different approach and changed the human resource settings. I hope that answers.
Do you do this kind of promotion in schools?
Yes.
How was that?
It was fantastic. I don't know if you saw the picture of the school. I don't know if I put it on the slide, but we are serving up to 3 schools. And with the school program, we also have started the nutrition program in the same area because we got to know that the kids were walking to school without having any food. And so the school program actually is doing really well. We have clean water. It's called uji, which is like a porridge in the culturally whatever is available in the geography and is appropriate. So that along with the dental intervention is really working well. It's in its 5th year now, so we'll have more data in the coming years.
Thank you.
Welcome.
You have multiple primary teeth and the need for oral urgent treatment.
Yes, we did. We had partnered with local dentists to work who would go with us. And again, the therapists were doing the stuff that the dentists wouldn't do. And this kind of partnership. Yes.
This is great, thank you. I have a question. I guess one of the themes that we've been talking about these last 2 days has been siloing. And so when I think about some of these applications of economic analysis, particularly like how oral health care can improve upon treatment of other medical conditions, one of the things that I've struggled with is kind of how to align those 2 different sectors or multiple sectors that are not overlapping. And so when you ask the question of like, does this matter to whom? You could have a medical payer, you could have a dental payer, you could have, and they don't talk. And so making an argument is difficult, at least we need like limited knowledge on this. Do you have any thoughts about this?
So the question for those on Zoom was when we think about treating oral health conditions, there are sometimes overlaps with treating other conditions, and yet the people who pay for those 2 treatments, at least in our system in the United States, don't always talk to each other. So what strategies might there be? And it's interesting when we think about, how a business gets started and how a business then goes through the phases of, getting a treatment accepted, getting it paid for. It's really a question of who you bring to the table. And, even on the public payer side, there's not just one system that takes care of it all. And so a lot is who do you bring to the table and what type of influence and network do you have? And can you make an argument that when we think about the overall costs, and in cost effectiveness, we often talk about the so-called societal perspective, which in theory is everybody's costs and everybody's benefits. And whenever I'm teaching about this, I say, great, it's wonderful if at some theoretical societal perspective, it works out. But at the end of the day, it's got to work for the patient, it's got to work for the provider, and it's got to work for the payers. And that's why you need some type of hypothetical meeting where everybody really does sit together and say, okay, is this a win-win-win-win-win? And if it's not, then is there some way of tinkering with the incentives, some way of compensating, some way of sharing, increasingly within just the medical insurance, between the insurer and the provider, there's risk sharing. And so one big question would be like, if you had a sort of a Kaiser Permanente on steroids, it wasn't just about general medical care, it could also include oral and dental and vision. Can you then make the argument in that type of organization? And could we, if we think back to the 1990s, for those of us who were teaching then, and the Clinton Health Plan and the ideas about accountable care organizations, that there was some appeal to that because you could have a very big set of costs and all of the incentives tended to point in the same direction in ways that when you've got different providers and different payers and the patient and the employer who's paying for the insurance that the patient has, it doesn't all go in the same direction. Has anybody mastered doing that? Not to the best of my knowledge, but that's the theory, that you would need to create some type of matrix and show everybody we all win on this one. Or if not, how are you going to make it so that it is somehow tinkered to get it worth their incentives? Thank you. You have time for one more question, Sujay? Or okay, one last question.
Question for Dr. Frick. Is there a individual citizen valuation over lifetime leveraged against GDP? And I'll let you answer to the US.
So it's interesting. So historically, when they looked at the value of a so-called statistical life, and I would like to remind people, when we talk about the value of statistical life, I'll go back to the speed limit example I gave earlier. Okay, there are some of us in the room who can remember when you couldn't drive faster than 55 legally on any highway in the United States. So they changed the rules. And when they changed the rules, they thought to themselves, all right, what is it worth for people to get places faster? That's a positive. How many more accidents are we going to have, and how much more severe are they going to be because people are driving faster? That's a negative. You got to put a dollar value on both of those. Every life lost, we apply a value of a statistical life. What's fascinating is historically, when we looked at the value of a statistical life, it was about $10 million, and it was about $10 million across gender, about $10 million across age. And so any other time we would calibrate these things. Interestingly enough, historically, we didn't really need to calibrate it. So again, in the US, about $10 million per life saved, and then for each percentage of a life saved, you would give that. And it's interesting that to the best of my knowledge, that hasn't changed very much. And that number's actually been around for quite some time. Great question. Thank you.
Thank you. Thank you. This was much needed. As you know, whether it's private practice or, director of an FQHC in Alaska, we do not get a lot of economics education in our four-year dental curriculum. I don't think we get it in a lot of our MPH programs. We don't get it in our DPH programs. So this is highly valuable. So thank you both for being here. I see someone is back. I have something that I want to hand out. I'm going to just stop sharing this and minimize this. Oh, there's a lot of stuff on this desktop. Nope, not that one. Maybe this one. Anyway. So we're going to go into some breakout sessions, but before we do that, we'll go over some rules and such. Let's see if that works. Great. But before we do that, if I could have Dr. Raskin back to the podium, please. I looked for you and then I had a little bit of a cardiac event, like, oh no, she left early.
Do you know where I was?
For the young one?
Eleanor and I were taking a walk.
Oh, fantastic.
At every meeting, we were co-inspiring.
Yeah, good. You just make space for this.
Yes, of course.
Yeah. Just a little moment.
Thank you for your patience.
Yeah. No, yeah. It's all good. All good. And if I could have Professor Frick to the stage. A little extra bark on the top. Bark for your bike. Thank you. And Dr. Freed, last but not least. Thanks, boss.
Thank
Gotta
you.
read it out.
Thank you.
So I hope you all agree that was quite an eclectic group of speakers. These were kind of curated as far as my dream education as far as a master's in public health. So the workshop groups, as you can see, we've got a couple of different topics: workforce development, interprofessional collaboration, innovation and tech, policy and advocacy, global oral health equity, humanitarian crises. So the objective, you can see, is to review. I said remove. I need more coffee or less coffee, I'm not sure. To review memorable quotes from the conference, to summarize the key lessons that we've learned, whether it's you or whether you think that somebody should have learned, propose next steps for collaboration, and ultimately draft a summary document, ideally to a peer-reviewed journal. The structure, so we'll go over this as time goes on. So each group will have about 45 minutes to complete the following tasks. You will assign a note taker or note takers, and we want your opinions and ideas, what happened and what excited you. And we'll put these up as we go through. So the icebreaker, because you will have maybe, I don't know, maybe a couple MPH students and maybe some PhD candidates, and then you might have the Dean of Research at the table. It's like, so this is a fantastic mentoring opportunity or a lifting up opportunity, or, you know, you have to be patient with, you know, a student mind, which you clearly demonstrated yesterday. So I'm not worried. I'm just, yeah. So as you can read, why are you here? Did the speakers motivate you, or are you now depressed about global health? Step one, approximately 5 minutes, and we'll have someone doing a buzzer. Yeah. Reflect on key statements from speakers, panelists, or attendees that resonated within your group. Yeah, I'll just go through this and then summarize key lessons, discuss major takeaways, blah, blah, blah. Propose new steps for collaboration. This is really the key. Identify opportunities for continued collaboration among attendees, discuss potential projects, post-conference stuff, then draft, outline key points for summary document. You've already assigned a note taker. Identify one representative to present your group's findings. Report back. So each group will have 2 minutes. So we'll change that. 2 minutes to present their findings. And a facilitator will compile all findings into a structured summary, and I will put my email up there so you can send whatever way it's on your phone or laptop, and then post-conference and blah, blah, blah. So those are the break prep. So these are the groups. So Dr. Elham, are you leaving? So if we could have, say, workforce development, Katie Battani's not here, is she here? No. But Carrie Kunzelman and Richard Rodriguez, you'll be leading workforce development. Do you have a table that you already have?
I would say here.
Fantastic. So if you're interested in workforce development, you're going to be right up front with Carrie Kunzelman and Richard Rodriguez, wherever he went. Next is interprofessional collaboration with Dr. Vestere and Dr. Denny, which is right here, right up front. And I will clear off my mess that I made. Health, innovation, and technology. That will be with Dr. Ane and Dr. Jessica, which is right behind. Just give a wave, Jess. Yes, everybody knows Jess. Policy and advocacy. This will be with Dr. Patel. Dr. Patel, raise your hand. I don't see Heather Taylor, Dr. Taylor, and I don't see Dr. Hughes. Global oral health equity. This is with, yes, Ms. Cummings, Ms. Carrier, and Ms. Bennett. Just, yeah, give a big wave. Bigger, bigger, bigger. Strong one. And then humanitarian crises with Doctors Raskin, Khatib, and Zahir. Right up front and center. So you can utilize the Padlet to document and review things. Does anyone need that scan code? But I will go back. So we'll do approximately 3 minutes or so for an icebreaker of what motivated you to come to this conference. Why are you here? Did the speakers motivate you? If you just have a table of speakers, this could be a problem. Or are you now depressed?
Nobody's depressed.
Nobody's depressed.
Okay, I'll take my miss. Okay. Okay, 3 minutes. I'm gonna start the timer now.
You don't really get.
Yeah, okay, we're good.
Yeah, since I go for it. Use the pattern.
Yeah.
Yeah.
What are you gonna do? This question? And then you can say what those
Sorry, we started. Right, how important and how and I saw that. Yeah, that's why, you know, I need to make some hour. Great. My name is AJ, I'm twisting my arm, and my body and battery, it is not something that we had, so I love like, the order, next thing, I learned what. In terms of spending
One more minute. Just an icebreaker. Hope you break all the ice.
But in general, like all the writers on the
All right. Sujay, can I go? Time for icebreakers up. Hope all the ice is broken. Only have water. I want you to now review some memorable quotes, reflect on key statements from speakers, panelists, or attendees that resonated with your group. So if you're in the innovation group, we want something that resonated with the innovation group. If you're equity, something with equity. And then also, one thing that we forgot is choose your person that's going to come up and share the thoughts at this stage. And then we have 5 minutes to do this. And your timer starts now.
Yeah, we can encourage them to, yeah, that would be great.
And people on Zoom can please add their thoughts on the Padlet. Please add people on Zoom on Padlet. And then stay on Zoom to listen to our people that report back from this room. Yeah. If Padlet is not accessible to someone, please Zoom folks can also add it in the chat.
Right now, technically, no, I'm not. Yesterday, one of the speakers, there was like, just right energy. Person out and out for like the rest of the body. So it's showing how like they're kind of look at teeth and healthcare professionals and want teeth.
I hope you're writing down those two quotes. And no one's coming up on stage yet, so wait for it.
I'm gonna talk about the single state I went to that. Estamos Yeah. Oh my God. Yeah. Yeah. Good.
Not a strong.
Okay, 20 seconds. I don't intend to rush you because the next step will give you more time. And as my son has taught me to say, trust the process, just trust. It will look great at the end. So moving on to our next step. This is 15 minutes.
Wow.
We want you to have 5 key lessons learned, 5 major takeaways. Knowledge gained could be 1 to unlimited. Innovative ideas could be as many as you like, and at least 3 best practices shared. 15 minutes? That's a lot of time. I'm not going to rush you. And then make sure that the person that is going to come up, your rapporteur, good French, Suja?
Yeah, yeah.
Okay. Have the notes. All right, 15 minutes starting now.
Thank you.
Thank you for allowing us. It will look great at the end.
Like when you actually think about dentistry and in particular, every day. They don't come understand. They'll go like they don't like it's to be part of the need for the competition. And so when we're talking about collaboration, okay, here, and then how do we like disperse that to the rest of the dental field? In there, but nice, for example, like I literally like I've talked to dentists that are like, I don't they're probably none of it made for that. I agree. It's like how do we get to that? Yeah, that is probably
I think that's such a higher than a lot of other skills here. Robust timer system. And then folks with parallel like I help excited and really bad and it's not that good. But it's also
Yeah, finally kind of prettying up my slide.
yeah, I wonder about that chair and also.
We're gonna do the speed round, right? Yeah.
So we have one more. I'm gonna cut time on that.
Yeah.
Come on.
I know the goals are much like the Instagram. I don't know. This is a policy intervention. So far, we've done that. But what about like, doesn't everybody talk about what else is education? Everybody is talking about next year. Sharing that lessons. Not reinventing. I don't know.
What are ways to really it's time for us to look at new. Exactly. Right. Yeah. It was like, I mean, does it even matter what? What is that there? Right, like the quality gaps. Yeah. I mean, it would be good. Medicated something. They'll do a restaurant. And there's like a lot of that actually do like everything. Yeah. There's some states that go completely but basically I took all my breaks. Yeah, so not only are I just a lot of states are understand Yeah. They're really dedicated or it's like and that's all solutions that come from the that's another place. They may not have access. They may not actually on the law because under they have yeah. I'm just saying that it's like not top of my head. Exciting understanding. Background with you know that background. Practices sustainable. Maybe not
Three more minutes.
I think it's one thing on presidents and Congress keep saying. But we also know the conversational. They're claiming, well, that's not clean. We're gonna streamline things. They end up telling the story of there's not $880 million in that spring. Yeah, we're not talking about. They're like they're lying that we use when they're telling they're not going to they're going to keep saying that to you right up until they get into the mercury. And then you say, hey, you're not like they're and I think are not afraid of that they can do I'm not saying that they're like, no, about then you're like I really think
All right, the second last step. Propose new steps for collaboration. Identify some opportunities for you as attendees to continue these collaborations. And with the whole post-conference momentum, how can we build on those collaborative opportunities as a large group?
What's up?
What's up, group? We already have recommendations. All right, we have, I'm gonna cut down on time on this. 8 minutes to do this. 8 minutes. Respecting everybody's Friday happy hour.
Yeah, we co-chair the National Partnership Dental Therapy. But I'm gonna have it on my card. They should be meeting now, but I was like, you're in. And that's something. I feel like I get these emails. Yeah. I mean, yeah, we're kind of all like my mom on a team like six, so there's a lot of No, we did buy one because many years our organizer are not funds so they started they expanded we work with organizations across the society like Bloomberg American.
We're not gonna, yeah, 12 minutes, yeah.
So if we end this at 3,
right?
You have 3.
Yeah.
And then I can pull one and
Yeah, now 8 minutes, we get. We have 3, so I'll go 3. 1, 2, 3.
So it's very
so that's all together. Oh, they'll be done.
No, they will report.
oh yeah.
Including my stuff. Okay, but I started.
Then and then so we'll be done by 3:30.
Yeah.
Yeah, that'll be perfect.
Okay.
Okay, and then our current couple, that's like totally right. I think we. That maybe what is up?
We mentioned that. Yeah. That's like come on, you just go on. Okay, that's good. Very fast. Say like Yes. Yeah, they always and this for 16 Yeah.
What about you?
So it's like you're
Okay, you now have 5 minutes to finish your write-up. And then you will have 3 minutes to present your Dragon's Den pitch for your table. 5 minutes to write it up all, and then 3 minutes for that chosen person to come up and talk.
Yeah, so we simply like to go online where it's like, share here and my birthday share. Yeah, I try to
One minute to wrap up.
It's perfect, thank you. Thank you.
How are we doing? Are you ready? Yeah, okay, that is time. Okay. Global health group, okay, we have group one. Group one is workforce development. Please send your representative. Your rapporteur.
Yeah. You have 3 minutes. I have 3 pages.
We're doing Dr. Ice Straight style timer.
Oh my gosh, well, luckily I already talk really fast. Okay. So hi, okay, gonna cut to the chase. So for the first one, we stated not just a silo. And then hearing about Alaska / personal stories looking to Alaska at systems that are already in place and already work. And then moving on to the quotes, public health is prevention. And then another one, when things are on fire, we don't wonder what color do we want the kitchen curtains to be, we get out. And then we were tying that into workforce development, referencing dental therapists are more likely to utilize minimally invasive care, medical management carries MID, than dentists, just historically, because dentists have like always done things in the same way. And then moving on, my notes are wild. I can't. Moving on for the notes. Okay, best practices. Is that the next one that we're on? Oh, key lessons and major takeaways. Put the mouth back in the body. community first, remembering the stakeholders and who should be at the table. Again, best practices, building capacity to empower the community, use available resources, relying on available resources, why reinvent the wheel, meet people where they are, looking at AI as a tool to improve patient experience and improve quality care, decolonizing research, acknowledge and deconstruct personal biases, looking at how we can do things differently, larger systems, how do we work in them and change them, and then planetary health, environmental health, right? Okay, and human health and environmental health, provide, and then moving on to the next one, cross trainings, looking at, all these things that we're talking about, how can we make it happen? How can we implement what we're trying to change and what we're trying to do? And that would be cross trainings, having oral healthcare providers integrated into medical settings, and then looking at the education. So education, for example, dentists in dental school receive education on the entire body, whereas medical providers do not receive like that education and training on like oral health to even provide screening for their patients. And then, so like the action for that would be like really at the top, looking at the educators, looking at schools, like from a broader picture, I think is what I'm trying to say. And then, let's see. And then the last one, again, is assessing stakeholders, which I think collectively we had kind of talked about, community educators, providers. Thank you.
We're gonna change everyone's name and email address in the table. Yeah.
Next time, please.
Okay, group 2 is interprofessional collaboration. Fantastic. Come on down.
Thank you. So some of our key takeaways was, firstly, dentists need to be more proactive in engaging non-dental professionals as a first step in breaking the siloed approach to care. A good way to optimally use the limited resources will be to engage more non-dental professionals. A new way of training dental and non-dental professionals may be needed for long-term and sustainable integration of oral health and overall health. Dental professionals can attend non-dental professional meetings to stimulate interest in oral health. Then some of the key takeaways is that the current model of oral health care delivery is not working. We need to do things differently. The idea of humanitarian clinician and research was quite interesting. This is the idea of helping people. Yes, so those are some of our summaries. Thank you.
Would you like to add something?
I think appropriate.
Thank you.
Innovation and technology.
Okay.
You want their extra time?
Sure.
Staying nice. All right. Setting an alarm for myself so I make sure I'm on time. 4 minutes, my speech begins now. So imagine a truck expertly engineered, but its journey is held back when different parts don't communicate effectively. This is exactly the challenge we face in healthcare, or especially in dentistry, where the different sections don't cooperate or often operate in isolation. Our key takeaway is clear. To move the field forward, we need to break down these silos and build better connections, as echoed within the past 2 days. First, collaboration is paramount. Dentistry and public health need to work together. But right now, many dentists focus only on technical skills. Education isn't addressing the need for collaboration. What we need is a system that encourages professionals, dentists, public health professionals, technologists, to share ideas and solutions. This would allow for better patient outcomes and a more holistic approach to care. The second takeaway is integration. Dental and medical records are often disconnected, leading to gaps in patient history. This fragmentation impacts treatment. A fully integrated systems, like Epic, as brought by Dr. Ine, could link these records seamlessly, giving providers the complete picture of a patient's health. But it's not just about technology, it's about creating a healthcare ecosystem where everyone has access to the same information, leading to better and more informed care. Technology plays a critical role here, as my group discusses. Think about AI. AI can be a game changer for patient communication, as brought up by Dr. Klaba. Imagine color-coded radiographs that visually show how what's going on inside the mouth. This bridges the gap between patient and provider communication. But we must be clear that AI is not a replacement for clinicians, but a tool to enhance their work. We've seen that AI can hallucinate, so it must always be in collaboration with human expertise. As Dr. Ine pointed out, we need to view the mouth as part of the whole body, not compartmentalized. Technology can bridge that gap, but how we perceive and integrate it is key to moving forward. If we're not the ones spreading the message, then who will be? Fourthly and finally, we need to focus on patient needs. A key challenge we discussed is the lack of seamless access to care, as mentioned before. Patients often have to repeat their medical history every time they see a new provider, and that's inefficient. This can only happen if we develop systems that share information across providers and regions. It's about creating community for patients so they don't have to repeat their story every time they seek care. Post-conference, it's crucial that we don't let the momentum fade. We must create dedicated spaces, platforms where professionals across disciplines can continue exchanging research, share best practices, and brainstorm innovative solutions. A centralized Slack channel or public forums could serve as the meeting point for these ongoing conversations, bringing together experts in dentistry, public health, and technology. Solidarity Dental already provides valuable channels for collaboration, and expanding these resources will ensure that the progress made here doesn't stop. By embracing the technology, breaking down silos, and making healthcare systems more cohesive, we can and will create a future where oral health is fully integrated into overall healthcare. This would not have been possible without Solidarity Dental, Dr. Ine, Dr. Klaba, Dr. Ash, and Monica in our table. Thank you for your ability and mind and for your
So now policy and advocacy, you've got some shoes to fill. Dr. Sana. Dr. Sana is up for the task.
Hi everyone. So from the policy and advocacy, I will start with what motivated me especially to come to the symposium was a desire to build a community and find a space in public health where I could talk about oral health. You know, and that was something I felt missing. It's been incredibly inspiring to find this community and see the space come to life. In our group, we reflected how isolating this work can be, especially for those who are advocating Medicaid dental benefits or working remotely. But being physically in this community reminded us that we are not alone in this fight. A quote that really resonated with our group was from Mary Backley from MDAC, who reminded us, in policy, it's important to stay optimistic because real progress often comes in incremental change. The message grounded us, especially in a moment where, as Dr. Fleming said, the house is on fire and other dental benefits are being stripped away state after state. In this climate, even protecting what we have can be a form of progress. We also talked about practical solutions like expanding the use of dental therapists, focusing on bipartisan state-level policies that still have traction. Realize how much stronger our advocacy could be if we prepared solid effectiveness data with real lived experiences. Because as someone in the group said, policymakers might appreciate data, but what actually moves people are stories. Stories from patients, providers, and community members. This is what looks like when access is denied. This is the cost of waiting too long. In the end, we all agreed. The symposium didn't just spotlight the problems. It energizes with solutions, community, and a sense of purpose. And while many of us wish this was way earlier in our programs, especially as an MPS student who's going to graduate this May, but we're walking away with ideas we're eager to act on, and that feeling that oral health finally has a seat on the table. Thank you.
Wow, everyone's doing very well. All right, we're at, I believe, global oral health equity. Yeah, global oral health equity. We must have had a global. Yeah. Fantastic.
Pretty smarter than everybody does my now.
Okay, so a few quotes that stood out to us. Your heart is a muscle the size of your fist. We cannot have a healthy people on a sick planet. And oral health is an overlooked priority in global health agendas. We talked a lot about reciprocal learning, so not telling patients what they need, but asking them what they need, listening to the needs of communities, and emphasizing preventive care, so less focus on treating and more focus on prevention. We talked a lot about integration of oral health into primary health care, so making sure that medicine and oral health are combined and that efforts come together as much as possible. Creating more platforms for new voices, so thinking about the people that are invited to the table and encouraging early career professionals to be included there. To support patient safety. Let's see what else. And our key action takeaways, so promoting collaboration between advocates, researchers, media, health informatics, encouraging interprofessional collaboration. Another thing we talked about was restructuring the pay-for-service model to be more equitable and to encourage dental professionals to care for those who need it most. Yeah, I think that pretty much sums it up. Thank you.
Quick and efficient, and that leaves us with humanitarian crises.
Okay, I just want to, is there a
You did, yeah. It's too low for you. You have it to your school? Yeah. Oh, you're not impressed? Oh, I knew we. Yeah, it's the highest.
Okay, first off, I just wanted to thank Solidarity Dental, Sujay, Priyanka for inviting me, and thank everyone else for coming in and for speaking. It was a very good experience for me as a student, so just a round of applause for everyone. It's been always too much time to quickly jump into the topic. We discussed humanitarian crisis and basically being able to improve international efforts and collaborations to solve different global health disparities and sort of bridge the gap and improve access. So I just wanted to start out with a couple of quotes. So first one is, dental care is healthcare. Another one is, it's not perfect, but it's progress. One that I think it was Sujay that said, no volunteers, no helicopter programs. And my personal favorite is the importance of touching hundreds of lives is greater than taking out a couple of teeth. Now, to move into the key lessons, takeaways, and the best practices to be able to improve health access on an international level. So the best thing to do would be to integrate oral health into primary care, whether it be emergency or not, and to basically improve international collaborations between nations and health leaders on various levels, and to be able to build strong relationships and overcome barriers to be able to improve accessibility. Now, oral health is also not the responsibility of just dentists, as there are many other professionals involved, such as dental hygienists, dental therapists, policymakers, and professors, and other governmental workers. And it's very important to basically engage stakeholders and community engagement, and to be able to focus on the oral health impact, like the oral health impact and the health accessibility impact, rather than the business aspect and just the money side of it. And by doing this, we can add incentives and motivate dental professionals and other workers to be able to improve accessibility and access to care. Now, some steps we can take to improve collaboration would be to focus on improving care and supporting the community as a whole rather than individuals. And the best thing we can do is to look at it as a bigger picture rather than going from patient to patient, and making sure that entire communities are able to receive care. And we should apply the integration and consultation and take social responsibility and be able to step up to create new solutions to solve different problems and tackle disparities in oral health. It's very important that we build strong connections with industry partners and organizations that can improve funding for public oral health systems and work between different careers in oral health and make sure that everyone is involved to help make a difference. And by taking these steps, we can improve global oral health access for all. Thank you.
That's amazing. I'm assuming, wow, this, did we got all the groups? I think we did, right?
Yeah.
Okay, let me just,
Yeah. Everybody, can you please share your reports with Sana? You can email them to her, or if you have written it on a paper, give her the paper.
yeah, or take if it's on paper, take a scan of it. Or you can make when you get back home, make a Word document. I'll put my email up as well. If you could make sure that you, send it to both of us. Just to make sure that we don't lose anything. And make sure you put all your names and email addresses as far as everyone that's on there. Let's see, where's my poster? That was fantastic. And thank you for having everybody participate and speak. I do want to thank all of our amazing speakers, our moderators, our early career presenters. This wouldn't have been possible without some very key people. Obviously, massive thanks to the Center for Global Health. Thank you, Megan Harrison, who is our on the ground. Your patience and organization and that lunch yesterday, that was Ebikan? Ekiben. I got the dyslexia there, Ekiben. The story behind that, we need to find the article about that, about them somebody needed something because of a health scare and they drove from Baltimore up to Vermont to deliver the food. I had heard about this and I didn't realize it, I didn't make the connection. But that was, I will have to say, if we can do this again, I'm going to request them again. And not just the food, but everything from the Zoom and your patience with, switching schedules and speakers and everything. And thank you for lifting up and having us connect and stay connected with the university. Massive thanks to Solidarity Dental. We'll go through a couple of folks with them. I do have to recognize and thank CareQuest Institute for Oral Health and Vifor Pharma. They are our main financial grant makers who have come through in supporting this idea and dream for the development of this conference and taking it really to the next level compared to the 2023 event, which was largely self-funded. And that's just not a practical way to do things. We had some support from the university, as I mentioned, Dr. Wu and Dr. Jill Marsteller from Cheshire. And certainly two of the student groups, one of them funding never came through, but that's I think a student assembly thing. Also want to recognize and thank the latest version of the oral health student group, the Johns Hopkins Oral Health Society, and particularly Dr. Sana Kafaria. And so your support you helped fund our lunch today, which again is fantastic. Sandwiches are always most welcome. We have incredible support from several early career folks who have helped in various tasks and asks from McMaster University, from Johns Hopkins, from the University of Cincinnati, from Dalhousie, the list goes on and on. So again, thank you all. And I have to thank the original crew from 2023. I'm happy to say that 3 of them were here this time. So I mentioned Dr. Fleming, who unfortunately on that particular day had to zoom in because of a conflict, and it was. But you can see from left to right that's Eugenio Beltran, who is one of our band speakers. I don't know if he'd appreciate me calling him out like that. I mean, not to he didn't ban himself, but I think I don't know if it's safe to say. And as I mentioned, Dr. Heywan Lee, who was one of our surprise guests and was involved with our prequel last week. Dr. Seymour, who was also involved with our fireside chat prequel last week. Professor Frick, you can recognize Dr. G. That's me with a little bit more COVID hair. And the other co-founder of Solidarity is Greg Krupa there at the end. So two involved in the prequel. One of the original 8 could not be here because he's in Turkey. That's our Vice Dean, Josh Sharfstein. He wanted to be here, but yeah. And then one of our speakers is in Nigeria, Dr. Ife Adetula. And yeah, as mentioned, one was scheduled, but not allowed to even come. So, there's the USA for you right now in 2025. Thank you to our surprise guest, Peter Mossy from University of Dundee in Scotland, Dr. Heywan Lee from Seoul National University, Eric Sung, my attending from UCLA. So yeah, that was a while ago too. And Dr. Christina Wanyonyi K from Cambridge University, and Dr. Eka Perez Franco from Panama. Massive thanks to our dragons. Formatting went funny, but Dr. Eistrate, Dr. Kadri, Dr. Mutis, who are here, and the other 3 quite well who spoke earlier today. Our early career presenters, massive thanks to Alexa Bennett, Ife Cummins, Catherine Carrier, Thandiwe Mkandawire, Vincenza Segura, Marina Nevison, Lakshmi Murthy, Amisha Parmar. And again, I just have to reinforce this idea of the fireside chat to kind of flip things around. It was an interesting start. We had some very established players, I think some rock stars in the field. And I think what the brilliance of this panel was the diversity. I mentioned the Breakfast Club, and we have a lot of that throughout these 2 days as far as the diversity. We have this associate dean who spoke about the environment. We had some ER data. We had a nephrologist, and how often do we get to hear from nephrology? We have a hygienist who's pursuing a doctorate here at the School of Public Health. We get to go to Australia to hear about antibiotic stewardship. We get a bit of AI. I never heard of health informatics before. I'm still not sure I understand it, but I know I need to know more about it. But we get to hear a little bit from the Cochrane Institute at UPenn, and a dental director. Again, some of these folks were like, "This is global. Why are you asking me here?" Again, with international projects starting locally, we have to, respect and recognize Maryland, and without having a dental school, I think any future partnership has to involve the University of Maryland School of Dentistry and the University of Maryland School of Public Health. There's some great resources and some great help as far as if we want to kind of continue on in this vein. And the workforce thing, that was a fantastic panel. That was one of the ones that I was most excited about. And I think you guys, everybody, I can't pick one dud in the group. Everybody did fantastic. I had a lot of hopes on this one, and you guys delivered. So I thank you for that. And our Dragon's Den, which we mentioned, again, the early career presentations were fantastic. It's a continuation of a reverse mentoring model that we tried out with a couple of other groups with a UN side event. It's an unofficial UN side event. And we'll see if we can kind of continue that. But I think this is something that Solidarity wants to continue. And we'd be happy to have Hopkins jump in on that. Today was just absolutely fantastic. Usually day two is a bit of a dud. I think day two was, no offense to the day oneers, but day two might have been even better. It's a shame a lot of people ended up leaving. Hitting it right out of the park, right from the get-go in the morning. So I think that really creates a new standard for conferences that, you know, if you want people to show, make sure you don't sleep in on day two. So thank you from the Humanitarian Crises panel, and thank you for the lessons for the Global North. I think that it was just a 1-2 punch that was fantastic. And patient safety, clearly this is something that we are in desperate need of, and same with health economics. Probably one of the biggest failures that we have in a 4-year dental curriculum. So if you enjoyed this conference, please send a letter, an email, phone call, whatever, carrier pigeon to the dean's office at the Johns Hopkins University School of Public Health. I will make sure, if you're interested, you email me. I'll make sure you get the dean's names and addresses. If you want phone numbers, I'll dig them up for you. If you know them, then that's great. That's even better. Tell leadership about the importance of oral public health courses and building a dedicated center for oral health here. I know it's a bit of a pipe dream, especially in 2025, when all universities are saying we have no funding for anything. This is a long-term thing. This might not be something I can do, but perhaps, I don't know, where's Richard Rodriguez? He's young. See him. Within the silo of dentistry, there are specialty silos. And fields like dental anesthesiology, oral medicine, orofacial pain, sleep disorders, those are completely siloed in dental public health. We really don't interact with them. So those silos within the silo of dentistry, we need to draw in. And that's part of day 3 of the conference, which again, funding does not allow it for 2025. If you have constructive feedback, your face-to-face comments were really wonderfully positive. I wonder what you'd say to me behind my back. So, you know, I'm not going to be offended. I've been around, clearly. I'm a lifelong learner. I do want to see how we can improve this further. So certainly your constructive feedback is more than welcome, but your harsh criticism with F-bombs, I can handle that too. So I'm not afraid of any kind of language, but I need your feedback if we want to improve this. If you enjoyed a particular talk or session, please write a positive recommendation. I don't know, on speakers Yelp. I don't know if there's a Yelp guide for speakers, but maybe on LinkedIn, you can do a recommendation on LinkedIn. This is potentially one of the best ways you can endorse an idea or a speaker, a concept, a panel discussion, especially for those speakers who aren't on the circuit. Most of the people that we have here are not regulars. You know, you don't see a lot of these folks at NOHC or APHA. So you could really make them into getting on the circuit with your endorsement. If you want to see and participate in this conference for 2026, then again, need your help with introductions, getting industry to show up to scheduled Zoom meetings, maybe. I mentioned toothpaste manufacturers, but anyone with money, I have no shame. Supporters, future speakers, funders, the planning for 2026 actually starts now. Because everyone says, oh, we make those funding decisions a year in advance. So if you want 2026 to happen, these things are expensive. I was surprised how stupid expensive. And so again, I'm grateful for the Center for Global Health for their help with taking the ease off of certain costs that they could. The university feels their hands are tied. I think all of them do. They don't understand oral health, as you all know. Which department to go in as far as oral health at a school of public health? They have no idea. I have no idea either. I think maybe, I realize the Center for Global Health is not a department, but happy to tag on and really focus in on that.
As we discussed, there's way more to oral health than clean, straight, and white teeth. Oral health impacts us all from eating, communicating, expressing emotion, intimacy, all these things that conservative 4-year dental curriculums, we just don't have the bandwidth to discuss. So this is Ekiban. I grabbed this off the website. I just had to put this on there. Everybody in this room and all of you still there on Zoom, we need to do a better job educating and inspiring allied health and public health about oral health impacts across the lifespan, not just pediatric caries. We do not collaborate with the center, or did not collaborate with the Center for Gun Violence. We didn't collaborate with the Center for Indigenous Health here. There are there are 90+ centers at Hopkins, and every imaginable crazy public health thing, every body part, but it's not the mouth. And it was wonderful that the Department of Otolaryngology sent their representative, but I want more. It's not enough. So we met, we gathered, we spoke about some serious topics. We talked about death, we talked about policy, we talked about advocacy, race. I think we talked about diversity. There were maybe some of us, were being careful with certain words. Environmental health and mercury, water health, challenges to the state of the nation, the unhoused, the incarcerated, cultural stereotypes, migrants, refugees. This is not the typical 4-year dental curriculum. Mm-hmm. We know, and again, thanks to the Bangkok Declaration, oral health is health. With the funding challenges that schools of dental medicine have, are you convinced that we can have these conversations at a dental school? I'd be happy to hear if you think that's possible. I think you know my answer. I'm a bit biased. I don't think we can. We need collaboration with public health institutions and organizations. And I think we need collaboration with the #1 public health school in the country. So if you enjoyed this symposium, please help me to build those collaborations across disciplines. And if you have partners and co-conspirators, please introduce me. Happy to chat, particularly with funders. Definitely with funders, because this has been definitely an ongoing challenge. So that's my email. Definitely for the working groups, please include me on your documentation. And I think you have Sina's email. No, well, Sina will make sure that you get hers, or I will definitely forward. Sina's working on a practicum with us, so I will make sure that she gets it as well. The final ask. So document concerns, questions, suggestions, recommendations on the bulletin board, or you can send them, privately to me. If you can send it anonymously on the bulletin board too, but if you don't want it public, then send it to Pri. If you don't want me to know, send it to Dr. G. She won't tell me who you are. And if you told me, if you feel like you hated it, send it to Pri. You can tell me. Definitely lifelong learner. Yeah, I need to, if we can improve it. Any funders in the house? If you're a funder, can we talk, please? Or if you're friendly with toothpaste people that make toothpaste, maybe you should talk to them. I don't know what I did to them to piss them off, but they won't literally show up to Zoom chats that they schedule. So I personally think they should be embarrassed that a pharmaceutical company funded half of this. The other funder was CareQuest. So why a seed named toothpaste wouldn't? I'm not sure, and it probably shouldn't say this on Zoom, but that probably isn't going to help getting them to fund. But so somebody else is going to have to act. Pri, you're going to have to talk to the funder. So the toothpaste dentifrice manufacturer. Yeah, I just find that hard to believe that they're not interested. So, and again, so finally, a truly massive thank you to Megan and the Center for Global Health. Thank you to Solidarity Dental, our executive director, Dr. Klebeck, our co-founder, Dr. G, the original G, Dr. And our social medias are Dr. Karam Manresa Kumarin. Thank you. Our in-house informatics guy, Dr. Ane. Thank you. And once again, I have to thank CareQuest Institute for oral health and Vifor Pharmaceuticals. See, I'm really thankful. If you give money, I'll thank you. I'll still let you. And yeah, our family volunteers, Master Soham, Miss Joshi, for the photography. Thank you, to Student Assembly, Johns Hopkins Oral Health Society, very much appreciate the help. And on behalf of the Johns Hopkins University Center for Global Health and Solidarity Dental Foundation, I so very thank you for being here. End of day 2. Yeah, lovely to have you all. And
Sujit, we need a day 2 picture.
day 2 picture.
That
Yeah.
lasted this long.
Yeah, so absolutely. Thank you for lasting the whole day 2. I know day 2 at conference. You all made it, and well done. Safe travels. Thank you all on Zoom. Have a good evening, morning, afternoon. Oh, yeah, I will make sure. Yeah. Absolutely. I'm just trying Thank you.
Right on the shoulder.
Thank you for running too.
I know you're talking about it.
Yeah.
Chris, Sujit, you need to.
Plenty of pictures.
I'm really
Yeah, people are like, oh, there's a man sitting on a chair.
Oh, wow. There's space on the other side.
Or matches day. I still my son, the doctor.
Part of that.
Oh, yeah.
Oh, it's gonna be too close with that.
It's a professional camera.
Oh.
No.
Yes, of course.
Megan is not here. She's hiding.
You can't see me, I can't see you.
Hey guys, can you hear me? Can you hear this? Nice meeting you. Good luck with you for everything. And you need information.
Thanks to everyone on Zoom.
To everyone that's still in this room here at Hopkins, can you please look around and see if you find a gold earring? I'm missing one. It's a loop. Please just look around your chairs and tables. Thank you.
Ladies and gentlemen, we have a missing earring. So, what does it look like, Dr. Patel? It's a gold hoop. Dr. Patel. Thank you to Zoomers. See, I'm trying to figure out how to. Yeah, maybe has the master thing. No, she started the recording somewhere else. You know, it's time for us. You know where it is.
That's why it's not available. But oh my gosh, yeah, some things that they say. The fact that I signed up for your job because I work for the Dental Training Foundation. So yeah, like.
That's amazing. Even better. Yeah, well, thank you. I would love to.
Basically, like, you know, they're the philanthropic, you know, running through their things and
Right. Yeah. Absolutely. Thank you. Absolutely. Thank you for coming and yeah. Well, maybe we should chat and I'll email you like in a week or so and just maybe arrange a Zoom chat or something. Yeah. So, okay, I will do that. And if you don't hear from me, feel free to email me. I don't know. I was trying to this. You can tell me the critical stuff in the email.
So you have to get a license. You're in a big city. Because your license is out of state. You can get license. So I'm trying to make sure that I still get about it, and then I finished and then I've worked, I worked for like the drug. Then I know.
I have your business card. If I don't, this is.
Oh, yeah.
Yeah, that's good. Now, I'm gonna give you the downside is, I personally wish I went into medicine. Because. Depending on what you do. I mean, that's. What they would change. And wasn't sure about that.